Hello? Yeah. So it's working now. No, no, I think it's working now. Good afternoon, everyone. Thank you, POSN, for giving me this opportunity. And can I have my slides on? So I was asked to talk on charging and costing. Charging and costing in P-Rothal is very varied because we have a lot of super specialties to cover, right from the strabismus to pediatric cataract to pediatric oculoplasty to ROP. So I just chose strabismus as one part, and then that charging or costing can be applied to others. So I'll be discussing the charging and costing in strabismus surgery per se, and then various aspects of why we should charge and how we should charge. This is my way of thinking. We can have then discussion on. So why we are discussing this charging is that we all want to know that are we actually undercharging? And then there are certain schemes of government which make us think that this is not worth it, especially when we talk about the charges of 46 rupees for synaptophore or 4,000 rupees for a strabismus surgery. Hello? Yeah, because is it on? Yeah. So charging sometimes, if you look at the government prices, so you have to charge one eye surgery or maybe maximum of 7,700 for both eye surgery, which is actually not viable in present scenario. Find out the costing of the strabismus surgery. So this was the एक mic चलाओ कोई सा भी एक चला दो because hand वाला चल रहा है okay. So this was a study which was published in Delhi Journal of Ophthalmology, which was based upon the activity-based charging. Hello.
Check.
So the basic idea of activity-based charging is that activity is calculated, the whole cost of that activity is calculated and divided by the number of people. So there are certain fixed assets like the building cost, the maintenance, the machinery equipment, the manpower, the electricity and the air conditioning, the lines and the laundry services, CSSD and the ETO, and they're all kind of added together and then they are divided by the cost incurred based upon the number of surgeries. So the total cost is divided by the number of surgeries. For the fixed assets, we talk about the depreciated cost and then the rental value of the land or the building which we're talking about. Now here the problem is the denominator. Because if you have a large denominator, say 32,000 or more than 1 lakh, then the cost is going to be really, really low. So this was the idea, this was the table which summarizes each cost about the cost of building, the machine, the electrical, the water, the AC, CSSD, gases, consumables, special surgical consumables which amount to 3.2 rupees, but that doesn't look very viable because here the denominator was 32,000 and the total cost was around 3,544 rupees for each surgery. Now this was another study by AIUS which talked about various surgeries, but there's no surgery here included in the pediatric ophthalm subspecialty. So I just thought maybe we can pick up glaucoma here because it needs almost the similar kind of consumables and a similar kind of time frame for a surgery as we do it for a strabismus or for any other surgery. So the cost here for a small standalone hospital was somewhere around 10,000, but for a large the C here, the third column here, which talks about 1,31,000 surgeries in a year, the cost is 6,000 rupees. So are we okay with this kind of surgery, this kind of costing? I don't think we're all okay. So there's a concept of keystone markup in the retail business. So whenever you have a wholesale price, it is multiplied by, manufacturing cost is multiplied by 2 for a wholesale, and then that is again multiplied by 2 for the retail price. So let us pick up these costs. So we pick up 3,544. So this study was done in 2003. So this is 20 years from now. We add cost of inflation, it becomes 11,000 today. We multiply it by 2 and then again by 2, it becomes 46,993 rupees for a strabismus surgery in the present scenario. Similarly, if based upon the AIUS cost, we multiply it by 4, again it becomes 41,000. So are we charging less or are we charging more? That's the question here. So this looks more or less contemporary, or a little more than contemporary for most of small standalone surgeries, setups. What is not included in these big setups or the government setup is the OPD infrastructure, the maintenance, the manpower, other expenses and costs, and the chair time of the patient, because sometimes you have to explain a lot to a parent or a child before you plan for a surgery. Other perks in the government job which are included are the retirement benefits, the health benefits for the doctors themselves or their dependents, which is again not included in a small standalone practice. The prevalence of low-cost labors, like in terms of trainees, students, fellows, again is not a luxury available to most of the standalone practitioners. Then you have no objection certificates, which are a very important thing for most of the standalone or small setups, and the additional associated cash gratitudes you have to offer to go get those certificates. Then there are obligatory and non-paying patients, which are also there in small setups, which have to be taken care of. So we also should think about the premium we should be charging for our fellowship and training as compared to a comprehensive ophthalmologist, the experience of the surgeon, the mental stress for a challenging case or a challenging patient, the indemnity or the legal risk cover, because this is also important here. The complementary resurgeries or complementary exploration risks sometimes, where we cannot charge the patient again if something happens in a small standalone practice, and surcharge for a high risk or the type of strabismus should also be added. Also, to add adequate compensation for a GA cost, because the anesthetists also charge a lot. So these are the other costs which have to be added beyond what has been postulated by the ABC model or the AIUS model. That's where this surcharge of making the multiple of 4 comes into. Now there are certain centers which charge per muscle. So that's also is not a correct way in my point of view, because once you take a patient into a GA or LA, next muscle is just going to cost you another 15 minutes with no additional cost. So I think that's not a correct way. Also, there is no differentiation made when you're transferring an LR to MR. That's again a single muscle surgery as compared to MR recession. Post-op risks of over and under correction, diplopia are again not counted here, because we're just talking about a single muscle or a 2 muscle surgery. The premium of one's skills is again also missed out here, because whether you are doing a superior oblique or inferior oblique, which is equated to an MR surgery. So imagine somebody is doing a painting work at a ground level work, and somebody is hanging from the floor to paint a building at a very high floor. So there are difference in the risks involved in these kind of jobs. So in our setup, we charge for everything almost. So first and foremost, we charge little more for our pedophthal consult, which is slightly higher than our general consult for the same patient. We also charge for our TNOs, FDTs, PBCTs, synaptophore, forced junction test. We all charge for everything. The reason here is whenever you do charge for small tidbits, the patient feels that something has been done for them, which is extra, which has not been done by a general ophthalmologist, and they understand the value of your specialty. Now, this is a small guide which we charge, which I have done as a division for various types of strabismus surgeries. So the S1 is a cost for pure horizontal muscle surgeries amounting to maximum of 2 muscles. S2 is more than 2 muscles. S3 is for a nystagmus surgery. S4, where we have partially accommodative IDS or inferior oblique overactions. Then you have the next category as superior oblique surgeries, DVDs, resurgeries, and Farden surgeries. Then next you have Browns, thyroids, post-traumatics, post-surgical squints, and then we have complex squints like DRS, third nerve, sixth nerve, NAPS procedures, and modifications. So this is how we split up charges for various types of strabismus based upon the type of strabismus, and then we add up our own premium. Like if you go for a Parks or a Phoenix incision surgery, which we usually do, we charge a little extra. extra cost for a two-stage or adjustable surgery, extra cost for transpositions, extra cost for cyclovertical muscles, and extra cost for GA. Now, why there's so much of split up? The reason is that this table here. So whenever you are in a private practice, you often get these kinds of emails where the insurance companies demand a lot of discounts, and you can see right at the bottom, they are demanding 50 to 100% discount on your teleconsultation. So you have to add up something to make up for this discount, and this is how you can do away with these problems. And it is important that we all know that if the patient is needy, we can always do a discount and we can downgrade a surgery and do whatever you want to do. So in the end, I would just like to say, don't keep the charges too low because it can be suicidal for our own super specialty. Be thoughtful and charge for the self-respect and the long life of the super specialty. Thank you.
Small-sized money.
When I started doing strabismus in Jaipur, horizontal muscle surgery, I was asked to charge 7,000 rupees for a strabismus. So 7,000 was not worth it when the same surgeon was asking for 32,000 rupees for a cataract surgery. So that's how I gradually increased from,
Yeah, I think the most important message is don't underestimate and charge for that skill. That's very important because it may be a small muscle recession for a general ophthalmologist, but that comes with a lot of
whether it took me 10 minutes or whether it took 1.5 hours. But over a period, we have evolved and made it into almost like 5 classes of different things, charging little differently. So our rates are probably in line with whatever you have prescribed for AIOS model, like that. But we don't charge for consultation. Everything is included in the same consultation charge. But of course, it's a little higher than what you're. Yeah, so like I don't I don't charge separately for PVCT or FGT. That's all part of the.
no, that's because we realized that the patient only identifies you as a different from a general
But
ophthalmologist
yes.
when you charge them, you are always free to discount. You
Yeah,
can
but
always say,
perspectives can be different
So-
because we are working in very two different
Yeah.
environments. So
so in my practice, what I tell my receptionist is that you charge, then I will ask for a refund, right? So the patient understands that this was supposed to be charged, but not charged. So that's a different perspective now the patient carries.
Yeah. Many times also people say that the insurance people ask for rectus 1, rectus 2 or rectus 3. This is the requirement from their side. But again, as Dr. Sumita said, we had this very same rate for everybody, as you said. What we made now recently is rectus 1, but add transposition, add transplantation to that. So that's the modification we have done in the recent past to improve or add to that complexity.
In the end, like if you're doing a sensory exo or a ESO, whatever, like you do a recess resect, it's fine. But moment you're doing say partially accommodative ESO, now your thought process changes because your responsibility increases. So that's the difference I thought we should have in our minds. That goes for
Yeah.
almost all subspecialties.
Actually, you are not getting paid for just the product per se. I mean, it's not a biscuit that you're being paid for. You're being paid for the entire process that has gone into, especially for strabismus and pediatric ophthalmology. The surgery per se may be a very small part of the overall intervention that you have given, starting from refraction, deciding what to prescribe, and the post-op management, evaluating for binocularity, and also that is why, I mean, I really like the way Ankur has divided on the amount of investment each one of us has to make depending upon the type of intervention that we are making.
I think we should move on. A lot of questions.
So we can adhere to that. We can charge more, but at least minimum charges should be like that.
Yeah, this can be taken up as a group call, and then we can have something what Dr. Ankur has put it. This is very useful for everybody, especially beginners, where to start, what it is, and what's the Indian scenario. It will be really good. So let's move on, and I call upon Dr. Aloka. She's one of the leading private practitioner in Hyderabad, and why not, she's a better person to talk on loan private practice. Over to you, Dr. Aloka.
All right, this is the most imposter syndrome that I've felt in my life because I have my mentors, gurus, and colleagues who have definitely much more experience also than I have. But I would just like to highlight some parts for anybody who wants to venture into this unknown world of private practice. So now I am a second generation doctor, and my both parents were private practitioners, are private practitioners. And what I always thought is that I will never do private practice. Because I saw them slogging day and night. I hardly got to see my father. And, I always thought this is not the route. I selected my own partner, but went south and then reached the Mecca, that is Arvind Madurai. I think it gave me much, much more than pediatric ophthalmology. And as we understood the community model of ophthalmology much more in the institute, and with that knowledge, with a new wedding, and as a hangry mother, I ended up in Hyderabad. And this city was completely unknown to me. And really, I actually thought after that fellowship and so much of experience behind that this city is going to enwrap me. But I was so mistaken. And there were so many paths, it was extremely confusing. And unfortunately, this was my experience almost a decade back in this so-called metro city of Hyderabad, where I obviously, in every job interview that I went to, I had questions like, what is pediatric ophthalmology? Like, what do you do? Like, we have an optometrist giving glasses. What else do you do? How many squints would actually come in a year? And I thought, like, I'm in the wrong place, wrong time. And most of the places didn't have a GA setup. And they were so hesitant to have something which I considered so basic as a GA setup that I really was daunted. I started rethinking, not pediatric ophthalmology, but my marriage. And I actually packed my bags and was ready to go back to Madurai. But I had to hang on. Indian families, Indian marriages, yeah. So what was the task ahead? I had to learn, unlearn many things, introduce yourself again and again to every place that you go to, learn in some of us who go to cities which don't speak our native language, you learn a new language, learn a new skill, and then you try to be more presentable and more confident. Very, very difficult, especially when you come out of institutes where actually you feel like a very small seed in that entire big tree. I started my journey from a multi-speciality hospital, then went on to solo eye care, became a freelancer, so tried my hands at almost everything. And I think as many pediatric ophthalmologists in the room, we are always the lone private practitioner wherever we go. Because most of these hospitals, you are the solo pediatric ophthalmologist, so you have to kind of learn all the skills of private practice even if you are in a corporate setup. Things are a little better now, but this is my experience. So I think finding in a new city, I find more friendships among pediatricians than ophthalmologists. I think pediatric hospitals or visiting these hospitals, making that kind of connect with your co-pediatricians is really going to help you in a long way. I started doing ROP screenings, almost 14 to 15 hospitals I was covering, and I met my tribe. Of course, Jeetu Bhai has been like a foster parent to almost all of us. Anything, anytime, he's always available. So yeah, meet your tribe and try to create a cohesive group. I again got lured into becoming a consultant, fixed pay, fixed things, ease of work. So, but yes, sometimes corporate practices in the beginning of your career does help you. You get more connections, more patients. You know how things work in a hospital, and that helps you to enter into private practice too. Of course, it builds up your confidence when you are, just out from an institute. The you're at all-time low, and when there is this city which does not adapt you, it's even lower. So having senior colleagues who are even refractive cataract surgeons helps you to understand how things work in this city. So of course, I stuck on to specialty practice, and many of you do practice adult cataracts, but I do only exclusively pediatric ophthal services and adult squints. So I stuck on to that practice, which was really difficult. I would say many a times you're lured. People tell you, why don't you just go and learn LASIK? That will make your life easier, more money coming in, and long-term patients of your pediatric ophthal practices. So each to their own, but in exclusive specialty practice is what I stand from here. So what do you need for an exclusive specialty practice is, one is availability, and that for a private practitioner is extremely important. Coming out like this on a Saturday, which is your busiest OPD back home, is difficult. And these things are almost a given that a parent wants you even if it is a Sunday or a Saturday or any of the government holidays. So with busy lives of your patients, parents, and everybody, your availability actually is key to working, getting that practice. Patients, I think decade back, these patients have taught me more patience than my kids have. And it takes a toll sometimes on you, but you have to learn your coping mechanisms. Consistency is the key. If you are visiting those 5 hospitals, you better stick on to that till your lifetime. Because consistency, every Friday if you're going somewhere, you have to be available come what may. Team building, now this is something which is very paramount when you come out of an institute, because here you need those 5 people around you, a good optometrist, a good counselor, a good reception staff, because these are the value services which will be talking to your patient much more than you do. And confidence. I think confidence is a skill which builds up slowly. You can't be confident on day 1, but you will be a slightly better on day 100. And that is now 2020, with all that lockdown and a lot of meditation, I started my own setup. And I thought it's time that I come out of doing a private practice in some other hospital and really started private practice. My main agenda was, of course, autonomy to decide what, when, how, which. And safe anesthesia facility, I think that is something a lot of, 3rd tired, 4th tired, or 2nd tired cities also are still having a problem with. Many corporate hospitals do not want to invest into a good anesthetic team, a good GA setup, and of course, the rest. So, how do you begin? Now, there's so much. When you actually sit with that blueprint, you learn about rentals, you learn about lease. As most women, we usually are a little hesitant with finance. So almost 5 years before this, I started doing at least my own IT returns, and that helps. A lot of us have fathers, husbands doing all these financial things, and you stop looking at how much you're actually making, how much tax you're paying. So start paying your IT returns, girls. That really helps. So finance is, financial education is something which you need very paramount in a private practice. Start with, what I feel is that if you have, when you're starting your hospital, let that anesthetist team also be a part of your core group, because you really are focused on having a good GA setup and a good post-operative recovery. And for pediatric ophthalmologists, that really is paramount. Visit hospitals, all your colleagues' places, any other city. Start visiting places and see how they are trying to set up infrastructure. Get some experienced designer who has worked with eye hospitals earlier, that helps. And start doing the whole process of those 15 licenses that you require to start your hospital. Practice management, I think more will be said later on this, but it's good to have a management software. Like we saw, so much of our myopia control, our myopia progression treatment, everything depends on a long list. And most of these patients, they either come directly from school or somewhere, they forgot the file, they change houses. We don't want to depend on them. So at least have a good management, patient management software, establish patient feedback into your services, reach out to patients or colleagues, and establish a good workflow in your hospital. Marketing, now this is something which a lot of us are very hesitant to begin with. Self-marketing is something you will have to do in a private practice, and you have to get that word out that you have certain skills which are little higher than maybe a general ophthalmologist. Sorry. Yes. So this is a thing all of you should have, especially if you're trying private practice. Please have social presence on Instagram, YouTube, Twitter, wherever you want. A very simple thing like WhatsApp chat actually helps. All of you should have a Google My Business page, and do marketing in your own hospital well. At least show your photographs and things like that. Team building is something, this team has entirely changed even in the last 2 years. So team building, people leave and you must be ready for it. Seek out for the industry support. Seek value-added services, like Sir said, market those services well. Outreach, and this, I think, I would conclude here, is it makes you a happy doctor in OPD or OR. And you're not looking at only returns, you are looking at the overall happiness. And like Ikigai, you're looking at what gives you happiness. Thank you.
I think very well spoken, Loka. It was really good. I think a lot of people here are going to get inspired by it. I think all of us who are in this field of pediatric ophthalmology is not for earning money, it's because of the passion that we have, and it's this passion which will drive us to start practice. So I think it's good. As rightly said, the patience and the consistency should be good. What other point I would like to say, as you also mentioned, is try whatever money you get back, try to invest at the same time, because this is not going to drive us and give us a lot of money simultaneously. But if you're passionate to do it, you can definitely do it. Start investing small, so by the time it is like 5-10 years down the line, you will have a good corpus which will help you build make you strong financially as well as have a good practice.
Thank you.
Go ahead. Yeah, I think we can call the next speaker, Dr. Jaspreet, who will speak on institutional pediatric ophthalmology. I think we'll shift gears from private practice to PGI.
Institutes have their own challenges.
Yeah, indeed, we are in an institute, we are under an umbrella. So that's the biggest aspect. We don't have to do any marketing, we don't have to go to any social media. Because if we go to social media, probably then we'll be left only for that. They're going to kick us out. We need a lot of permissions for all these things. So we are not into all these things. Probably I would be talking about my institute. Thankfully, it has a good name, but it's the people who make the institute big. So what all, I'll try to paint a rosy picture of it. There are some issues which I'll highlight as well. So, oops. So basically what we have, so where can I read this from? Can I come down?
No, the size is going beyond.
No, it's difficult to read there.
Can you readjust the size for this? It's going beyond the...
I'm myopic, this is too much for me. Yeah, okay, so I'll go that way. So where I work is a tertiary care institute. It's a teaching institute. So we have to cater for all these things. We have a multidisciplinary team where we have different departments. We have a good anesthesia setup. We have pediatric anesthetists. So we can, with all these things, we can do a lot of research, and which is ethics-based. We have evidence-based medicine. And of course, you can see other institutes as well, LVP, AIMS. I mean, all they have making guidelines for all these things. Collaborative trials are something which big institutes can go on. we don't have to bother about patient-related finances. That's a big thing in private practice. And of course, we have access to equipment and manpower as well. So can I move to the next slide? It's not moving. Can we have the next slide, please? Next slide. Yeah. So because it's a tertiary institute in North India, it's a referral center. So we would cater to all types of patients. You have the simplest of patients coming for classes as well, and you would have the most difficult or the complex cases coming as well. So that all makes it a very large volume based center. Patients with delayed and late presentations. So patient would be going on to different places and being managed. And sometimes what happens is, unfortunately, it's the patient after going to so many places comes at a very late stage where we are also helpless. So we have to deal with all these patients. And because it's a tertiary care institute, these patients have high expectations. So to counsel those patients about what goes on is quite a difficult task, because they come that, yes, you are the last point in our management, you do something about it. But then that goes on everywhere. We have to be realistic in our goals. And yes, there comes in where you have a comprehensive eye care, basically, where we can send the patients to different subspecialties or departments as well. So because it's a multidisciplinary collaboration, and we have subspecialty expertise, like obviously in an institute-based practice, we have a pediatric, you can have retina, you have glaucoma, you have cornea. So we don't have those issues. I mean, wherever we have doubts, we just send the patient and have referrals and have their opinion as well. We don't have to send them to different places outside that, okay, fine, you would go to a cornea specialist or go there. I mean, we have people doing pediatric retina as well. So those things are taken care of, and basically it's a quick way of dealing with patients. I mean, the patient is also quite happy on the same day. We try to do, basically collaborate on the same day and have a decision what is going to happen to the patient. And of course, in case the patient require opinion of other departments like a pediatrician or a neurologist and a geneticist, probably we have the provision for that as well. And probably doesn't take long. Probably in a week's time, we have everything in that institute. In a week's time, probably we have all the opinions, all the suggestions where we are able to manage the patient in an appropriate way. So that's the biggest advantage. You have in-house probably just everything to manage the patient. So the next thing is coming on to the teaching and research opportunities. Now you have so many different type of patients coming here. Probably you would have a better chance of seeing all the different ailments, and in a, you can say, a larger volume as compared to maybe other places. So what happens with these? You have academic activities like presentations and ward rounds. Obviously, patients are admitted for all these things. You have the provision for admitting these patients before surgery, and so the discussion goes on for all these things. You have allocated time that, yes, okay, fine, finishing in the evening or maybe in the morning, we could do these rounds. Then, of course, because of all these things, what we are staying updated with the knowledge. I mean, these academic activities in our institute are almost done every day, every morning. So that does help in keeping us updated. I mean, we have the residents presenting. So those are the things which help us in moving further. And because we have a continuous intake of residents, probably, so we are not really bothered about manpower in our clinics. Yes, manpower comes at a little senior level. I have my senior resident who's a dedicated worker here, Kajri, sitting here. So she's been in pediatric ophthalmology probably for quite some time. But yes, the issues are that at their level, what happens is there is a rotation. So we don't have any fellowships or MCH programs in our, at present in pediatric ophthalmology. Probably in the near future, we would be starting some of those. So, but they are rotated. But still, even if they are rotated, we do have somebody helping us with the examination. Then you have interdepartmental case discussion as well. So probably in these complex cases, we might have a day, okay, fine, you come up at the particular time, and we can have a discussion on this case and how to manage the patient in a better way. Clinical trials and research can go on between different subspecialties. So that is not difficult, because it's in the same departments where you have different subspecialties. And even with, if it's because it's a big institute, you have other subspecialties, so we can easily collaborate with all of them. That is no hindrance. Of course, CMEs and joint academic meetings because it's a large group, probably we are able to hold this in an institution, and there is a provision of training health professionals from outside who would come from even other countries as well, and the provision exists for having them for a few months and getting trained. So surgical care, as was rightly pointed out by the previous speaker, probably you need to have a good anesthetic team as well in your management protocol as well. So we have a round-the-clock anesthesia backup. So we are not really bothered about in case the patient has a complication or what at 3 o'clock or 4 o'clock. There's always an anesthesia backup. But yes, we have allocated days for surgery. We cannot do the surgery any day. We have specific days where we probably would have a day allocated for a GA team and a day for our LA patients. So that is there. It's a system which we follow. High risk is much easier as compared to a private setup because we are under institutional umbrella. So we do take a consent, but thus the patient is more receptive if we tell them the risk involved with the particular case. And we are dealing with a great number of rare complex cases because it's a referral institute, it's a tertiary care institute. Even the private practitioners who are there probably in our area, they prefer to send such complex cases with a high risk of GA to our centers. Pre-anesthetic checkups, of course, not done on the same day. They are done previously because the patient might have to go, the little child might have to go through different departments to get a clearance, maybe having some kind of a cardiac defect or a pediatric issue. And we have specialty trained anesthesia teams, which particularly are involved in pediatric anesthesia, pediatric care. So equipment, this is a little difficult part. We do have access to advanced technology for all the exams what we have. It's a state-of-the-art technology, but the procuring process is lengthy. We have to go through government portals. We have to select which is the lowest bidder. We can't be just buying which is the best machine. That is not allowed. So this process takes time because every department is allocated a budget. So within that budget, every subspecialty like retina, cornea, glaucoma, pediatric ophthalmology has to have to give their suggestions and have to ask what they want for the current financial year. So that is one aspect where we might lag behind. But yes, with the changing, basically what's happening now is that the way they are managing is changing, so probably things would get faster. But this is one of the places where we do have difficulties. So we do but the advantage is that we would have equipment like RedCam, OCT, probably even research tools, which might help in better understanding of the disease. So all these are possible in an institutional practice.
1 minute to go.
Oh, that's okay. So patient-related finances. Of course, private practitioners, as we have been here, the first talk, Dr. Anko was saying that what all has to be, they have to see how to charge their patient. Here, we are not involved. So, of course, in AIMS and in our institute, probably how much do we charge? I think just 1,000 rupees for a squint surgery. 1,000, 2,000 rupees, that's all. So basically, it's an institution, so we don't have to bother about all these things. So the total probably with the consumables is probably would be done in about 4,000 or 5,000. So this is an issue here. So we don't have to. We can choose the consumables if we want. The patient does not have to. I mean, it does not basically fuss about it because the consumables are not that expensive. So there's a lesser cost of surgery, and we do have schemes to accommodate the unaffording patients. So we have patients who cannot pay. We do them, of course, free of cost as well. So that is a provision in the institute. Then on the new schemes which have come up are that under 1 year, there is no cost. You can use the best of IOLs, you can use the best of your vitrectomy cutters, and for pediatric cataract surgery, they are under 1 year, I mean, they just do it it's done for free. So I'd like to conclude here by saying that comprehensive and specialized healthcare setting is something what we have in an institute. We have a multidisciplinary approach, which is everything is there in the institute with a commitment to ongoing improvement in clinical practice and patient experiences. So all this with large volumes and different specialties and subspecialties, probably that is what the advantage, what helps us in moving on is. And then we have access to advanced resources, opportunities for collaboration and research, exposure to complex cases, and of course, with this we make a supportive environment for both the patients and the professionals. Thank you.
I am going to take a slightly different approach here, being from an institute but a private institute. So my perspective is a little different here. Yes, as he highlighted, there is team and multidisciplinary approach, and you really don't have to worry about finances part of it, or you don't have to worry about sterilization, OT staff, personnel going, coming. That's not at all an headache. But every institute has a culture, and navigating that culture can become, for somebody who is not trained in an institute, is a challenge. I was trained in Arvind and then went to Shankar Netralaya. It was a huge cultural difference between them, and you had to learn to navigate it. And again, there, it's better always, if you are traversing from one training place to another, it's always good to keep a little low profile in the, in the beginning, watch out, and then go it. But on the positive, there is always help available. If you are stuck in a difficult case, there is always a second opinion available at the corner. And I think that is a big, big plus for anybody who wishes to join an institute. Only thing is, yes, you have to learn to deal with different types of people and learn the culture of the place.
Yeah, I think that's good. Yeah, thanks. Yeah. So we'll then call Dr. Kalpit Shah, who better than a Gujarati in Baroda can tell us how to tackle insurance issues.
So the topic is tackling the insurance issues, but here just I would like to raise the different queries, not tackling, but raising the queries that what should be our answer or how to make the mediclaim files. So there are different points what we have to answer. So first, regarding the first consultation, always we have to write that since how long, that as per the history given by the parents, but we should not be in the trap that since 3 years or 4 years, because sometimes they have some photographs of the previous years, and that we can be under culprit that we have made a wrong statement. So generally I do practice in that way, that the history given by the parents. I would like to ask Rohit, Ankur, Jitu, what we
write is like noticed squint 3 years back. Parents noticed squint 3 years back. So that's a kind of bargain between when it was there and what the parents are complaining of. So we should not commit, at least right, that the squint appeared, squint came 3 years back. So squint could have been there from the 6 months of age, but the patient is saying that now it is problematic. So this is what we have to keep in mind.
because that comes with the intermittent XT. Because it might be since long, the patient has taken that insurance before 3 years or 4 years, then that problem occurs.
So in the XT specifically, I asked the patient that do you have a photograph where you are looking absolutely aligned? So I need to have that photograph and keep it with yourself, because you have to keep yourself safe from this forgery kind of thing, which can cause a investigation against you and then possible blacklisting and depaneling almost all insurances if you forge your documents. So you have to save yourself there. So keep a photograph of XT with you, and then write that this is the photograph which the patient has shown, and the squint is not there in this photograph.
So infantile iso.
Again, you say like when the patient notices it, it's like sometimes it happens that the mother and father are saying, we don't feel that the child is a squint, but actually Dadaji or Dadiji was saying that the patient child is a squint. So it is their feeling of noticing the squint. It may be there right from 6 months of age. So you have to rely upon, as rightly saying, parents complaining. It's not your decision when it is there.
So yeah.
Most of the insurance companies, if we write that it is from since birth or since early childhood, they don't cover it in the insurance. So parents have a feeling that you write that it came suddenly before 3-4 months. What's your take on that? That shall we write what it is?
No, that we have to write what it is. That is sure. If it is an infantile iso, then we have to write like that. So if like suppose something is like a midway, gray zone would be intermittent XT, that would be a gray zone. So in that case, we can help them to get that claim.
Yes, exactly.
If we feel that he should get that mediclaim, then we should help. But if we know it is since birth, then of course no, because we will be under strap then.
Also make clear that this agreement of insurance is between you and the insurance company. When you bought this insurance, I was not there. So whether they pay you or don't pay you is not my kind of job, and I am not going to forge anything for your payment. This has to be made very clear to the patient. At the beginning,
Don't get your money, the problem between you and your insurance. So right now, people and insurance companies are also not clear. Sometimes they get the reimbursement, sometimes they don't get the reimbursement. So, like in cataract vision promise, but here it is a bit of gray area.
We should not give promise.
That's what I said. Now, like we have to make it clear right from the beginning that it's an agreement between you and the insurance company, and I am not part of the agreement. I am a service provider. I am a doctor. I am here to correct your diseases, not clearing your insurance
That
claims.
all depends, like sometime it depends. It's a group policy, they can get.
Sorry,
Even in infantile ISO, they can get in certain
No,
policies.
are you also talking about cashless facility which your hospital does? Then you are in a soup because many a times you don't get insurance, the patient has already finished the surgery and gone. So for cashless, like right now what I am doing is I'm not allowing any cashless, I'm only doing reimbursement that the parent can do. So what is your take?
I think reimbursement should be followed.
Yes, I mean, since cashless, it is not available in many centers, and insurance companies are not providing good rates also. So it's better if we go for reimbursement.
No. I differ here. Like if you have a cashless facility with one insurance company, you have to first offer a cashless treatment to the patient. That is as per the MOU you have signed with the insurance company.
But
so you have to send a pre-authorization.
Before the cashless, we have to make the agreement. So in agreement, we have already made an agreement with them regarding that screen
Yes,
surgery.
yes.
So it is like purview, then we have already decided. Then it's okay. But
Yeah.
normally, we prefer to do reimbursement because it's not our headache. Yeah. We can write like,
Yes, definitely. I too prefer reimbursement. Regarding the declaration that what Dr. Om was asking, sometimes the patient expects from us that if you don't write that it is since birth, then they will reject. So the patient is as if you don't want to favor us for reimbursement. So what I personally guide them that this is the condition if we are tackling infantile esotropia. If you want me to write that this is since not since birth, then there we have the panelists in the insurance companies who are much more senior than us. They'll just throw your papers away. So there is no point in you expecting me to favor by writing something which is not
that
there.
we can make
Because
simple statement. We don't write anything wrong.
so
It's our, it's a final statement.
yeah, we
are
don't
not
write,
doing any
but
wrong
they
thing.
when they insist us to favor them.
Yeah. No, that is one, it's a single slide.
Even we know that the infantile esotropia is not at birth. It may develop 4 months or 6 months down the line. So the first thing you have to make clear to the patient is it at birth or is it after birth? So that's a different ball game.
And if we feel it is not since birth, we can write it was not since birth. That's all. Now the second, yeah, please.
I think one of the thing which is important. Yeah. Okay. One thing I just wanted to say is most of the time problem comes with regards to infantile esotropia. The minute they hear infantile esotropia, they will reject everything. So in this, how can we help is there are 2-3 things we can do in the statement. Even if it is infantile esotropia, surgery is done to align the eyes, improve the binocular cooperation, and it's not a cosmetic surgery. These 3 sentences makes a big difference. As Siddharth said, I am not lying there. I am really facilitating insurance for the patient. So these kind of additional things we can tell our counselors or our people who are taking care of insurance. That way we can benefit.
Yeah, so that is the point, the reason for surgery. We have to mention the reason for the surgery. Either for the diplopia, for the amblyopia, for the binocular vision, head posture. So if we write, and specifically we have to mention that it is not for the cosmetic purpose. So if we write the reason, then there would be better presentation for that file.
So in a non-seeing eye sensory exotropia, what will be your reason?
No, then it's a cosmetic. So we should not write that any reason for that.
That's what I'm saying. So that's
So
there is a
it is no. In the policies,
actually there is a paper from American Academy of Pediatric Ophthalmology. Even a sensory esotropia, a person has a right to look normal. This is what it is. It's not like if you get a wrinkle at 70 years, taking botulinum toxin there is cosmesis. Here, person has a right to look normal. That's why even sensory, we can say that it's a functional outcome, not a cosmetic outcome.
Even a blind person with strabismus has a right to look like a human being is meant to look with the eye state. It is a correction of position.
Yeah. So that's why I wanted to add, we write restorative squint surgery and we don't write cosmetic surgery, one. And secondly, there are a lot of papers even in ophthalmology regarding the major psychological and developmental impact of strabismus on learning and on the confidence and social interaction of a child. So, I mean, it's just that as pediatric ophthalmologists, we have not stressed on this fact, and unfortunately, we have always been downplaying these other major changes. And I'll tell you for a fact that even children with CVI and children with other developmental issues, some time back, I was hesitant where I was clear that there is very poor vision. I was very, very hesitant to do any kind of strabismus surgery. But I've realized that in particularly children with esotropia, just an increase in their field by aligning them has made a huge impact in the development of the child. So, like I said, as a group, we need to make this aware information to everybody, caregivers, decision makers, that it's not just a cosmetic or a restorative, but there is a huge psychological developmental change that you are going to see in a child, and that is a major impact. I mean, why do we fall into the trap of, I would say, cataract surgeons, that you have measurable, improvement from 618 to 66 as the only benchmark of success? The benchmark of success in a child is that he aligns and gets developmental, overcomes the limitations in the development process to make him, socially, normal person. So
what should be the final verdict for the sentence?
I think it should be restorative, because there are many evidence. Surgery.
Okay. So we are restoring his alignment, what it normally should have been. The eyes should have been aligned. We are restoring that alignment.
Okay, so the reason for that restoration of the alignment,
Yeah,
we have done
because people get married, people get job after this correction. This is what a difference it makes to the patient.
Rohit, there's a question that they directly ask, is this cosmetic or not? So when they come as a ring, so we refuse that.
So we can write, it was not for cosmetic reason.
Because unfortunately in India, the final thing is that you want to
suppose
reject
then-
insurance at any time.
I wanted to
That is created by us only. Even today, इसको एक cosmetic कर दो यार. This is what I get a referral. Cosmetic कर दो.
General ophthalm, but suppose there was a simple question, queries raised by the insurance company. Please mention it is for the cosmetic reason or not.
No.
So we should write that it is not for the cosmetic reason, it is for the restoration.
It is functional.
So is it problem that we should be under trap?
Yeah,
We should
that's why
understand-
I'm saying it is important that all of us change it, that there is a functional change in children that we see after we have done strabismus surgery, even if it is not going to give binocularity. That is an understanding we have to first learn and imbibe as, treating physicians.
It's important to understand what's mentioned. Means everything is normal. In your perception, you want to enhance something even more than that. But it is essentially normal. A misalignment is not normal. So straightening out an eye is nothing to do with cosmesis. Cosmesis should be out of our language.
One more thing
Now
is
then
I just
the-
wanted to add Dr. Kalpit. So sensory strabismus, right? So those patients who have moderate or even severe form of vision loss, majority of them, they do
Okay,
have
okay, okay,
peripheral
okay.
vision. So if you align
No,
their eye,
see, just
they
want
can
to
use that
make a
peripheral
point.
vision in a very better way. patients with ROP, patients with the macular scar. If we align them, they do have a very useful utilization of peripheral.
That everything we understand, but here the point is what we have to write for the file.
Okay.
That we all understand.
I know this is, we can carry over this discussion in the lunch, please, because otherwise we will not give the.
Question you want to ask? Any last question?
Major
Nah, then regarding the general anesthesia, they require 24-hour stay. So like as a solo practice, there is nothing like a 24-hour stay.
But I don't
So
think
Lot of insurance
for
companies do.
general anesthesia, for local anesthesia, they give.
No, no,
all generally they don't insist.
They don't insist.
no, insist. छोड़ देते हैं यहाँ.
Okay, fine. Then any changes what we have to make the receipt or the bill come receipt, anything else like, fine. So this is the, okay, fine. And this is the letter we can provide along with that our file. That letter issued by the PM office, Dr. Pradeep Sharma sir. So we can give that letter along with our Mediclaim file.
They reject. That's the unfortunate part.
Yeah, they always raise a queries. Regarding the queries, one point they always ask the cause of the disease. So normally what I do, I write, they don't understand nothing else. I write idiopathic. And don't write that idiopathic means without any reason, nothing like that. Idiopathic. So they want just one letter. Fine.
Okay,
So,
okay, we are going to move to Dr. Jitendra again with skip, huh?
Okay.
Okay, very good, thank you. So
Get lunch faster
that's how, okay.
for starting private practice.
So, okay, Dr. Om Patel, please, for your tips about starting private practice. So, research is getting trumped by the lunch. We'll see afterwards if you have time, you can come back and.
Hello.
You have to take this mic.
No, it's working. So my topic is tips for starting private practice. Now, as such, there are no perfect tips, but I would like to present some of my points which you can ponder upon while starting your practice. So, first thing is you should ask yourself, are you ready for it? Ready in terms that you should have a necessary skill set, you should be adequately trained, because any premature entry and complications in the early phase of private practice can lead to disappointment. Second thing, you should define your scope of practice, like whether you want to do only solo specialty practice or you want to do comprehensive practice along with it. Third thing is you should think upon your personal and family commitments, like you should be able to give proper time to your practice in initial period at least. And then obviously you have to plan how you would raise the funds and what are your plans for investment. So once you are clear on this, that you are ready, then you should plan where you will start your practice. Because you should first assess what is the need of the community regarding your particular services in that area, what is the existing level of care available, and how you can penetrate, or like what extra you can offer to that specific community over there. Third thing to ponder is whether to go solo or to start a group practice. As we always all know, teamwork is dream work, and I personally believe that 1 + 1 is not 2, but 1 + 1 is 11 when it comes to starting your practice. So if you are thinking on group practice, always think that it's always better to get a partner who is practicing some another specialty, or there are again many benefits versus disadvantages, and this is a debatable thing. Then once another thing comes, premises, like when you are starting, whether to buy it out at the first go or start on a rented premises, then gradually shift to your own place. What should be the minimum space requirement for a startup? Because these days, especially in metros, you should have slightly comfortable and aesthetically good looking setup to convince the patient for getting operated or getting services at your place. Another point is equipments. Now again, in our branch we have a lot of equipment, so we should define what is the minimum basic requirement and how we are going to allocate our budget for the same, and what kind of OT premises are we planning, whether to go for a modular setup at the first go or gradually enhance it. And then always think about what is the scope of expansion and how you can add on services gradually. Then comes the most important part, reaching the target audience. Now, there are no specific way how you can reach to your patients, probable patients, but I think letting your work speak is the best way. Like definitely working in some trust hospitals or working in government setup nearby, you build some good patients who are happy with your work, who try and give you more patients. Then always utilize scientific platforms like local ophthalmic society, your subspecialty platforms. Always show your work so that people are more convinced, especially referring ophthalmologists are more convinced that you are able to handle all kind of difficult situations. Obviously, utilize social networking platforms, business platforms, and marketing. As it is already discussed, you have to do some sort of marketing, maybe in digital form or print media. And then, even if you do all this, even if you think all these things, still there would be waiting period. So how to tackle this waiting period? Patience is the key. Value yourself, and most important, don't sell yourself cheap. If you don't value yourself, nobody will value yourself. So set reasonable goals for revenue in the initial period, and whatever free time you have, always sharpen your axe. Try and see how you can enhance your skills. Another point is always go for ethical practice. Always think on a long-term basis, because it builds credibility among your patients, among the fellow ophthalmologists. If they see your cross-consultation, if patient goes for second opinion, they should be convinced that whatever he has said must be ethical and really needed. And ethical service doesn't mean offering free services or cheap services, but do what is needed, and you should always have a long-term goal. And this is my last slide, and I would like all of you to give some inputs on this, that whether to stick to the ground, go for an expansion versus real growth. As you grow, you expand, or you go with all in like the corporates. That lot in the race of marketing, equipments, whether to involve investors or not, especially non-medical investors or corporate investors. So these are the few points. Thank you. Thank you for giving me.
And also money. If you have all the money, if Ambanis want to open one thing, they'll make it huge.
If you have the money, then how much sane it is to invest in all in one go? Like.
Yeah, so that's what I'm saying. Money is not there. You're not worried about the loan on your head, and you feel you can start in next 1 year. You're not worried about getting back the money. You can easily start with a big thing. So obviously, it's going to be individualized. It's not that everybody should start this as a blanket thing. But when you feel that you want to go into practice and you want to go, definitely you're not looking at any other option, and you don't have the money, then go slow. Invest on important things like microscope, where you know you want to get the best results, something like this. So you have to go slow and steady and then go. But where money is not your worry at all, then you can go. And one thing which you mentioned about group practice, which is not very common in many places, but when you plan it, and you plan with, try to have the open-minded, same-minded people, but ensure that you have everything in black and white. You literally have to have four friends start, but eventually as the practice goes, one may be a pediatric ophthalmologist, unfortunately not earning as well as a cataract person, and then you start spoiling relations. So it's very important, everything should be written in black and white when you plan any group practice. And I think I liked your point of saying don't value yourself, don't sell yourself cheap, which is very important. And as pediatric ophthalmologists, unless we really, value our own selves, nobody is going to value us. That's true. I think Siddharth is waiting to push him off.
No, I'm
and
not
give the last talk.
Because we are short of time.
And I guess, I know you're hungry, Siddharth. We'll go.
Acha, okay. Okay, so my talk is about addition of vision therapy to your practice. This talk was supposed to be in the last session, but because I arrived late, it is now in this session. And I have been allotted 10 minutes, but you are free to stop me anytime because if you are hungry, the lunch is already served outside. Before I start my talk, a couple of pep talk for the new people. Stop thinking of this yourself as a bechara. Being a pediatric ophthalmologist is not being a bechara. So get out of this bechara syndrome. There is a lot of money in pediatric ophthalmology. Extremely large amount of money in this pediatric ophthalmology. You should know just how to get it. Okay? It's like on a hot summer day, you are the only person with a pitcher of lemonade. Okay? So in the entire city, you are the only pediatric ophthalmologist, or there are two like you, and you are still crying about money. That means you don't know how to make money. And then if you are in that situation, you will not be making money in any other branch, believe me. Okay. Second, why do we crib about it takes time to establish? Who doesn't take time to establish? Sachin Tendulkar became overnight sensation? No. He took a lot of hard work to get there. All the actors, they struggle, they do small roles, side heroes, dance in the back. Then they come in the front. So why are you crying about this struggle, so-called struggle? You want to be given on everything on first day? No, you will not get. And no branch will get. You be a pediatrician, you be an orthopedic surgeon, a radiologist. You have to go through that struggle. Who knows that you are a doctor of good repute? Who will tell them? You will tell them. Have confidence. If you are going down, backwards, bending and asking for work, nobody will give you. You have to prove that you know more than the next person. He will send you work out of respect, not out of charity. So you have to command that respect in society, not beg for it. All the pediatric ophthalmologists will get referrals from the children of the other specialities. Why? Because they think you know something. No? The same people will refer you their patients. So that is beside my topic. I'll come back to that later maybe. Okay. But I feel very strongly about it. I feel that you are all sitting with a goose with which will lay you golden eggs, and still all that everybody talks about is, there is no money, there is no money, there is no money. If you cannot make money in pediatric ophthalmology, you cannot make money even in any branch. Then you are stupid. Okay, now we come to addition of vision therapy to your private practice. Now this is vision therapy, you are listening about it a lot in the last few years, especially after the advent of a lot of vision therapy software where it got a wind under its wing and a lot of marketing is getting pushed. So yes, it is a very good revenue stream, and that's why you should have it in your private practice. But that is where your businessman in your mind and your scientist in your mind are always at conflict. So because there is money to be made, don't forget the science behind it. So every claim that comes with vision therapy, you have to evaluate, you have to examine, critically analyze, and then suggest it to your patient. Because your responsibility is towards your patient, not towards your software. So you have to first understand that whoever is trying to sell you a product, aiming at treating all sorts of disorders, ask them 100,000 questions before you are convinced. It is easy to sell it, but then you have to answer the patient later on. So what is vision therapy? It is we have attended a seminar on that, so I will not go into it. Broadly, two types: orthoptics, where you are talking about vision training of extraocular muscles, vergence disorders, diplopia, squint, convergence insufficiency, accommodation disorders. And then there is behavioral vision therapy, where you are talking about functional processing of vision. Now here you will come across so much jargon, words which are invented de novo, and which don't have any basis behind. You go back to literature and search. These pathways, many of them don't even find any reference where. And these things have come just because somebody thought it works. Okay, it's just like Bates therapy in using glasses. So you have to ask questions. Don't suppress that scientist in you. You are a science student. You know how to evaluate science. Don't let him go to sleep. Ask questions. If you don't ask questions, you will not get the answers, and then you don't have the right to suggest it to your patient. Okay. So behavioral vision therapy is the gray area, where people are claiming that doing certain exercises will actually improve processing in the brain, which really nobody understands. It's like telling that if you read too much or you study very hard, you can become more intelligent. If you study hard, you can become more knowledgeable, but you cannot become more intelligent. That is an inherent quality. By learning to play a music, you cannot become a musician. You can just play that instrument. If you start playing table tennis every day and increase your hand-eye coordination, that doesn't mean that you can go and play lawn tennis from the next day. For that particular task, you are trained. So when you are doing vision therapy, most of the times you are saying, okay, this is the task, this is the measurement before vision therapy started. Then you train on the same task for several sessions together, and in the end you say, okay, he has improved in this task, and that is why he will be able to do so and so also well. But he is only going to do that task well because he has been taught how to do that task well. It's like an operant model. So you have to understand how these things get extrapolated. So why should you add vision therapy to your practice? Obviously, it increases your referrals. Somebody in the city may not send you a strabismus patient for surgery, but he will surely send you a patient which he doesn't understand. Or it is an important a stream for the optometrist to keep his interest intact. So it will make him read more and more, they will discuss more and more. So it's a very good learning tool if you have vision therapy in your clinic, because you are thinking about aspects other than aligning the eyes. You are talking about binocular vision and fatigue and all those things. So that's why it is an important part. Patient selection is very important. Patient who understands the process, you have to make him understand the process. Patient who can afford the entire program, not only a part of it. Patient who can give commitment for the time that is required. And patient who understand that this may fail also. Okay, and the tip is, do not select patients who want 100% cure. Now, patient counseling, always counsel patients that you may require 10 to 20 sessions at least. 2 to 3 sessions will be done per week. And detailed evaluation has to be done before starting the therapy. It has to be a very detailed evaluation where you get involved with the optometrist. You make a plan for it, discuss it with the patient. You show him that these are the aspects we are going to work on. This is how we are going to give him a roadmap so he knows what you are doing. Don't keep him in the dark. You have to make him understand the rationale behind what you are doing. Then he is more liable, more likely to become more compliant with the treatment. You should always take upfront payment for at least 10 sessions so that the compliance is good. Don't keep it like paper. So otherwise they will come pay, the next 2 days they will not come. In the end, your therapy will not work because he is not compliant and not because he will say, I have completed 10 sessions, but over what period of time? Now, how do you establish referral in your department? Talk to people. Talk to people about that you have this service wherever you meet them. One important tip for private practitioners is don't go and meet people in their clinics. That time it is like this. So he is the boss, he will make you sit outside, then he will ask you to come inside, like a pharmacology representative, they will treat you. Meet them on equal terms. So go to meetings where those people are there, you are there. Talk to them. Talk to them about what you do. There you are meeting them on equal terms. Don't go begging for work. What do you need in a VT clinic? Last talk in the last session has already told us. You have this simple equipment that you have to buy. Nothing hi-fi. It costs less than 50,000 rupees investment. You can import all these equipment directly because that we can avoid a lot of middle charges because of that. So you can get it to some relative who is living in the US and they can bring it for you. There is no problem with that. Computer vision therapy actually digitizes everything that is available already. So you have anaglyphs and vectograms and you have targets and you have everything that was available previously. It is just put in a software. It's packaged in a way that and most of the time it is presented as if it is something new, which is not. It is just a way of delivering the same thing again. Problem with computer vision therapy is that it is very costly. Whereas the same time, the same thing you can do in your clinic for much lesser rate. Same thing you will be able to do. Computer vision therapy helps where the patient is not accessible. He cannot come to you, so you can deliver it remotely. And also help him, keep variety in the clinic where you can do some exercises for free hand and then do some computer vision therapy. So it keeps him engaged and he doesn't get bored. So using individual freehand exercises is more cost effective than using softwares. Okay. A word of caution, again, I come to the same point. Stick to proven indications. So there are good literature published on where vision therapy works, where it doesn't work. As an end service provider, It's your responsibility only to stick to proven indications. Okay, a lot of spurious claims are being made. Don't go by it. Let time show that whether it is working or not, and then you do it. Don't make a guinea pig out of your own patient. Remember, while there is money to be made, your reputation is also at stake. Your patients are coming to you because they think that you are an honest, evidence-based practitioner, and you will not suggest anything that doesn't work. So treat every patient like the way you would treat your own child. Would you do that therapy in your child? Yes, then please do it. That means you are convinced. If you are not convinced, don't do it. Wait for the results to come. So these are broadly the current indications. One is amblyopic, non-strabismic binocular disorders, strabismus, some kinds of strabismus like intermittent exotropia and some diplopia. These are the indications where you can use vision therapy, where there is solid literature. This is not more of vision therapy, this is more of orthoptics, where you can use it. So there you can use it. There is enough evidence for you to back up your this thing. Learning disorder, brain injury, sports vision therapy, myopia control, evidence is wanting, least to the say. There are case reports and all, but then it is not something that you would start right now. And organic retinal disease, nystagmus, optic neuropathy, I don't know what to say. I mean, I'm totally at loss of words. Because then if we have found a cure for all diseases under the sun, then ophthalmology ceases to exist, you know.
Siddharth, can you wind it off?
Yeah, it's the last. So I'll come to the challenges because I'm going to make a request to the panelists. Rigorous investigation is needed to define the uses of vision therapy. Education of patients regarding proven uses of vision therapy. You have to educate your patients also because they are also getting misled by internet. Discontinuation of ideas that have already been proven ineffective. There are good trials which have shown that certain things don't work. Stop doing them. Today only. Don't wait, that study might have been bad, some new study will come. No. It doesn't work, forget it. Some certification should be made mandatory for delivery of vision therapy. Everybody is giving vision therapy. Right from the optician in your colony also is giving vision therapy. It is so freely accessible. I want to request POSN to take lead in coming out with a white paper on vision therapy where these indications of vision therapy are clearly listed for all the members to go through. And where the research is clear, where the research is still going on, things are not out, and where it is been proven not to work. These three categories we need. All of us together should sit down, find the literature. We may not do the research ourselves, but at least we can go through the trials and find out, and then come out with this paper, which we can use as a basis for practice in our clinic, for any clinic altogether. Thank you very much.
I think, Siddharth, we can look at that. But one other thing that POSN will start is having a 1-week fellowship with you to know how to earn money from pediatric ophthalmology.
No, there are a couple of very, I should say, good practitioners in Mumbai whose billing is, we should learn from their model, Dr. Chandresh.
Yes, so there are. So we can start with, and the money will come to POSN, unfortunately.
Just a cut of that, just a cut of the fund.
No, my only point is there is a need, and you are the only provider. What else do you want?
Absolutely. So I guess thank you very much. It's been a wonderful interactive and learning experience, including for me, who's never had, thankfully, to think about the end of the month remunerations, except from the government of India. So, but it's been a wonderful session, and it's great to know that pediatric ophthalmology is alive and kicking, and I always say that I'm glad I'm in this specialty because both pediatric ophthalmology and neuro-ophthalmology, which I practice, their time has come. 20 years ago, the time for cataract, 15 years ago, time for refractive, but for these specialties, our time has come. We are the future. I deal with 30% of RP centers OPD because 30% of the OPD is less than 16 years of age. And a typical thing happens, I mean, Delhi में बाकी जगह मुझे पता नहीं ये जाता है कि नहीं, एक वो गाड़ी आती है दिल्ली में, वो गाना गाते हुए कि कूड़ा वाला आया अपना कूड़ा निकाल. तो that's what is happening in RP center. वो बच्चा आता है crying, वो न्यूरो ऑफ्थल्मोलॉजी का पेशेंट आता है बाहर से, अरे अरे भेजो भेजो इसको, उसके बाद भेजो वो देखेगा, अगर कुछ और होगा तो वो वापस भेजेगा, वरना वो ही देखेगा. So we are catering to, you know, virtually 30% of a general OPD's population. So as Siddharth said, I mean, like, really, I can't understand how you can be without work, or how you can, I mean, parents are nowadays really concerned. They may ignore their disease, but they can't ignore their son's mosquito bite also. So, you know, it's exactly, I mean, we need to recognize, we need to realize that what we are serving is among the, you know, really need of the hour, and we should be proud of doing that. So wonderful, great to see such lovely session, and again, looking forward to some great interaction in the next 1.5 days. Thank you, everybody.
Lunch is served at ninth floor. Let us move there and be back here by 2:25.
We found
So I would like to call Dr. Shailja Tibrewal. She is going to present a case on goat horn-induced extraocular muscle injury. Sorry. I shall call the panelists for this session, Dr. Amitava, Dr. Maggie, and Dr. Sumita. So each case presentation is of 5 minutes. So I invite Dr. Shailja to present the case on goat horn-induced extraocular muscle injury and its management.
So, very good afternoon, everyone, and thank you, POSN, for the opportunity. So this 36-year-old male presented with a chief complaint of trauma to the left eye, leading to a vertical binocular double vision. His uncorrected visual acuity was 20 by 20 in the right eye and 20 by 30 in the left eye at the time of presentation. This is how he presented to us. The left eye was in hypotropia, and there was some muscle tissue which was hanging from inside the eye. Along with that, there was lid ecchymosis and elevation limitation. When we closely examined this muscle tissue, it was actually a tendinous portion of the muscle and seemed to look like a superior oblique because of its striations and the tendon. So we made the diagnosis of a traumatic extraocular muscle avulsion in the left eye. We got an MRI done. In the MRI, this is the right eye and this is the left eye. You can see that there is some soft tissue disruption and hyperintensities in the left eye. I don't think, is there a pointer here? There's nothing.
It's working, I can see.
There's no pointer? Okay, it's okay. So you can see that, the superior rectus region, there is some inflammation and there is some tissue disruption. Yeah, there's an arrow. Oh, it's not showing. Okay, okay.
Go
okay.
back once. Go back once, right?
Yeah, I'll go. Sorry. So definitely there was some injury around the superior rectus muscle here also, and as we saw clinically there was a superior oblique also which was suspected. So we went ahead with the surgery. In the surgery, whenever we tackle avulsion or muscle traumatic injury, you have to take care that you don't put too much traction on the globe, especially in the direction away from the avulsed muscle or the muscle which has undergone trauma. I don't know why it's not working properly here. So the superior oblique, the part of the tissue of the tendon which was prolapsed, so that was secured with the 6-0 Vicryl, and the superior rectus was explored. Now whenever we explore these muscles, again we have to take care, don't go directly over the muscle, go on the sides of the muscle to explore the tenons around it, so that the tenon sleeve, you can see the, the proximal part of the muscle. Otherwise, if you put traction on the distal portion, you might pull out whatever little bit attachments are there. So that was done, and some part of the muscle tissue was identified, you can see here, and was secured with a 5-0 ethibond sutures, and it was attached, reattached to the stump. That stump you can see here is actually 14 millimeter in measurement, so the cut was around 14 millimeter behind. I'm not sure what the tissue which I thought that this is a superior rectus proximal end, whether it was actually a proximal end, but that is what looked like a muscle, and that was attached with these non-absorbable sutures. So this looked like fairly like a muscle tissue which was attached back. The superior oblique, however, the proximal could not be found, so went ahead with the decision of just severing it and detaching it. So I'm hoping and keeping my fingers crossed that this would work for the patient. So this is how he was on the first post-operative day. He was a little bit of hypotropic there, like a 10 prism diopters of hypertropia, but he had a dilated pupil. I'm not sure why, maybe a little bit element of direct injury. We gave him IVMP for the inflammation and suspecting probably Tron, maybe because his vision had dropped, but it improved on the second day only to 20/30, and hypertropia also improved. We gave IVMP for a total of 3 days, and this is at his 1.5 weeks, a month follow-up. He just has a small hypertropia, but the elevation limitation has improved, but has not become normal. Definitely there is some elevation limitation there. Very mild superior oblique or underaction there, but most of it is okay in the depression. So he's quite comfortable in the down gaze, in the primary gaze, only having some diplopia in the up gaze. So I also was interested what it was like the torsion, whether it was affected or not, but surprisingly torsion was not affected in him, it was similar in both the eyes. So this is a small video showing the mechanism of trauma. He said that he was just standing, this was the festival time of Bakrid, and one goat just jumped. And he was lucky enough that the goat horn went into the space between the globe and the orbital bone, and just severed these two muscles like this, bringing the superior oblique in front like this, hanging in front. So I thought that, I have seen something new, and every time this happens to me, I go back to the literature, and many of my colleagues have already published this kind of case, and 2 of them are actually from South, from Arvind Eye Institute, and similar type, the superior oblique coming hanging, and the common, denominator here in all this publication is that there is a hook-shaped object which goes into the orbit and puts the muscle. All of these cases, no injury to the sclera, no injury to the bone. So very lucky of the patient to have his vision saved, and very lucky of him to present early so that we could do a primary repair and restore whatever was best. Another thing which I felt that maybe I was not good enough and could not identify the superior oblique muscle proximal end, but none of them also could not find the superior oblique. It's very difficult to find the superior oblique end. And subsequent surgeries have also been done, but in my case, I think it will be okay. Thank you.
I think congratulations for managing a difficult case. I think what saved you was the patient presented early.
Yes, yes.
So at least you could. And I don't know whether it would have worked to suture it somewhere approximate to superior oblique instead of just severing it off the globe, because how much follow-up you have right now?
This is 2.5 months now.
2.5 months. So I think superior oblique palsy is still a possibility,
Yes,
and you
it's
have to
still a
keep that in
possibility.
mind.
Yes,
It may happen over a period of time or may not.
It may happen. But it's like the superior oblique palsy has been treated by a superior rectus recession.
Recession, yeah, probably that's why you got away without torsion and without, but excellent result.
Thank you.
My issue was just with the diagram of the horn that you kind of depicted. I'm not sure. I mean, goats usually will have a horn which is like this. I'm not sure if it is going to go in this manner. Like
Agreed.
Concave towards the globe. Yeah.
So I agree, it's a little bit limitation of the graphic person there.
Yes.
So I was trying to tell them it will go, and it's a dynamic thing, the patient's head coming like this, going up, and the horn going like this and coming. So the conjunctival wound, if you would see, it was just a very small linear wound, as if it went like this, but the patient's eye probably rotated, and then it came out from the same position, because the conjunctival wound was a linear wound just over the superior rectus, and on the medial side, the superior oblique was prolapsing.
And I'm not sure why we are not finding torsion.
Yeah.
Because
I don't know.
Yeah.
I think both the superiors are gone.
He's not even, but it both are intorters, so there has to be an extortion, but that's why he didn't complain of a torsional diplopia
torsion
also.
would be expected.
I think maybe scarring and also.
Yes, sir.
Very nice result. I'm just thinking there was a component of superior factor also in this case. Because if it is purely a superior oblique palsy because of the rupture, patient will have a hypertropia than hypertropia. This patient, whatever you are cutting, there was a flat tear of the superior.
No, sir, the superior, I think you missed it. Superior rectus was totally torn. 14 millimeter behind the point of insertion. The superior rectus was totally cut off. In fact, there were no attachments also. I could pick up something from the sleeve, tendon sleeve, which I could see there. It looked like a muscle and attached it. So superior rectus was totally gone.
So it's majorly a
Superior rectus, yes.
Now, whatever that hypertropia is there because of probable Brown system, which is the superior oblique, is causing. That's why the patient is not able to elevate. Probably no need to do anything, but just that flat tear is something which can happen on all of these patients. And if you try to do a force suction
Yeah, it should not. It should not.
Yeah, for any injury in a muscle, I think you did it under general anesthesia.
Yes.
Yeah. And again, to know that it is a muscle or not, you can always, if you hold the muscle, whatever you think it's a muscle and pull it, you might get a ocular cardiac reflex. So you will suspect, okay, I'm on the right zone or in the right plane. It's a muscle which I'm holding, not anything else.
Thank you.
Thank you.
Now I would call the second presenter, Dr. Tisha. She is going to present residual exotropia more than meets the eye.
A very good afternoon, everybody. My name is Tisha, and today I would like to take you guys through a case that I have titled Residual Exotropia More Than Meets the Eye. Okay, a young male presented to our OPD who was keen on surgical correction for his residual outward deviation, and his past history was significant for 2 previous surgeries that he had undergone when he was 10 years old. And the details were not available, but according to the patient, he had an outward deviation when he was a child as well, and he had undergone 2 surgeries for the same. And he reports no period of improvement in ocular alignment after the surgery. He was a highly unsatisfied patient and was keen on cosmesis. He reported no complaints of any diplopia at any point and no history of ptosis ever, and he was not on any medication and he had no other comorbidities. So when we went through the FAT scan, this is him. We were lucky enough to get these pictures of him. So as we can see, there is an outward deviation in the primary gaze, and what is standing out to us here is there is a marked limitation in the right eye adduction. So we went ahead and examined this patient. His visual acuity was 20/20 N6 in both eyes. Anterior segment was unremarkable in both the eyes, and his fundus examination was also normal. There was no torsion in both eyes. Unfortunately, I don't have an image right now. So in the external examination, we noted that he had an exotropia of 70 prism diopters on MKT in the primary gaze. And the right eye limitation, there was a adduction limitation of -5, and the rest of the motility was normal. And the left eye, there was an abduction limitation of -1, and rest of the motility was normal. So what did we do next? We went ahead and got an MRI orbit with quasi-coronal cuts to look at the extraocular muscle pathways before we plan any kind of surgical intervention for this patient. And this is what we saw. So as you can see here in the T1 weighted sequences, there is encapsulated mass which is abutting the right globe. It is hyperintense on T1 and hypointense on T2, and taking up contrast and very clearly seen in the quasi-coronal cuts. So what could this be? Now we had 2 questions. One is, what could this be? Is this an intramuscular hemangioma? Is this a choristoma? Could it be an isolated nerve sheath tumor? And our second question, what do we do now? So we took him up for right eye MR exploration with excision biopsy. So as we can see in the T1 weighted sequences here, the MR muscle cannot be appreciated separately from the mass, and this was what we saw intraoperatively as well. So it was, the medial rectus was found to be bulky along its entire length, and there was a mass that we could see, and there was no clear demarcation from the muscle tissue. We excised this and sent this for histopathological examination. And the HPE showed us on hematoxylin and eosin stain at 40x, we saw there was spindle to epithelioid to oval cells with no pattern. It was a patternless pattern, and there were bundles of atrophic muscles that we could see. And with a suspicion of spindle cell neoplasm, we went ahead and looked for multiple immune stains. It was CD34 positive, Desmond positive, actin positive, as well as positive for vimentin, which suggested that it was of mesenchymal origin. So we diagnosed it as a benign fibroblastic tumor. Now why is this case important? So one is that benign fibroblastic tumors have been reported, but they have been reported in the orbit, and there have been, as I have highlighted in the reference here, and they are supposed to be slow-growing tumors, and they have equal incidence in male and female. They may present with intracranial extension as well, even in the benign form. And very rarely, they can present with malignant transformation. And the treatment is, as in our case, complete surgical excision. But an isolated benign fibroblastic tumor in an ocular muscle has not been reported earlier. And this case also highlights the importance of imaging, especially when we're dealing with a case of complex or residual strabismus. Thank you.
That was really very interesting. But I was wondering whether you did the force duction tests and force generation tests.
Yes, the force duction test was done, sir. And MR was 4+ tight.
It was you couldn't adduct it, that meant. No. Okay, and obviously it wasn't generating any force either. No. You tested for that.
Yes. Unfortunately, he's still exotropia.
He's still exotropia.
So, yeah, we'll have to plan for it.
What's the next plan? Transposition or what?
Yes, that's what I was thinking, that we could plan for a transposition and probably go for the other.
So how long a piece of the medial rectus could you manage? You see, normally we don't reach right till behind. Yeah.
So the muscle was not, it was entirely bulky, so we got around,
distinguish the muscle with
cut whatever we could, it was cut and sent for, no, left it.
No, so would you be concerned that some tumor is left behind?
Both the earlier surgeries were on lateral rectus only.
Yes.
Yeah, it's little unusual. I know. But it's benign tumor, so maybe it's just sitting there, causing more and more tightness.
It is increasing in size also. Visual line?
No, it's like a medial rectus paresis because the muscle was completely flattened by that tumor, I guess. So it's like a atrophied yeah, it's actually a atrophied medial rectus completely.
There was no separate muscle fiber that was appreciated.
But muscle is not to be seen at all. So you have to treat it like a MR palsy at some point. Best of luck for the surgery. I don't want to. I'm just glad it is Sampada's case. That's all.
Thanks for the interesting case. Thank you. Now I would call upon Dr. Devanshi to present dealing with latent hypertropia in teleophthalmology.
Thank you so much for the introduction, ma'am. Just a correction, I'm still pursuing my PhD. I'm an optometrist by profession, and I'm here to present an interesting case of latent hyperopia. So going ahead with the case. So basically, uncorrected refractive errors tend to be the most common causes of the avoidable blindness, and among that, the spectacle dropouts in those cases of the uncorrected or undercorrected hyperopias are again a most common causes because of the adjustment issues to the spectacles. And in this era of the teleophthalmology, specifically the post-COVID situation where we have decreased the chair time, and in these cases there is more of false positive referrals occurring. So I came up with a case where we used a stenopic slit, and we found that it could be useful for both spherical as well as astigmatic correction finding out instead of other techniques or other specialty instruments usage. So it was a 20-year-old healthy female who complained of gradually diminished vision in both the eyes since 7 years of age, and it was done during a rural camp setup. So the patient had earlier checkup, was prescribed glasses but never worn them. So the current unneeded visual acuity was 624 and 36 in the other eye. Retinoscopic glow was fluctuating and very dull glow. The approximated value was +3 with -1 in one eye, and the other was +3 spherical. So the subjective acceptance had a varied response. The patient was basically not accepting the plus amount, and again if we would give that same undercorrected value, then the patient would again be and drop out with the spectacles. So we used a stenopic slit refraction. Why stenopic slit? Because it is always done under fogging, so it would manage both the issues of spherical correction as well as giving a proper cylindrical axis, and the prescription with the stenopic slit acceptance was 2.5 with 0.75 180, and the vision was 612, and the near vision was N6, and the other eye was 2.5 with 6.9 and N6. So the near vision N6 suggested that we are no more undercorrecting the patient. So instead of doing a cycloplegic refraction, which was not possible in the setup, so we went ahead with a Borish delayed fogging test and found that the previous acceptance with the stenopic slit, the results were comparable to that of the Borish delayed test, and so the case was further taken for the anterior and posterior segment evaluation and was discussed with the ophthalmologist in the teleconsultation. So the patient was given the adaptation before prescription, and the diagnosis was confirmed, and the refractive correction was prescribed. So coming to the discussion, with the development of the technologies and the digitalization, many tools are available. So the disadvantages that sometimes the dependency on those automated tools is happening, and because of which if these devices are not able to take in the rural camp setting, it becomes difficult to differentially diagnose, and there can be chances of false positive errors or false positive referrals at the tertiary eye care center. So in the primary camp setups and in the teleophthalmology setups, if these small little instruments are available, can be used and employed. And in this case, why Borish delayed was not done at the first go, because we need a reference objective prescription, but again here the retinoscopy was fluctuating. So the stenopic slit was the best option, even instead of a JCC, because where we need a reference cylinder to go ahead with the procedure. So to conclude my talk, the undercorrected refractive error if for a long time can lead to amblyopia. So our burden is to increase the vision screening for prevention, and for differential diagnosis, the available basic instruments and techniques can be used. And to go ahead, one more thing is that in these days, the newer companies are availing the remote refraction and other facilities, but again, you need a technician or some trained person to go ahead with it. So if we know the trial set better, utilize it in a better way, then it would be a good take. Thank you.
All I can say is the stenopic slit is, underused for sure. We keep talking about it at the postgraduate level. It's also shown at undergraduate level, as part of the exam. But beyond that, I don't see it being used much. I think it has a place, but it's usually neglected. What do you feel?
I use it. So I use it.
Good.
I have not used it. Anyway, but I would have gone for +1 or because he's already a 20-year-old, no? Immediately to give for a refraction of +3, you've given 2.5 based on that. You didn't try.
So if we would have undercorrected, then again there would be issues in the accommodation, and then patient would not be using it
I
because
think
of the asthenopic symptoms.
she has a bit of a ametropic amblyopia. So not very severe, but it's probably to start with, it's better to give a little closer to full correction. I think she's right in that. Only thing is, and once the vision improves, you can maybe undercut it.
So that is what was the thought on the first go, that if we would correct, I would correct it completely, then and then we can go ahead with the finding the other issues related to accommodation as well.
So this stenopic slit refraction was done by where? Teleophthalmologically? No.
So the optometrist was at a place, and then the consultation by the ophthalmologist who was situated in some other place.
So
basically optometrist was performing the things.
So ophthalmologist suggested stenopic slit.
No. What she means is, there was a specialist, and it was an optometrist who was physically there with the patient.
No, because Dr. Dhawat is a VR surgeon, and if he suggested, I will give him extra 5 claps.
Okay, done.
So it was a clue given by him that it could be either an accommodative spasm you need to find out, or you need to search about whether it is actually the amblyopic case or not.
Thanks, Devanshi, for that case. Now I would invite Dr. Siddharth to present the case, surgical outcome of inferior rectus transposition in type 1 DRS with hypertropia.
So I have a small case to present. This is a 25-year-old male who came to me with a right face turn with -4 abduction. It was at -5 abduction limits. In forced primary, the right esotropia was 30 prisms. His hypertropia was 6 to 8 prism diopters, and he had a small V pattern. These are the 9-gaze pictures. You can see there is almost nil abduction. This is there since childhood. So I made a diagnosis of esotropic Duane's retraction syndrome because I felt the head posture is out of proportion to the deviation. Now the surgery I did was I transposed the inferior rectus to the inferior border of the lateral rectus and did a Foster suture at 10 millimeters from insertion. And I also recessed the medial rectus by 5 millimeters. So post-operatively after 6 weeks, he is near ortho in his primary position and he has gained around 2 stations of abduction. So he is now -3 in abduction. Main thing was that he got relieved of his head posture and the hypertropia also was relieved. But he is left with a residual -1 limitation of depression in the right eye, but it is not causing any diplopia to him. A short literature search shows that SRT is chosen when there is a A pattern and there is more limitation of abduction in elevation. And IRT is chosen in patients where there is a V pattern or more limitation of abduction in depression. IRT may be a beneficial procedure for patients with preoperative hypertropia or intorsion requiring transposition procedures because SRT can lead to hypertropia. So if already there is a hypertropia, doing an SRT would probably exaggerate it. Thank you very much.
Well done.
Everything is crystal clear.
Literature is also proved it. Yeah, that's all.
Thank you.
Yes, but we don't think about inferior rectus as much as we do superior rectus. So I think that is also an option in some
I
cases.
think you have to pay attention to the vertical deviation
part,
in
yes.
abduction limitation. That's the carry-home message. Thank you very much. Inferior oblique, no, inferior rectus.
Inferior rectus.
Inferior rectus.
Instead of SRT, he did IRT.
So I just wanted to know the consensus. Can I ask? I just wanted to know the consensus is in case there was no vertical deviation, would you prefer transposition of two muscles or partial tendon versus just SRT or IRT? Can we discuss that?
Me?
There cannot be any consensus in Duane syndrome. Number one, because every case is different.
You have to imagine a case and present it.
Yeah, no, I think it's worth discussing when do we transpose, two muscles or partial tendon of superior inferior. When you want to pick only SRT.
So I think we have shifted from 2 muscle to 1 muscle. So I guess if you are going to do 1 muscle, you have enough literature backing you. So why should you do the second muscle? I mean, it doesn't give you any additional advantage.
Just the risk of creating a vertical.
Yes, that is there with only 1 muscle. There is definitely a risk of torsional as well as creating a superior. So he was lucky there was already a small vertical, so it could offset it.
In primary, like for pre-surgery, would you still pick doing one? one muscle SR.
There is a mic, Ramesh. There is one mic behind. No, there is one mic behind the photograph.
So I think that is correct. So you're not disinserting any muscle at all. So now my choice in such cases would be to do a belly transfer. And sometimes I do only a inferior belly transfer rather than doing an IRT or an SIT. So I think that also we can think about as an option.
So have you?
Belly transfers and they do very well.
So have you moved away from transpositions to only Nishidas?
No, I have not moved away. All options are there for us. I believe that we should choose them at our own volition, whichever we feel is best suited. For example, here as we are talking, when there is a vertical deviation, we may choose an SRT. One reason of SRT doing is that it's simpler than a belly transfer. Second is you don't require a non-absorbable suture. Sometimes if you are thinking about the added cost, then one may think about doing just a belly SRT because it can serve the same vital which we are using. So I'm just telling you from the private practice point of view, sometimes even that is an option that you can choose. Okay, why add cost of the patient? You can just do it. But if you have that, belly transfer is a very good procedure. It gives you good control on the abduction and probably that's one. Yes, Ramesh?
If I may share a case where there was an exo-DRS with, I did a lateral rectus deactivation and SRT to LR with Foster's. There was initial hypertropia which resolved in 6 weeks. So does that happen frequently?
After, say again, what happened?
The initial post-op period there is hypertropia and within 6 weeks it came back down.
I always see in cases of SRT done that there is some vertical deviation. Even in the published reports of the other authors, you can see in the pictures, there is a little vertical deviation.
Do you feel it comes back down after some time?
I think have to follow them. I don't know so much of.
I think initially it happens, but you follow them long enough.
Yeah, in all cases of Duane syndrome with abduction limitation, I do superior rectus transposition unless there is a significant retraction, which I don't do. I would do only medial rectus recession. Having said that, if you had exactly said A pattern or V pattern, if there is vertical imbalance, then you can do a superior rectus and inferior rectus. 90% of the cases I do superior rectus transposition without belly transfer. I do SRT with Foster augmentation in all the patients. In the literature already there are more than 100 cases published. The fear of having intorsion or vertical deviation is never zero. It's around 8 to 10%. It can still have. Personally, I did not have any patients who had vertical or torsional problem. But as Dr. Sharma said, on the abducted position, if you see, post-operative, you will see a little bit of vertical deviation. You can always 100% hyper in superior rectus transposition. Hypo.
I have noticed a bit of hypotropia in SRTs which I have done in attempted abduction position.
Yeah.
So I mean, I was like very surprised, but that's what I had seen.
But literature says that you can get hypo or hyper, but hyper is more common.
Common. And also, what is the gradation or a change is what you do with the medial rectus recession. You do SRT, but medial rectus recession is the culprit there. Even in your case, you can see a adduction limitation now.
Yeah.
Smaller the dose, it's better. Homeopathic dose of medial rectus recession is better. This is one thing I have learned over a period of time. I used to do even 5.5 of recession. I don't do any more than 4.5 now for the medial rectus. That's one thing we have learned over a period of time.
What is the effect size you get with your SRTs?
15 prism diopters to 20 prisms.
And in case you are stuck with hypertropia, then what do you do?
Stuck with hypo?
Hyper. Then what do you do? You go back and release the Fosters?
You have to release the Foster because
So
that is called...
I rarely have put a Foster's into ones. Because whenever I put a Foster's, that there is, I find an increasing chance of a vertical deviation.
What is the effect size you get?
So just by an SRT, I would say 15 to 18 prisms. And I add that, if I want to add that with a medial rectus recession, again, as Ramesh says, I mean, my upper limits would be 4.5 to 5 for MR recessions. I would get a fairly good, up to 30 plus prisms.
So whenever you have put, I mean, you have not put Foster's, but...
I have put, in fact, I used to put...
But then what is the effect size like that?
So the effect size was more, but I found a bit of hypotropia in these patients. So that's
And
why
that's,
I have...
and that's why I said there cannot be any consensus.
And here
So
sir,
let's
in this
move,
case-
let's
in this
move on
case,
for the sake of
adduction,
time.
Just last. In this case, the adduction limitation, is it because of Foster's or because of the medial rectus?
It's because of the medial
Some
rectus.
because of medial rectus.
Because irrespective of your SRT you get, and the reason is that actually it's a peritic medial rectus. Peritic is defined by less than normal innervation. Medial rectus is getting less than normal innervation because part of the innervation has gone to the lateral rectus. So more the retraction, more the abnormal MR or more the hypoperforming MR, the more weakening you do in a weakened muscle, the more adduction deficit you will get.
So in addition also the effect of the paradoxic medial rectus.
Yeah, that is of course.
Because the main thing
Yeah.
is in doing
And exactly, the more you do, the more.
That's the reason when you are not tightening the lateral rectus and only weakening the medial rectus, you are inviting iatrogenic synergistic divergence.
Most of these patients turn from type 1 to type 2.
Yeah.
If you only do recession.
Yes.
Thank you.
I think we'll move on the last case. Thanks, Dr. Siddharth. Now I would invite Dr. Isha to present the case on one oblivious slipped muscle and eye swings over.
Good afternoon. I have a curious case here which has taught us many lessons in our last 6 months. Okay. I'm so sorry. I will take this time to thank you all for taking out time for me and my mentor, Dr. Deepti Joshi. So a 6-year-old female presented to our OPD with 40 PD incompetent exotropia and a 15 PD hypertropia. Her vision in both eyes was comparable with 6/12 parts in left eye and 6/6 in right eye and a -2 adduction restriction in right eye. She was stereo blind. The parents reported that the squint was there since last 3 years. But was it always like this? We went into the history and we asked for a few old photographs. So this was at the age of 4 years, this at the age of 3 years, but Aadhaar card tells a totally different story. The child has a clear large angle infantile esotropia, and on further inquiry, the mother revealed that there is history of previous surgery in both eyes for esotropia done at a peripheral camp at the age of 2 years. So what could have gone wrong? Either there was overcorrection leading to a consecutive exotropia, or that it was a sensory exotropia due to amblyopia, but as I stated before, both eyes have comparable vision, or it could be a slipped medial rectus muscle post-surgery for esotropia. So we went and we took the child under GA to manage the case with the intent of advancing the MR, because we assumed that it must have been a bilateral medial rectus recession. So with the intent to advance the MR and to tackle the hypertropia with the IR plication, we took the child for surgery, and this is what we found on table. Can you play the video? Can you please click on the video? The previous one. Can you play this video, please? Yeah, so we tried hooking the MR muscle, and this is the sheath of medial rectus which is visible. As you can see, there are no muscle fibers visible inside the sheath. So this was a case of slipped muscle. We opened the sheath and we tried to see if there are any fibers that we can trace and reattach the muscle. But we could not find any fibers at all. So we detached the muscle sheath. Can you please play this video? And this is our remnants of the muscle sheath. We tried tugging, we tried looking for oculocardiac reflex, but there was no muscle to be found. So finally, on table we decided, since the eye was in hypertropia, we would like to transpose, we would like to do an asymmetrical transposition of the inferior rectus to the assumed site of medial rectus insertion. So we took the inferior rectus bites and we freed the muscle and transposed it to the site of assumed medial rectus insertion. And so this was our 1 month post-operative result. We were very happy with these results because there was only a 10 PD residual exotropia with a 5 PD of residual hypertropia. So where did we get this idea? We got this idea of asymmetrical vertical rectus transposition from these articles which were there on muscle palsies. Can we do the same for missed muscles also? So we tried that in this case. And since the lesson we learned was there is no fixed course of events for a muscle to slip. In this child, the muscle slipped maybe after 2-3 years of the surgery, and the exotropia increased over time. Also, what we missed out was to do a dynamic MRI before the surgery to look for any signs of slipped muscle. And I wanted to end my discussion here, previously when I submitted this case for this conference, but the child came with a surprise 2 days earlier when we came here. This was pre-operatively, this was at 1 month, and this was 2 days back. So we learned another hard lesson, that an asymmetric transposition may not be the best choice for a missed muscle where there are no mechanical factors restricting the eye from moving up. So this was 2 days back at 6 months of post-operative age, where we ended up with a 35 PD hypertropia, although the exotropia was within the same range, 15 to 20 prism diopters. And that is, I'm open to the discussion at what would be the next step for this case. Thank you.
Yeah, this is very interesting, but I'll tell you, rationally, asymmetrical surgeries not leading to asymmetrical results it's always a wonder why superior rectus doesn't really cause the problem then. I mean, the evidence is there, I agree. Or an isolated inferior rectus transposition, one gets away with it. Yes, the rationale should be that it should be a symmetrical surgeries to get symmetrical results. Yes, if you don't want the eye to go up and down, then it is better to do, I think, more symmetrical surgery.
We already had the hypertropia in the pre-operative, during the first surgery. Yes. So we thought the asymmetrical surgery will bring down the hypertropia, because the IR will pull the eyeball down when we transpose it to the MR.
But you weaken the inferior rectus. That's the one which pulls it down. It's more likely to float up again.
Yeah. But it floated up again.
It was already floating up before.
Yes, sir.
Yeah. I would think so. I would think. Yeah. Go ahead, Shailja.
Photograph looks like there is an inferior depression limitation now, the current photograph.
There is.
So could it be that the IR has slipped now? Just
I know.
Bad luck for the child, but looks like that.
Yes.
Slow.
That's a good possibility because IR more often tends to slip. This is a common observation of a progressive over-recession of IR, especially in thyroid cases. The reason given is many, but one of the most plausible reasons to my mind is that because of the Bell's phenomenon. Whenever we are sleeping, at that time it's the rollover effect of the eyes, and each time the IR is under stress. So in the initial phase of the sutures not having been strong enough or the fusion haven't happened, at that time it may tense. So that's a possibility.
One way of preventing this could be to use a permanent suture.
No,
especially when you're dealing with inferior rectus.
4 weeks or 5 weeks the sutures are there. After the sutures
it, can we prevent it by using a permanent suture? Like,
I think that's what some people have been saying. From Israel, I got the same, I think, yeah, Quran. So he keeps insisting that he uses proline sutures for medial rectus.
not medial, probably for inferior, I think
No,
it's.
for inferior rectus, several people have used non-absorbable sutures. For inferior rectus, yes, of course, it's the common
Yeah.
practice to use, especially in
Thyroid cases, yes.
non-absorbable. Yes.
Just a question. Couple of questions. Was it only the right eye MR which was explored or both the eyes?
Only the right eye MR, because the left eye was the fixating eye. There was no adduction limitation in the left eye, so we did not open the left eye.
Was there a pre of ASOCT or an MRI orbit? Because
No, we did not do a pre.
It was a ET which has gone on for the next.
Yeah, we just went in for the surgery. We did not do a dynamic MRI pre-operatively.
The IR transposition, was it with a foster or without
I'm
a
sorry.
foster?
It was without a foster. With a foster, sorry, with a foster.
Yeah, Sandra.
Lost MR or split MR, I have done a nasal Nishida, so similar to what Sharma sir was saying.
Yeah.
It works pretty well.
Pretty well,
And it doesn't cause like maybe this kind of side effects. So even I was doing a lot of SRTs before, but in most of the cases, even if there is not a primary position deviation post-operatively, I do note that there is an elevation limitation. There is like -1 or -2 elevation limitation. So now I have gone back to doing Nishida or partial VRT with augmentation.
Yeah.
So that way there is no vertical forces created.
So, but both the muscles.
Yes, both the muscles like partial VRT with augmentation.
You may do asymmetric belly transfers if there is an existing
Pre, yeah, but this case where you are adding a adducting force, probably a bilateral surgery would work better. I mean, by both inferior and superior.
No, but here she is saying that in this there are preoperative hypertropia.
Hypertrophy. Yes, ma'am.
Was there any DVD component to that?
No, ma'am.
Hypertrophy? No.
Preoperative hypertropia was there, and there is a foster suture for the IR which was transposed here.
Okay.
Initially there was 15 PD hypertropia, but over a period of 6 months, now she went into 35 PD of hypertropia. So
But there was no DVD-like thing.
there was
in
no
that.
DVD-like component.
Because of course she has adduction limitation also, but abduction and hypertropia in a post bimedial recession, sometimes that is also a possibility. And only one other suggestion, you could have done a ASOCT to see if, to see how far back is the medial rectus. Not a very perfect modality for a very small child, but you could have tried.
Yes. Ma'am, but one question, what could be the next step of management in this case?
Explore again.
Maybe now they should do an anterior segment OCT.
Yeah.
So,
Thank you. Thank you.
so we come to this end of this interesting session. Thanks speakers and thanks panelists for their opinion.
Thank you for all the presenters. Good job.
Hello, good afternoon. I'm Dr. Anupma. I'll be moderator for the video session. So without wasting much time, I would like to call Dr. Satya Ravila for her presentation.
Patients that can make an eye exam a
Thank you for this opportunity.
Yeah. No panelist in this. I don't know why.
Which one?
No, audience is discussant. So everybody can ask the question.
Yeah, so the video is... so this is after all those fancy surgeries, is a compilation of kind of crude innovations just still in process, but just sharing the ideas here. And a big thanks to Jitani sir. So through all of these innovations, I've been also eating his brain and asking him. The audio isn't playing. Can you play it from the beginning, please? From the beginning. Play it from the beginning.
Reality Innovations that can make an eye exam a Disney experience. The authors have no financial interest to disclose. Pediatric ophthalmology over expectations. Reality. Yes, even the basic torchlight examination can be a nightmare for the child and the examiner. The normal torchlights are bright and can be quite disturbing. Here is a do-it-yourself innovation from very basic items. Colorful pictures are painted on translucent paper and pinned onto a stiff sheet. A plastic bottle is cut to fit on the torchlight with a slit for the pictures. This simple adaptation not only reduces the photophobia but has them fixed longer, allowing for better ocular examination. But more importantly, you now have a super cooperative patient. For a thorough slit lamp evaluation, simple, colorful fridge magnets are the solution. As the magnets can be moved, it helps to keep their eyes steady in any position, be it for a fundus evaluation or a suture removal or to evaluate the upper tarsus. 2 pairs of magnets are needed for a slit lamp, and this costs less than 20 rupees and can be interchanged. Any examination in a dark room can be scary. These cost-effective projector watches gives them something to fix and helps keep their eyes steady in the desired directions. The cartoons can also be varied and helps distract them from the darkness. It is cumbersome to hold prisms in the eye away from you, and we often ask for an assistant or sometimes even involve the patient. This 3D printed device has been designed to hold prisms and can be attached onto a spectacle frame or be held by the examiner. We have found that the prisms are stable, the prisms can be stacked, can be easily exchanged, and this fits on most frames. During squint evaluation, measurement in up and down gaze results are often varied as patient tends to change head position. This could affect surgical results. Hence, we created a head holding device which is adjustable, gives great support, which can hold the near vision target at exactly 33 centimeters, helping to standardize squint evaluation. It also has a protractor on the side so that we can know the degree of neck flexion and extension, and the results can now be reliable. Night gaze measurements is now made easy and accurate. These simple innovations make a world of difference in our day-to-day examination and indirectly to a child's life. Thank you. Innovations that can make an eye exam a
Thank you so much,
Disney
Dr.
experience.
Satya. I would like to ask you one question, whether you have some modification for the retinoscopy also, like how you keep child engaged during retinoscopy?
No, we haven't.
No, you don't
we
have,
haven't
right?
done that.
Okay. Anybody in the audience would like to ask question or any suggestion for the pediatric setup changes, like where we can keep our patient engaged or entertained while doing examination? Anybody has any suggestion? Yeah, sir.
No suggestions. The projector. We still haven't figured out how to fix it onto the table. Right now we have somebody, I think we're looking at how to make it hand-free also.
Fantastic video. I don't have any suggestions, but I would like to know if there's a way to reduce the experience of the cycloplegic part of examination. I think if there are any innovations from anybody here, anything that you could recommend.
Shruti, I usually put Paracaine before starting the cycloplegic examination. Second, I mix the drops. So I mix cyclopentolate with the tropicamide. So your one drop is like reduced. So you put Paracaine. After Paracaine, like couple of minutes later, I put a mixture, cyclotropica, Then again 5 minutes later, again a mixture. So mostly it is quite comfortable for the kid. Like if the kid is otherwise not fussy, the stinging and burning part can be taken care of. Then we can keep them entertained by giving some toys in the waiting area. That's all we all are doing, I suppose so.
A smiling child becomes the one who loathes you by the time
True,
you
true.
finish the cycloplegic fun.
I am CTC, still CTC fan. No, home atropine for home, sir, and the kids with the CP or the kids with the prematurity, where we have a risk of crossing the blood-brain barrier. Rest of the kids. No, sir, no, sir. Like, why would? Why would? You don't. At all. Is it? No, sir. So, but like till 5 now, kids are active. Like, sir, dilatation is for.
It's quicker by about 10 minutes. And I feel that it gives more cyclopedia by about 0.2 in my patient.
More stronger. And yeah, that is. Yeah, because sometimes in clinic our staff is putting the drops. So sometimes instead of 2 drops they can put 3 times. No, cyclopentolate creates problem. That is true.
I do want to contribute here. There is a
Sir,
trick.
can we take this discussion to the tea time or something else? Thank you so much, Dr. Satya, for such a wonderful presentation. Now I would like to call next speaker, Dr. Gitanjali, for Saga of Progressing Iris Cyst.
Just a small pointer, all these torches which are LED are very bright, so you put the old cells in them. And secondly, suppose you get a bright torch, put 2 fingers in front. But the moment you shine a torch, they are blinded for the next 5 minutes.
We just wanted to add that I made it a little brighter for the video's sake also. But yes, I do agree.
Good evening, everyone. I thank Team POSN for giving me this opportunity. Can you play the video, please?
A 2-year-old girl presented with history of redness, watering and photophobia in the left eye of 1 month duration. Her left eye showed translucent walled cystic lesion in the inferior part of the anterior chamber pressing on the iris. There was pigment dispersion on the surface and the pupil was pushed superiorly. ASOCT showed clear cyst with thin walls touching the cornea inferiorly. Cyst measured 5.3 by 6.2 millimeters and the gonioscopy showed open angles in all quadrants and the intraocular pressure was normal in both the eyes. The differential pachymetry showed increased corneal thickness inferiorly due to endothelial decompensation. The imaging of brain and orbits was normal and the blood workup was negative for any infections and hence diagnosed as primary iris stromal cyst and managed conservatively. On follow-up, after 6 weeks, there was progression in size of the cyst and hence planned for surgical excision. Side ports were made at 3 and 8 clock hours, ensuring no damage to the cyst wall. A cohesive viscoelastic was injected to separate the anterior wall of the cyst from the cornea and the adhesions released with the repositor. A vitrectomy cutter was used to remove the anterior wall and contents of the cyst. separated from the angles with a repositor. The viscoelastic was removed with bimanual irrigation and aspiration. As the posterior pigment epithelium was released from the anterior lens capsule, the pupil returned to its normal position and the wounds sutured. A month later, eye was quiet, cornea showed mild inferior haziness, and there was remnants of posterior iris pigments on the anterior lens capsule. ASOCT showed thick iris inferiorly, and there was persistence of increased corneal thickness inferiorly. Iris cyst can be primary, either involving the pigment epithelium or stroma. The secondary causes of the iris cyst include post-trauma and surgery due to intraocular tumors such as medulloepithelioma and iris melanoma. Could be induced by miotics or prostaglandin analogues. Primary iris cysts are epithelial-line structures thought to be remnants of marginal sinus of iris or entrapped surface ectoderm. Pigment epithelial cysts are most common childhood iris cysts. However, the stromal cysts are aggressive and require aspiration or excision.
The story is not over yet. 2 weeks back, the child came back. This time, there was a cyst behind the iris, and I want the opinion from the seniors and the colleagues what to do next.
So it's a difficult case to because if you go through literature,
yes,
most of the cysts will come back. So I struggled with 2 cases and it came back. In third case, I did absolute alcohol injection. So you put a 3-way valve and you get a 30 gauge needle inside the cyst. You aspirate the cyst through the same, change the valve position, put absolute alcohol, keep it for 1 minute, aspirate the alcohol, put saline, wash it, bring it back, never comes back.
So, but this is, it's behind the iris now. We cannot visualize. Only UV. I'm sorry, I don't have the images, but
I understand it's behind the iris, I agree, but it makes it more difficult, but it is still not impossible. You have OCT, no?
Yes.
So you can see and go through inside.
Okay.
And then you can do the aspiration and injection.
Yeah.
Pardon?
Okay.
So
yeah. There is no
even if
cataract as of
right now there is no cataract,
yes,
but this cyst is going to grow. You are going to land up in big trouble. Cataract you can treat, but the larger this cyst becomes, a bigger problem it is. Because even if you excise that section of the iris, even if you excise that section of the ciliary body, it still comes back. So what you should have done after you have eaten it up, you should have cryoed the base.
Okay.
Probably that would have prevented it from coming back. Okay. If you had have burned that base, then probably it would have not come back. But the sure shot solution in literature, where most of the cases have responded, I think it's published by Shields actually, that when you inject alcohol and it will collapse, it will not come back.
Many of these cysts remain static. So it is also a good idea to just observe them. It is a very good idea. I have had children who I have observed for 10 odd years without the cyst having increased vision remaining 618. Whereas sometimes this alcohol injection can cause in the 618 patient corneal scarring, vision can drop down to counting finger from 618. Sometimes it can happen. So it's a good idea to leave these cysts alone unless you see progression, definite progression. Maybe a good idea in children.
there was progress.
So quick thing, I have experience with both alcohol and cauterization. So I have 2 cases which I had very small cysts which we observed, like I've observed it, not done anything to it, but they were primarily cases which did not have any trauma. Whereas the other 3 cases rather, I had trauma which had a corneal tear and had come with a cataract, and later on of course developed an iris cyst. First time when I went and I just aspirated, did not put alcohol for that case. That case remained okay for 6 months and got a cyst again. They come back again to you. So as she said, I had done alcohol for 1 case which did not work so well for me, and that cyst reappeared but after 1 year. So that was 1 case. What I learned from that case was that this did not work. in between, I had another case which had come again with the iris cyst with a trauma. Similar case. This was a larger cyst. So this time, for the first time, I went, aspirated it, and second time when again it reappeared, I directly cauterized it. So you aspirate, you go inside with the endocautery, and you cauterize the lining over there. So the one which I had, which did with alcohol, and later on which I again went, I cauterized it. And those both cases which I have gone inside and cauterized, I don't have the cyst coming up for last 2 years for both the children. So it has not come up. But whatever came up in 6 months to 1 year. And they come larger, they become bigger than what they are. I mean, that's just an experience which I had.
Thank you, Dr. Geetanjali. Now I would like to call next presenter, Dr. Jaspreet Sukhija, for his presentation.
Voiceover. Just pause it. So there's no voiceover here. Can you just go back? So what I'll be discussing here is how we treated this child with ectopia lentis. Obviously, most of them would require a lensectomy, a simple ectopia lentis with something new in the armamentarium what we've got. So the plan was to implant, to do a scleral fixated IOL. So of course, you are making a sclerotomies, and after marking a 180 degrees and raising these flaps, this partial thickness scleral flaps. Because it's the first thing what we have to do when you are planning a lens matter aspiration, when you intend to do a scleral fixated lens. So after making these ports, what we're doing it like a routine cataract surgery. I mean, the capsulorhexis is a little difficult because the capsule does not behave in a normal way as it should be. It's a little difficult to do a rhexis. But if you can, I mean, do a rhexis, take out the lens matter which by the bimanual irrigation aspiration. And once you've done that, then you remove the bag with a cutter. And while doing this, probably some of the anterior vitreous also comes in the way. It's good to clear the anterior vitreous. So basically, we've removed the lens, and our plan is to implant an IOL. So the IOL what we've used is not a basically scleral fixated. So we've gone inside first, made the ports. And so this is what we've used. So this is a T-flex IOL what basically, and it has these two haptics like in the shape of a T. It's a hydrophilic acrylic. Can you go back a little bit? I'm slower than, so anyway, okay, fine. So basically in the form of a T, it's a 6 millimeter and 13.7 millimeters. So it's a foldable IOL, and you don't have to enlarge the incision. So just like you have a 3-piece foldable IOL. So once you've done that, probably what you have to do is again use like a handshake technique. So with at one of the ports with the max grip forceps, you would have to hold the T of the haptic. So the T has to be held very firmly, because there are chances that you might slip or you might break it. So once the T is coming out, as you see, it's held with the forceps, and then gradually you're pushing the IOL inside and pulling the T outside. So through a small incision, we're able to pull the T and get it out through the scleral flap. This step has to be a little careful because sometimes it happens that you might break it. Obviously, my experience is limited, so maybe. So that's the T. So you can see here how, I mean, it's basically just fixed outside the scleral port. And similarly, on the other side, with the forceps, you bring the other part of the T outside, and that is it. And of course, you can put glue on the scleral flaps, or you can suture them, and that's the end of the surgery. So instead of using maybe scleral fixated lenses or doing a technique like a Yamane technique or things which are not very, I mean, probably not very successful in children, this is a reasonably good option at the moment. But yes, experience is limited with this, and probably will require maybe some studies for it to actually substantiate the role of this IOL. Thank you.
Sir, what is the youngest age when you
5
advise?
years.
5 years, the youngest age.
And it was hydrophilic.
Yes, hydrophilic acrylic, yes.
Yeah, Dr. Sukija.
There is a...
It's commercially available, it's made by Apaswamy. So they've used it in adults probably, they've done 9 or 10 cases probably, never used in children.
Yes,
so I thought maybe it's a good option. I mean, because what happens with Yamane is in children, because that sclera is elastic, there's a tilt of the IOL. So with this, it's such tightly nudged, I mean tightly fixed, the IOL probably won't move.
Yeah, Dr. Sukija, we have also tried and we have made our own Sharana scleral tuck lens which we have used in Marfan syndrome. So it works well. The only thing you have to take care of the end which is exposed, which can bring the infection. That's only. But we have done in last year only, we have done in 50 cases and it works very well.
So I would not probably do it in Marfan syndrome because obviously there's a lot of scleral thinning subprogress. So I would be careful, I mean, in those cases. But yes, people have done it. It's a good option, but over time, long follow-up would be required to know exactly the outcome of these. Pardon? No. No, I've eaten up the bag first. But one of your haptics is already out. Why would it go? You've held one of the haptic. But why do you want to so many gadgets inside? I mean, you can, when it's possible to do this way, I mean, there are numerous ways you can do it, increase the complexity as well. I mean, that's not, but whatever is best in your hands probably.
Sometimes what happens, suppose the remnants of the anterior capsule remains there, the posterior pigment epithelium grows over that anterior capsule.
What?
Sometimes after putting the lens, we can't go just behind the iris. It happens. So, because we can't cut the whole thing. So in that case, what I do is sometimes, like from the opposite angle, suppose the superior subluxation is there, after doing the intracapsular bag aspiration, at the opposite side, Grasbier forceps, we remove the whole bag in toto. So there will be no cutting, so there will be no vitreous.
Toto means you pull it out?
Yes.
So that is a risk factor, especially in case of Marfan syndrome. You might end up in a retinal detachment. So that should not be done. Absolutely no in patients of Marfan, and even otherwise. I did it in one case, but yes, I did read up the literature then, and this should not be done. The vitreous base, exactly. Yes.
Thank you so much, sir. Now I would like to call next speaker, Dr. Atul Sheth, for his talk, his video on surgical management of anti-elevator syndrome following pure IOAT interruption.
Good afternoon, everyone. Apologies for not having a voiceover. So, can you please start the video? I'd just like to describe a case of a 13-year-old female who was referred to me with a divergent squint. And yeah, can you please pause the video for 1 minute? Just a brief introduction that she had a history of a squint surgery for a childhood esotropia at the age of 4 years. I had access only to the operative notes, which showed that a right medial rectus recession and a right inferior oblique pure anterior positioning had been done. There were no pre-op clinical notes. Now, pure anterior positioning is a procedure where described by Professor Prem Prakash and his colleagues at RPC, prominent of them, Dr. Pradeep Sharma sir, who's here. It was described as a procedure where the inferior oblique was shifted to the lower border of the lateral rectus, and the cases which were presented, they showed that it had an elevation weakening without having a recession effect, and it did not have much effect on the intorsion. So with that brief introduction, this patient had a, yeah, play the video. Play the video, please. Vision of 6/12 in the right eye, and it revealed a 50 prism V pattern exotropia with a 20 prism incomitant right hypertropia. She demonstrated a -3 elevation deficit in all cases and a -1 adduction deficit. The left eye also showed an inferior oblique overaction. Both fundi were mildly extorted. So I made a diagnosis of a consecutive exotropia with an anti-elevator syndrome. I plan to do a right lateral rectus recession, a right medial rectus advancement, and I was to explore the inferior oblique. I was not very sure about what I'll do with the left inferior oblique at that point of time. So FDT revealed that there was a severe restriction of elevation in the right eye. After taking an inferotemporal fornix incision, when I tried to hook the lateral rectus from the lower pole, I found it a bit difficult. So I hooked the lateral rectus from the superior pole. After doing that, when I started searching, I realized that the inferior oblique had been placed ahead of the lateral rectus. That's not exactly how the pure anterior positioning is described. So, but after freeing it, I found that this was at anterior to the lower border of the lateral rectus, quite anterior. After freeing it, this is the, the pointer is not working, but this is the inferior oblique. You can see the hook holding the lateral rectus. And now this is the inferior oblique, which was being dissected out. In fact, I also found a mild amount of fat adherence at the posterior border. So if you see, this is almost ahead of the lateral rectus. After dissecting it out, I reattached it 8 millimeters below and behind, so which amounted to a 10 millimeter Fink's recession. At the end of the surgery, the elevation was freed, but there was still a mild restriction. Probably that was a result of the mild fat adherence that I noted. This is the posterior border, which I was just cleaning up. So now this is the whole inferior oblique. And along with this, I recessed the lateral rectus 8 millimeters. I advanced the medial rectus along with a small resection to 5.5 from the limbus. So end result was that I noticed that on day 1, I'll just show the post-op video. This is the inferior oblique at the Fink's, it's a Fink's recession. And for that was the lateral rectus. I have not shown the medial rectus advancement. Post-operatively, day 1, I had a flick hypotropia and still a -1 elevation deficit. At 1 month follow-up, it was 10 prism right exo with a -1 elevation deficit. Now probably, I did not do anything to the left inferior oblique, though it was overacting. I was a little wary about doing too many things in the same sitting. So my questions would be, could I have reattached the inferior oblique differently somewhere else? Should I have done the left inferior oblique weakening simultaneously at the same sitting? And I have not seen any of these pure anterior positioning cases because they are not done so often. So whoever would have an experience with this is one of the problems, but this was not a properly done the way it has been described. So the anti-elevation effect might have been because of the inferior oblique being placed too anteriorly. But for those who have seen this surgery and its probable problems, if they have any comments on it, because it's not done much. I think probably Pradeep Sharma sir would be able to enlighten us.
Firstly, this is not a pure anterior positioning at all. This is a total anterior positioning. This is just a little more temporally placed anterior positioning. So it's an IO80 which has been done, and as we know now that it definitely causes anti-elevation. So that would be the first remark that's there. But in such cases, when we get cases which have been operated, inferior obliques which have been operated and there is an anti-elevation, that is the right approach that you have to do an FDT. And especially when you ask the person to look up, that time the FDT will come positive because it's an anti-elevation. It's not, the inferior oblique is not becoming a depressor. The inferior oblique is still innervationally an elevator. So when you ask them to look up, at that time you do an FDT, you will feel a tug. So that's the first thing that you need to do an FDT, and if you find that is what is happening, you need to explore and disinsert the inferior oblique. Mostly I find that in such cases, if the inferior oblique is tight, I would do a Stager's procedure. That means get the inferior oblique on the nasal side and keep it 2 or 3 millimeters posterior to the inferior rectus, so that anti-elevation doesn't occur at all. So that is what I would have done. Secondly, I would also do the other eye, because that is definitely overacting, and unless we tackle that, and especially in children when we are doing under general anesthesia, we may try to do the inferior oblique in the other eye also. And as we see, it's a 3+, you may do a Stager's procedure.
Stages would have not left the hypotropia, a little bit of hypotropia that was still remaining probably.
Can I add something? I had a similar case. I think I'm presenting it tomorrow. So in this case, the patient had undergone a surgery for previous squint, right? It was a consecutive exotropia.
Yeah, only one eye medial rectus recession was done and one eye inferior oblique was done.
Just a thought, could it be that during the lateral rectus resection, the inferior oblique was dragged inadvertently and
There was no lateral rectus resection. This was an unoperated lateral rectus. Yeah.
Oh, only medial rectus.
I just hooked the lateral rectus in order to get to the inferior oblique, and I was a bit surprised because it was not where I was expecting it to be. I thought pure anterior positioning was written, but I did not expect it to be actually
That was something which happens sometimes. You may, drag the inferior oblique.
Yeah, but this was an unoperated lateral rectus.
So other thing is like, as sir said, I would have done the other eye also.
Because there was a bit of fat adherence, I was not very sure about what so I thought I'll probably do a stage procedure. So
and also, in which position was the maximum deviation? Was it in dextro elevation or, in the dextro elevation or lever elevation?
I don't think I had that in my records, but if you see the video, the elevation deficit was in all the gazes, it was almost similar, but of course, I don't think I would have the 9 gaze right now with me.
Then I think you did the right thing by putting it back.
I probably should have done the other eye, that is what and in retrospect, probably not doing a Finks and doing either putting it to the 0 position or this thing would have been better.
Below and lateral would be better. Thank you.
Thank you so much, sir. Thank you. Now I would like to call next speaker, Ankita Bisani, for her video about pseudo-iris cyst in the traumatic cataract. On there? Yeah, that's okay.
That's okay. So good afternoon, everyone. I'm Dr. Ankita Bisani from Arvind Eye Hospital, Chennai. So we'll play the video first.
It's not there. You would like to, Ankita, or should I call next speaker and then you can present later, yeah? Okay, now I call next speaker, Dr. Shilpa Solar Khan, for her presentation on the magic of simulation training. Dr. Shilpa. Please do the next one. She can come later sometime. I would like to thank POSN for giving me this opportunity. Here.
Strabismus surgery simulator offers ophthalmologists the most realistic hands-on experience in surgical training. It is a life-size 3D eyeball, and the replicated tissues like conjunctiva and muscle give a feel like operating on a real eye. One can learn basic recession and resection procedures as well as complex surgeries. Surgery on oblique muscles can also be performed. It can be practiced by mounting on a fixator and using eye speculum to understand the exact size and space constraint.
So see the center.
The recession of a muscle is demonstrated here. A fornical incision is taken and the tenons is separated. The muscle is hooked using the Jamison's hook. The overlying conjunctiva and tenons are separated using small hook. The muscle is held between two Jamison's hook, and the recession of muscle is done by taking the muscle bites using 6-0 vicryl suture. Similar bites are taken on both the sides, consisting of partial thickness and full thickness blocking bites. The muscle is cut at the insertion. The muscle stump is held using the fixation forceps. The recession point is marked on sclera. The scleral bites are taken and the muscle is recessed at the desired point. Similarly, for resection, a conjunctival incision is marked in the fornix. The conjunctiva and tenons are separated to see the bare sclera. The muscle is hooked using Jamison's hook. The desired resection is marked over the muscle. A 6-0 vicryl double-armed suture is used to take the muscle bites. Partial thickness and full thickness muscle bites are taken on both the sides. The remaining muscle is cut from the insertion. Moody's fixation forceps are placed at the muscle stump. The muscle is brought anteriorly towards the insertion and resected. The conjunctiva can be closed using 8-0 vicryl suture. Studies have shown the many benefits of practicing surgery on simulator. Practicing surgery on simulator improves outcomes and patient safety through reduced errors, improved precision and shortened procedure time. It improves your skill set, hand-eye coordination and gives ample opportunities for improvisation and discussion between trainer and trainee.
Thank you. Yeah. So basically the cost of making the mold, 3D printing and designing was difficult
for me, but now it is, you know, on the production. Right now it's costing me 1200 rupees per unit. 1200 rupees per unit, but if it's for mass production, obviously the cost of the unit will come down. Thank you, sir.
Yeah, thank you so much. Thank you. Now again I am calling Dr. Ankita. Ankita, is your ready? No. Okay, so I am calling next speaker, Dr. Sandra, for her presentation on traumatic cataract with the dialysis. Yeah, traumatic cataract with the dialysis, CTR and IOL implantation techniques.
So I am going to show a video on traumatic cataract with dialysis.
Thanks for the opportunity. Could you place the video, please? So this is a child who came with a traumatic cataract with a zonular dialysis of around 3 clock hours. So it would be a bit of benefit to juniors where CTR can be applied.
I am going to show a video.
And you can be safe, and in a larger dialysis, of course, you would need to go for a...
So what is the CTR? It is a flex. So I am going to show a video on trauma.
It's shown here. There is audio also.
CTR and IOL implantation technique. So what is the CTR? It is a flexible C-shaped device made up of PMMA which exerts outward force at the capsular bag equator. It helps to distribute the forces and helps to support the areas of zonular loss, and very useful in trauma with the focal zonular loss. So a CTR can be inserted at any time during the cataract surgery after the rhexis has been created, but it does require an intact and strong capsular rhexis as well as an intact posterior capsule. Placing the CTR at the beginning of the case can provide an additional stability during nucleus removal, but it can make cortex removal more difficult because it traps it at the capsular bag equator. For this reason, the common saying is to place the CTR as soon as you need it, but as late as possible. The best candidate for a standalone standard capsular tension ring is a patient who has a mild diffuse zonular weakness or focal zonular weakness extending fewer than 3 to 4 clock hours. When not to implant, if there is more than 4 clock hours of zonular loss or progressive zonulopathy, such cases require endocapsular devices which can be scleral fixated like the modified CTR or a CTS. So this is a video of a child with a traumatic cataract. You can see that there is a focal area of zonular loss in the nasal quadrants around 3 clock hours, and this is a scleral tunnel which is being done. You can see the 2 side posts being created here. I am staining the capsule so that the capsule becomes less elastic and it will be easier to fashion a rhexis. This is the initiation of the rhexis away from the area of zonular laxity, and the rhexis can be completed with the help of when needed forceps, but the thing to remember is that it should be of adequate size and centration. It is very difficult to enlarge the size of the rhexis in a case of CTR implantation. Hence, initially only it is very important to make the rhexis of the correct size. So after rhexis, CTR is being inserted from the side port. So I am planning to insert the CTR before aspiration of cortex to aid in better stability. So you can see the CTR going in, and to finally put it inside the bag, I am using a two-handed technique with 2 Sinski hooks to hold and direct it within the bag. So then a mild hydrodissection is being done to loosen the cortex. Cortex aspiration will be a little difficult once the CTR is in place. So you can see that now most of the cortex is being aspirated with the coaxial irrigation aspiration cannula, but now I can have a little difficulty here while aspirating the superior cortex. So I decide to go in. You can see there's a lot of force needed there. The cortex is really caught within the CTR. That's why I decide to use the Simcoe to go in nicely and catch the cortical material, and is being pulled out gently. And it's very important not to create additional zonular weakness at this stage by pulling on the bag or pulling too much. So now the most of the cortex has been aspirated, and I'm injecting a 3-piece IOL from the scleral tunnel. And why using a 3-piece is, if in case there is something wrong, there will be a plan B which is possible, where a single piece is going to decenter. So I am flexing the haptic and putting it inside, and this is a technique which I really like. If you want to dial it inside, it's going to use a lot of force, whereas by just holding the haptic at the correct place and then slowly you just nudge it inside and it goes within the bag very easily. So I am very comfortable with this particular technique. Side ports are being hydrated, swept with a spatula to rule out the presence of any vitreous. In the end, you can see the very nice centration of the IOL within the bag with the CTR in place, and the patient had very good visual recovery. Thank you.
Thank you. Thank you, Dr. Sandra. Very nice presentation. Now I would like.
Instead of using the CTRing from the beginning, first we use the capsular tension hook. So by hooking only that segment, then we remove the cortex, and then implanting the CTR would be a good option instead of from the beginning.
Yes, I have a small thing that, so if you use only the hooks, sometimes while doing the IEA, the back can move forward and that could be a posterior capsular end. But if you can put a CTR, it is stretched and it would not come in the way of irrigation aspiration.
Our children are becoming more myopic today and at an earlier age. Their eyes grow longer and more quickly than they should, resulting in a blurry image. This phenomenon, called myopia progression, may lead to higher myopia. Standard ophthalmic lenses provide clear vision by correcting myopia. However, they cannot control the eye elongation and therefore do not prevent myopia from worsening. Essilor now revolutionizes this state of fact and unveils the Stellest lens. The Stellest lens creates a signal into the eye that acts as a shield against eye elongation and therefore effectively slows down myopia progression. Clinical studies on children showed that compared to single vision lenses, Essilor Stellest lenses slow down myopia progression by 67% on average when worn 12 hours a day. How? By using the HALT technology and its constellation of 1021 invisible lenslets, guaranteeing clear vision and myopia control with no compromises.
Either CTR or otherwise simply scleral fixation or the iris fixation.
Okay.
Our children are becoming more myopic today and at an earlier age.
We don't
Their
have
eyes
time.
grow longer
Sorry,
and
Dr.
more
Siddharth,
quickly
we'll
than
not
they
be able to
should,
take questions.
resulting
I
in
would
a
like
blurry
to call.
image.
Thank you, Dr. Sandra. I'm sorry if
This phenomenon called
discuss in the
myopia
tea break.
progression may lead to high myopia.
I would like to call next
Standard
speaker,
ophthalmic lenses provide
Dr.
clear
Divya
vision
Natarajan, for
by
her
correcting
presentation.
myopia. However, they cannot control the eye
Her topic is
elongation
how to be
and
sure in
therefore do not
nystagmus,
prevent
EMR, a
myopia from worsening.
useful clinical tool. Thank you, Dr. Divya.
Essilor now revolutionizes this state of fact and unveils the Stellest lens.
Importance
The
of eye
Stellest lens
mobility
creates
recording in diagnosing many cases of nystagmus. Nystagmus is the rhythmic, involuntary biphasic oscillations of one or both eyes. It may occur physiologically or it can be pathologic. The typical pathologic feature in nystagmus is the presence of a slow phase in one or both directions. Eye movement recording technology helps in identification of various types of nystagmus and thus helps in the evaluation and management of neurologic and ophthalmic disorders. It is a non-contact optical device that uses infrared light reflected from the eye, which is sensed by specifically designed optical sensors. Here is an 8-year-old boy with high myopia in both eyes with infantile onset nystagmus. On binocular viewing, there is a small amplitude nystagmus seen mainly in the left eye. There is also a latent component that can be noted. Here is a 6-year-old girl, a known case of bilateral retinopathy of prematurity and aphakia post-congenital cataract, who has a left beating jerk nystagmus in primary gaze. Latent component is also seen to be present. However, on occlusion of the left eye, it is difficult to identify the direction of nystagmus. It can be presumed that this is an infantile nystagmus syndrome. However, eye motility recording shows a jerky nystagmus with linear and decelerating waveforms. Thus, the diagnosis is confirmed as fusion maldevelopment nystagmus syndrome or FMNS. This is a 12-year-old boy who was adopting a predominantly right head turn while reading. Occasionally, he was also noted to be changing it to a left face turn, but it was not a consistent feature. Eye motility recording shows linear velocity jerky right beating nystagmus that was changing to left beating over a period of 3 minutes. Spontaneous change in the direction of fast face along with change in the direction of head posture is the classical sign of periodic alternating nystagmus, also known as PAN. Hence, examination for 3 to 5 minutes is a must to rule out PAN. This case was diagnosed to be periodic alternating nystagmus with infantile waveforms. Here is a 20-year-old male who presented with increasing symptoms of poor vision. Clinically, there is a multiplanar nystagmus along with exotropia and dissociative vertical deviations. There was optic disc pallor in both eyes with thinning noted on optical coherence tomography images. Eye motility recording shows multiplanar disconjugate nystagmus with infantile waveforms. This goes in favor of spasmus Newton syndrome, where one must rule out optic nerve glioma. Here is a 33-year-old female with complaints of oscillopsia and difficulty in reading that she has noted since the last 5 years. On clinical examination, it was normal on primary gaze, but nystagmus-like movements are noted in all other cases. The direction of nystagmus was difficult to elicit on clinical evaluation. Eye motility recording shows multiple saccades disrupting foveal fixation without any pathologic slow movement. This was suggestive of nystagmoid eye movements. This will necessitate further neurological evaluation for a final diagnosis. However, EMR helps us in differentiating this from a nystagmus. This video has shown few common cases of nystagmus where diagnosis is difficult based on clinical evaluation alone. It can be confirmed with the help of eye motility recording. Thank you.
Thank you so much, Dr. Divya. Thank you so much. Now, I would like to call Ankita Bisani for her presentation.
Adhesions were released with spatula at the site of pseudo-iris cyst. Iris hook was used for better visualization. The diagnosis of pseudo-iris cyst was confirmed. Capsulorhexis was completed. Lens aspiration was done. A 3-piece acrylic hydrophobic IOL was implanted in the back. Remnants of iris adherent to the anterior lens capsule were then removed. A prophylactic peripheral iridectomy was made. Post-operatively, patient had a BCVA of 6/12 and 6 with normal intraocular pressure. In a review article by Alexander et al., UBM was found to be an essential tool in diagnosis of a variety of ocular diseases in children. UBM is effective in identifying subclinical abnormalities not visible on a clinical exam. In this patient, UBM was essential in ruling out a secondary iris cyst and thus optimizing our treatment. UBM has a specific niche in pediatric traumatic cataracts with disorganized anatomy of the lens and iridociliary complex. Our case stands as a perfect example for it. Thank you for watching.
So I think my video is self-explanatory.
Thank you so much, Ankita. Now I hand over to the next moderator, Dr. Nikunj. Thank you so much, everybody.
Thank you, Dr. Anupama. For the next session, I would like to invite our panelists, Dr. Sumita Madam, Dr. Jasprit Sukija, Dr. Ramesh K. Kunya, sir. We are running late, so we'll start with the first presentation, a tale of two cases a decade apart by Dr. Nidhi Agrawal.
Is it good afternoon? So I'll be presenting a little away from the mic. It's a tale of two cones a decade apart. I thank Dr. Ramesh Kekunaya for letting me present this case. So it's two cones meaning posterior lenticonus. Can we move on to the next slide, please? So it's two cases, posterior lenticonus bilateral, one presented in the year 2007 and the other presented in the year 2017. The first case was a 4-month-old child who presented with bilateral white reflex. On examination, he was found to have a 30 PD of exotropia along with horizontal jerk nystagmus. He was found to have a bilateral posterior subcapsular cataract-like opacity. We did an immersion B scan, and on immersion B scan, we found a posterior bulge in the lens capsule shown by the yellow arrow, and he was diagnosed. This is only image of one eye. He was diagnosed to have bilateral posterior lenticonus. This child underwent a pediatric lens matter aspiration with a primary posterior capsulorhexis and an anterior vitrectomy. He later underwent a secondary IOL in the sulcus. The second case presented to us in the year 2017. This was a 6-month-old child who presented with bilateral white reflex. He had no nystagmus on examination, no strabismus. He had a central plaque-like opacity in both the eyes, and on immersion B scan again was found to have a posterior conical protrusion of the posterior lens capsule. This child underwent a pediatric lens matter aspiration with a primary IOL in the bag along with posterior primary capsulorhexis. This is the post-op follow-up of the patient. This is this year when the patient had come 2 months ago. The case one that presented to us in 2007 is 17 years of age now. Best corrected visual acuity in both the eyes is 20/100 with a N6 vision near. This is the case 2 which presented in 2017. The child that had no nystagmus has a BCV of 20/50 parts in the right eye and 20/40 parts in the left eye. The fundus photograph of both the patients was normal. Patient 1, this is a slit lamp photograph of the IOL position showing a well-centered IOL. And the patient 2, we took a shine plug image showing the IOL placement in the bag. This is a simple graph representing the axial length progression in both the cases. In the case 1, the pointers with this red. It's not working. Okay. So I'll try to take you through the graph. Case yellow represents the right eye and red represents the left eye. In case 1, the baseline was actually taken at 13 years of age. From 13 years of age to his current age 17 years, the axial length progressed by 0.59 in the right eye and 0.62 in the left eye. The difference between the two eyes was 0.51. This I'll come to later in the next slide. In the case 2, the right eye progressed. The baseline was taken at 6 months of age when the child was operated, and at 7 years of age, the progression was 2.68 in the right eye and 2.49 in the left eye, with a 0.19 difference between the two eyes. Refractive error comparison between the two cases. Case 1 had a spherical error in the right eye of minus 1.5 and in the left eye of minus 0.25. This corresponded to the axial length difference between the two eyes, 0.51, correlating with the refractive error difference between the two eyes. Case 2 had right eye refractive error of minus 2 in the right eye and the left eye was minus 1.5, and the difference being 0.19 in the axial length, again correlating with the spherical refractive error. So this is basically two simple cases that we commonly encounter in our practice. Maybe for the junior members here, the surgery tips might help you to tackle posterior lenticonus better. Can we start the first video, please? The first video shows the technique when we do not have a pre-existing PC defect. The anterior capsular excess was done with a lower bottle height. Now peripheral lens matter is getting aspirated, and then the central lens opacity is tackled. This is in the absence of a PC defect. This is a outside-in technique. The post after removing the cataractus lens, that is the lens crater that we see in the posterior capsule. Can we start the second video, please? This is with a pre-existing PC defect. We can see the fishtail sign. Here the central lens matter is aspirated first, followed by the periphery of the lens. That is an inside-out technique. This is to prevent any lens matter to escape in the anterior vitreous. IOL was implanted in both the cases. Can you switch on this video, please? This is the case, that 7-year-old boy. He was super happy when he came to us 2 months back. And that's the difference, I think, as a pediatric ophthalmologist, we make in the life of the patient as well as the parents. Thank you.
Any questions? Just I wanted to highlight it's 10 years, 17 years and 7 years follow-up. And I don't know how many of you see bilateral posterior lenticonus. It's not very common. It's very uncommon to see, especially at the infantile stage. Because usually they come with one eye and then maybe after a few years they come with the other eye. So bilateral posterior lenticonus per se, it is rare. And some of those, as the first case had nystagmus and the second case did not have nystagmus. So, and also their axial length progression, it's good to see the cases over a long period of time just to see what is happening to them. That's why I think these two cases are presented. Thank you.
Can I add something?
So when do you do a systemic evaluation in these cases?
Sorry, sir?
When would you do a systemic evaluation in these cases? Like
a bilateral posterior lenticonus, we would actually take up a systemic evaluation. We had examined the parents of both the both the children, and the father had thiacical high in the first case, the bilateral. And but the other child, the parents had normal lens. There was no lens opacity or
regarding the child, I mean, because these are sometimes associated with Alports.
Alports, yeah.
So
bilateral.
I mean, these children would need evaluation probably because it's a young child. So maybe after a few months or years, starts having some kidney problems or those issues. So this should be kept in mind for when you're dealing with these cases.
Right.
Generally, we haven't seen any kind of kidney issues with the posterior lenticonus. Mostly whatever we have seen with the anterior. Posterior lenticonus amounts to 2 to 4% of our pediatric cataract population in a tertiary center. Out of that, in the recent time, 30% of them are bilateral. We are doing genetic and other association. Maybe in the few years, we will be able to tell. What I have seen in the last 20 years is bilateral is usually familial, unilateral is not familial. This is what we have seen, but we are doing genetic analysis of these patients. Probably in the next 2 years, we will be able to come up with any kind of genetic association.
Just to add on that, in early stages, if you see a lenticonus, it may mimic an oil droplet appearance in that patients, and we have published that also. And otherwise, you have to have, like, you know, it may mimic it may be associated with the posterior capsular dehiscence or not. And you may see the bowing of the posterior capsule on a B scan, and you can see the fish hook sign, I mean the fishtail sign when you're moving. Sometimes even when before you start the surgery itself, if you just, when you're just holding with the forceps itself, you can appreciate it. And even atoll sign has been described. So these are some typical signs. Oil droplet is something which you may mistake it for a subluxated lens. So always it's better to plan it with an EUA and go. Another thing would be to, I don't know, to go with the cutter when you have a, congenital
Pre-existing
posterior
dehiscence.
capsular dehiscence, because that you can aspirate as well as cut instead of going with an IA directly.
Alright.
So these are some things which I found useful.
Okay.
Yeah, there are 4 stages of posterior lenticonus, and from one stage to the other stage, they can go very fast. Sometimes these cataracts can be diagnosed as traumatic cataract. They will say that from 5 days only I am seeing this total cataract. So there are different stages of posterior lenticonus.
So just one last comment. If you like when you are doing the irrigation aspiration where you don't have a dehiscence, I think lower your bottle height to the low, so that you don't have create a defect in that. And of course we've described this in IGO. I mean, we've done posterior optic capture also in these cases. So all these are possible. I mean, because that opening is not that big when you have posterior lenticonus. So just go around it. And so when you do you do a primary IOL implantation in these cases?
So when the PC defect is lesser than the anterior capsular diameter, we would like to do an IOL implantation in the back preferably, otherwise the 3-piece and the sulcus.
Even if you have a dehiscence, it is usually a spindle-shaped dehiscence. All you have to do is round up the spindle into a kind of an oval. That's all you need to do. So that then there is no danger of any extension, and you can safely put the lens in the back.
One question.
Eccentricity, instead of the central, we can say lentiglobus or whatever, eccentricity is there and it is not coming into the visual axis. So what would be the plan of management?
Yeah, there is a eccentric posterior lenticonus and central axial also. In abaxial, there are some cases we have observed them also, not even doing surgery. So there are 2 types again, depending upon the position. We have observed some of these patients without any surgery also. Thank you. I think we will go on to the next.
Thank you.
Okay, he's
Thank
there.
you, Dr. Nidhi. Now I would like to call upon Dr. Pooja Lakhani. She will be presenting on pediatric cataract out of blue solution.
Very good evening, everybody. Thank you for being patient at the coffee time. I won't take much. I'll be talking on a case of pediatric cataract where I felt I did something unusual. So, talking about the case history, 4.5-month-old female child was brought to me 3 years back with complaint of left eye appearing smaller since birth, and there was occasional watering. Rest history was normal. Visual acuity with both eye open, the child followed light and object well but resisted right eye occlusion. On examination, right eye was fine, but left eye, there was microphthalmos, microcornea, white reflex and non-dilating pupil. Rest details are not seen. IOP was normal with eye care. On fundus examination, right eye was fine, but left eye there was no view. So I asked for a B scan and I was planning to consider left eye lensectomy. But patient was lost to follow-up after that. And they came back to me after 9 months when the child was 13.5 months old and they wanted surgery now. So again on examination, right eye was fine, left eye had same, microphthalmos, microcornea, and there was something like membrane-like cataract with occlusio pupil or synechia, but the child was not very cooperative. On fundus examination, right eye was fine, no view of left eye. When B scan was done, it was suggestive of absorbed 1 millimeter of cataractus lens and the axial length was 19.2 millimeter. So I advise for left eye cataractus lens removal, either lensectomy with or without IOL implantation depending upon the intraoperative status. So what I felt was different from normal. First there was microphthalmos, the axial length was 19.2 compared to 20.9 in other eye. There was microcornea, horizontal only 10 millimeter, vertical 9.5. The pupil was non-dilating and partially absorbed thinned out cataract was there with unilaterally at the age of 13 months. So what I was planning was cataract removal with anterior vitrectomy and posterior fixation iris claw lens placement. Can we play the video please? So this is how it appeared. So there was synechia all around. I tried to remove them with spatula and repositor, but I was not able to clear all the synechia. There was some membrane-like adhesions. Can you just please forward it a bit? Just few seconds. So by trying with spatula, I was hardly able to relieve the synechia at 180 degree. And so I considered peeling off the rest of the part using forceps, but it was not of much use. When it was not possible, I finally planned to cut off the adhered portions. It was all adhered behind to the calcified portion, adhered to the iris. So by going in different planes, I was just trying to make the opening so that I can get a field to operate. So after cutting with Caesar, I could finally get this much of small aperture, which I couldn't find enough, so I tried a bit of pupilloplasty. I did stretch pupilloplasty, but before that, what I felt was the synechia were not just at the pupillary margin, they were somewhere even in the mid-periphery. It was free at few angles, but spatially, is the pointer working? No. So now you had seen the last part, it was adhered completely over here, and it took some efforts to relieve. So at 1/4 quarter of the place, there were complete synechia. And after I removed that, I went for stretch pupilloplasty to get a better opening. We can just forward it for a few seconds, please. This was it. Stop. While doing stretching, I observed that the back support was not good enough in periphery. It was only the central calcified portion which is visible and the crumpled bag with striations that were visible. So removing this part was not possible. There was no opening possible either with the stitome or forceps. Even by trying with Caesar, it was not possible to make an opening. Even the vitrector was not helpful. And you could appreciate that on touching that portion, entire thing, everything, whatever you call it, cataract with the bag was moving. So finally I selected the MVR blade, created a plane and used the phaco probe to aspirate the calcified central cataractous portion. Sorry for the bubbles. The access was clear, but obviously I didn't expected any back support over here. Everything was moving already. So I continued with my plan of posterior fixation iris claw lens. Please forward it a bit. Sorry, it came from the beginning. We'll go. Please take it more than halfway from there. Forward it, please. No, actually, it came from the beginning by mistake. I continued with my plan of posterior fixation iris claw lens. I closed the main corneal wound. As putting non-foldable iris claw lens, I prefer scleral fixation, scleral tunnel, sorry. So I made a tunnel and completed the vitrectomy again to avoid vitreous coming into my way. And 5.5 millimeter optic posterior fixation iris claw lens was placed first in the anterior chamber. Made it horizontal, holded the central portion with the lens holding forceps. Passing the first side of the haptic seems easier, enclaving it with Sinskey hook. Nowadays I use cannula, which is more easier. In this case, the iris was not ideal for putting iris claw lens because it was rigid, non-dilating. So passing the second part was a bit challenging. It literally took me this much efforts 3 to 4 times before I could finally pass it. And enclave it. And did iridectomy with vitrector and closed the wound. So postoperatively the patient was fine as examined in the immediate postoperative period, and that was till 1 year post-op the patient was in regular follow-up. There was slight esotropy around 5 degree, but the fixation appeared good. Then the patient was lost to follow-up for 2 years, and finally I was trying since last 1 month for academic purpose to get back the patient, and I was lucky to get the photographs yesterday evening where I can see that the left eye is esotropic but appears to be taking fixation at times. So my question to panelists are, what can be the better management option for this patient? Like removing the calcified membrane was possible in any other better ways? Considering the microcornea in this patient, was sulcus IOL safe? And what about putting the child aphakic and using contact lens? What about the experience of my seniors? And regarding the getting more exposure, anybody using BX ring or iris hoops in such a small patients, as well as the long-term stability and risk of glaucoma in these patients?
There were blood vessels all around across running, smaller eye, and to me it looks like anterior PHPV or a persistent foveal membrane. So how much was the corneal diameter?
10 millimeter horizontally when I operated.
So only thing I would have done differently would have probably left the patient aphakic and put a secondary IOL a little later. I don't do retrofixated iris claw lenses.
Okay.
But in this case where the cornea is small, child is not very compliant with follow-up, putting a lens which is like probably PCIOL would have been okay, but in this iris fixated IOL is just asking for trouble.
So ma'am, putting IOL in sulcus, I was just...
No, in this day you don't have a sulcus at all.
So what could be the better option?
Yeah, I would have left it aphakic. I would have managed aphakia even with glasses.
Okay.
One point I would like to make, I have seen a patient like this, because it's a microcornea, they put an iris claw. Iris claws comes as 9 millimeters, and your diameter is 10. So later on, I have seen the entire iris being lifted, it has caused PAS all around, and the patient landed up with a secondary glaucoma. So when you're putting in a lens, even if it's iris claws, you should have a lens when you're putting it behind on your iris significantly small, otherwise over time, this child will land
This
up.
one is 8 millimeter diameter, ma'am. Entire diameter.
Yeah, but when you put it in a 10 millimeter, if you're looking at it, it gets lifted off and it can cause. So I have seen that, and finally we had to explant. So in children like this, best would be aphakia. Even if you put a lens later on, sometimes we need not push it for an IOL at the same time. We can do it. They do very well with contact lenses. The vision improves, and then at a later stage, any time we can put in a lens.
And in this case, synechial, you were using the spatula, no?
Yes.
Sometimes that causes a lot of trauma, and you did have some bleeding there.
Yes.
So it's probably better and safer to use a scissors to cut it, clean cut between the additions between the anterior capsule and iris.
Okay.
And probably you could use a vitrector, but it is important that in that calcified membrane, you first use a scissor from the area where and make 2-3 vertical cuts. Then only you can use a vitrector and use it. And probably 20 gauge vitrectomy will work better than 23 gauge, which is now standard with all the new machines. But sometimes here you will have
to remove this. That could have been easier. Yes, sure.
I think this patient has a history of poor follow-up. So one of the things I would have done is I would have gone with the phaco, because that eats away all the things easily. 3 to 4% of pediatric patients you have to use phaco. You can. That's one of the options. Pupil is unhealthy in this patient. Iris and pupil is unhealthy. So whenever the iris is not healthy, it's better not to implant anything, because it gives a lot of space for breathing and the inflammation to come down. Maybe in the future you can consider a thing, because I'm not sure how this child will do in the real long run. And I think there is no way you could have put it in a sulcus because already the lens was wobbling there.
The thing like when you do the
In
iris
sit-
lens, in every pediatric patient, make a habit to do the peripheral iridectomy.
Yeah,
Because, and that is also, I prefer to do in the inferior part. Because this child, I have a chance that it may require some retinal surgery and silicone oil. So
Okay.
every time, like for doing this type of iris square in pediatric, in lower segment, peripheral iridectomy.
Lower, yeah, I did in upper.
She did an iridotomy, I
In
think.
upper segment, I did with vitrector.
Yeah. But did you invert the IOL before putting? Like these IOLs, what is the shape of these? They are the plano-convex? How are they? Because you have
plano-convex.
So they have to be inverted upside down and then so that obviously you don't have all these secondary glaucomas and the
convex
PI,
are downwards.
PI for posterior iris claw is it's now, I mean, it's up to you. I mean, there are studies which say even if you don't do, nothing is going to happen. Okay, for posterior, if you put it the other way around. Okay. And yes, I have the same opinion as the others. Probably we could have left the child aphakic considering the small eye, your size of the IOL, the state of the iris. No doubt they are customized iris claw. They are smaller as well. But considering this child, probably aphakia would be a better option in
I
this child.
conclude majority are in favor of aphakia. My only concern was that in our setup, generally patients are not accepting contact lens. So just thinking of long-term amblyopia, but yes, would definitely consider this.
I think we'll move on.
Sure. Thank you so much.
Thank you, Dr. Pooja. Now I would like to call Dr. Akshaya for her presentation, autosomal recessive cornea plana with bilateral complete flesher ring without associated ectasia.
Good evening, everyone. Thank you very much for the opportunity. Yeah, I'm here to share a case of an autosomal recessive cornea plana which presented with an interesting finding of a bilateral complete flesure-like ring without associated ectasia. So, as we know, cornea plana is a congenital familial flatness of the cornea wherein we have high hyperopias, flat corneas, variable corneal opacity, corneal size with limbal abnormalities. So usually the corneal curvature is less than 43 diopters. There's type 1 and type 2. The type 2 is autosomal recessive and for which the gene mapping is on the KERA gene, it's because of the KERA gene mutation on chromosome 12q. So mostly found in the Finnish population. And this case was a 9-year-old boy born of second degree consanguinity with normal parents who presented with poor vision since childhood and small eyes since birth. Visual acuity unaided was 636 and N12. The refraction was plus 11 and plus 10.5 with a small cylinder. There was apparent ptosis, corneal apex appeared to be flat in the side view. But what was interesting was a complete brownish flesure-like ring, which was more prominently seen in cobalt blue filter in both eyes. The corneal diameter was 9.5 mm horizontally. Vertically, there was superior arcus lipoides. So approximately it was 9 mm vertically. There were no other signs of ectasia. IOP was normal, gonio was normal, fundus was within normal limits. So the axial length was 20.57 and 20.77 right and left eye respectively, and anterior chamber depth and lens thickness were fairly normal. So the pentacam imaging showed a grossly flat cornea with an average corneal reading of 35.1 and 35.8 in the right and left eye, an average pachymetry of 478 and 461. And the anterior and the posterior elevation maps showed some irregularities. So we went on to see the Bellin-Ambrosio display, which we usually see for keratoconus ectasia. So the picture on the left is that of the right eye of the patient, which shows a more classical picture. The first column is the anterior float. The first picture is the anterior elevation of the cornea with respect to the best fit sphere. And the second picture is the anterior elevation with respect to the enhanced best fit sphere, wherein the central 3 mm of the values are removed. And the third picture is the difference between the two, which is absolutely normal, showing that there is no change in the corneal curvature in the anterior float. But the second column shows the posterior float. So in the posterior float, if you see the last picture, the difference between the best fit sphere back floats and the enhanced best fit sphere back floats, we see a classical green area which is a central depression, followed by a peripheral elevation and a yellow ring in between where we saw the Fleischer ring clinically. So a similar picture was seen in the posterior float of the left eye as well. So we managed the patient with best glasses. We are treating for amblyopia. We're looking for intraocular pressure monitoring, specular microscopy, systemic evaluation, and genetic analysis was advised. So we were thinking why there was a Fleischer ring in a congenital condition without an ectasia. So generally we see this ring at the junction of an ectatic and a normal cornea and keratoconus, which is because of inadequate tears getting swept away by the eyelid margins. It is also described in after various refractive procedures, also after orthokeratology. But in our patient, there was absolutely no change in the anterior contour of the cornea, but the posterior float alone showed a sudden change in the curvature from center to 6 mm and beyond. And the graph here, the second graph shows the percentage thickness increase from 2 mm and beyond. So the only flattening was there in the posterior corneal curvature, and that has led to the change in the contour and the formation of a Fleischer ring. So we do not know if such a ring or such a finding is common in cornea plana, because Bellin-Ambroisio display is not commonly studied in cornea plana. Or should we still monitor the patient for ectasia in this cornea, or some studies have explained a plaque in the posterior surface of cornea plana as seen in ASOCT. So is it due to that? So I wanted the panelists to give us more insight on this.
Yeah, I mean, no doubt, I mean, to have a Fleischer ring in such a condition, I mean, something very rare. Usually you have these lipid deposits when you have the cornea plana too. So, I mean, probably because of the curvature, what you're showing, that steepening which is happening on the
posterior float.
Yeah, so probably might be playing a role, as I mean you have in keratoconus when you have these conditions. The other thing is, how would you differentiate it, whether it's one or two in this case?
Sir, the autosomal recessive was mainly because of the phenotypic presentation. The parents were not involved. I mean, parents did not have any problem, and the child showed a bilateral listing, and the hyperopia was high, and there was a severe flattening of the cornea. So just with the phenotypic presentation and the history,
so
probably
what
it
was
was
the hyperopia? Sorry, I missed
the
it.
genetic testing was
hyperopia. How much was it?
It was plus 11 and plus 10.5.
Axial length?
20.57 and 20.6.
Okay. Most of these cornea plana, what happens is that looks like a sclerocornea. They will have an elliptical shape. Wherever that flatness happens, what we see is generally a scarring. You will see a corneal scar also in some of the patients. So having this ring, I don't think so I have seen in this kind of patient, and it's a bit unusual, probably because of the folding, some deposition has happened. Otherwise, you see a lot of scar in cornea plana cases, and usually it is bilateral.
Fleischer's ring, that also we don't know, because there is no way of knowing it. Some kind of ring, but
it was subepithelial, full complete in both ends.
But it looked like a classical Fleischer's ring.
The pentacam picture, wherever that yellow ring was seen, exactly in the same location we had the Fleischer ring.
Anyway, take better pictures and publish it.
Thank you, Dr. Akshaya. Now I would like to call Dr. Saulin Kaur for her presentation. Pediatric cataract with coexisting glaucoma, a case of triple Trenoni syndrome.
Staying away. Very good evening, everyone. I'm presenting a case of pediatric cataract in a patient who has a coexisting glaucoma. So, describing the story of a 7-month infant who was a known case of congenital glaucoma and then referred to us for cataract surgery. As you can see, the patient has a discoloration on the face, which is kind of obeying the midline. This port wine stain is accompanied by a hyperpigmentation on the front part of the chest, the back, as well as some of the limbs. He also had a hypertrophy of the right hand. So putting all these things together, vascular malformation, port wine stain with limb hypertrophy, we obtained a pediatric consult and an MRI revealing pyeangiomatous. So a diagnosis of Klippel-Trenaunay syndrome was made. It's a neurocutaneous disorder, kind of the Sturge-Weber spectrum. It is characterized by vascular malformations and limb hypertrophies. And the ocular associations are again the same as that we see in other phacomatoses, that is glaucoma, a thickened choroid, retinal hemangiomas, and very anecdotal case reports of cataracts in patients who have Sturge-Weber. So because it's a relatively rarer condition, the glaucoma team at our institute went ahead with a goniotomy after anti-glaucoma cover, and the child was doing fine for 4 months. So 4 months later, the child presents to us with an anterior subcapsular type of cataract. The axial length is 21.1 as compared to 18.8 in the other eye. The corneal diameters are 11 and 10.5. And IOP is maintained with a cup disc ratio on the last examination under anesthesia noted to be about 0.5. There was a slight increased choroidal thickness of the right eye as compared to the left on ultrasound. So in a case which has a coexisting glaucoma and you are doing a cataract surgery, we have a lot of preoperative considerations in mind. We need to have the adequately controlled IOP to make the cornea a little clearer so that we have a good view at the time of cataract extraction. Intraocular lens power calculation in these patients can be challenging, and especially in cases like these where you can have laryngeal hemangiomas also, anesthetic complications also have to be kept in mind. Intraoperatively, I'll just show some representative photographs. For a cataract surgeon, you might have to shift temporally because of a superior bleb. Often these patients are known to have a poor dilation of the pupil, and intracameral phenocaine has been, we have experienced it to be working in these cases. There is a poor visibility because of the HAB stria that these children might have, and corneal scarring because leading to maybe because of a delayed presentation and because of the glaucoma disease per se. The intraocular lens sometimes in the bag, in the presence of a larger bag diameter or in a larger eye more than 13 mm corneal diameters, is known to subluxate. So anterior optic capture can also be one of the options, keeping in mind that you do have to do a posterior capsulotomy and anterior vitrectomy as well. In our patient, it was a patient who had malformations, vascular malformations. So there is a risk of rapid decompression and choroidal effusions that have been described post-glaucoma as well as post-cataract surgeries. So the trick is to avoid sudden hypotony and maybe use higher viscoelastics. Coupled with this, we had a departmental publication where we had used perioperative propranolol. In these cases, in the dosage of 2 mg per kg body weight, starting 1 week before surgery and extending up to 6 weeks later. Not only does it decrease the choroidal effusions, but it also has a transient anti-inflammatory effect, decreasing the levels of VEGF and MMP in these eyes which are already prone to inflammation. So I went ahead with the right eye phacoaspiration as a personal decision, deciding against intraocular lens implantation in this child under the cover of oral propranolol. The surgery was like any other case of pediatric cataract, except the fact that I had to use blunt hooks to dilate the pupil, coupled with a relatively smaller pupil phacoaspiration, and then doing an anterior as well as, a posterior capsulotomy. I did use a little bit of triamcinolone because there was some iris manipulation involved, leaving the child aphakic with an intact bag for secondary intraocular lens implantation. So postoperatively, the child is doing well with a clear visual axis and a reading 618 on preferential looking test at the 18-month follow-up. The IOP is 14 on some anti-glaucoma medications. So I wanted to highlight that these cases are rare. Refractive glaucoma and secondary cataract are very commonly seen in these patients, and the chamber maintenance is a must, and oral propranolol can be one adjunct that can be used in case we deal with these situations. Acknowledgements to my mentor, Dr. Jaspreet, and the glaucoma team at PGI. And I would like to have the opinion of the panel as well as the audience onto their experience in cataract surgery in general with glaucoma and phacomatoses, how do they do IOL power calculation, and whether their age cutoff is different for implanting an intraocular lens or any different drug regime that they may use. Thank you.
I
hope you did remove those 2 loose sutures which were there.
At the end, yes.
One thing we have seen is whenever there is a glaucoma or ophthalmos, the bag stretches and it becomes a little bit unstable. This is one thing what we have seen with regards to glaucoma and cataract. Second thing is IOL implantation, still not really sure because they have a tendency of growing still. Here the corneal diameter difference was just 0.5 and even the axial length there was a difference of 2 millimeters. So most of these patients have unilateral. If they have unilateral, I will go towards emmetropia, still undercorrect, but go towards emmetropia.
Emmetropia.
Yeah, that's what done. But if you look at the glaucomatous eye, they become more myopic. So I don't know whether this kind of undercorrection is required at all for them. So these are the two things.
But contrary to what you felt, ki glaucoma will corneal diameter enlarges, but bag size is normal. That's been my experience of doing several times with my glaucoma colleagues and their cases coming to me. Very, very rarely you will find a bag which is enlarged very. So if it is a full anterior megalophthalmos, then probably yes. But if it's only a megalocornea or ophthalmos, lens is, you can perfectly place the lens in the bag without any. Bag is very rarely enlarged.
Yeah, so the zonules get
you can have zonular, yeah.
Zonules stretch because of the bag.
Yeah, but bag is
but
normal
bag diameter also, I mean, what we've seen is, I mean, it does enlarge because what you're doing is, in these cases, you have to do a primary posterior capsulotomy. You can't just put in the bag. So it really becomes a kind of a unstable situation unless you're doing an optic capture as she was showing. So either you can do a anterior optic capture or you can do a bicapsular capture. So to prevent a PCO, because in these cases, if there's a PCO or something, I mean, going in again is again a problem.
And ma'am, I do have seen one case of, I think Dr. Jasprit will also, a wandering intraocular lens because it was
No.
placed
Some
in
cases,
the bag.
yes, where the whole anterior segment is enlarged, that is fine. But lot of them who have only corneal enlargement, bags are fairly normal size.
So maybe we measure the bag.
Yeah.
Yeah, good evening all. I just would like to share my experience that recently I operated a child presented 4-year-old developmental delay and bilateral corneal scarring and again ophthalmos, and then possibly it was due to the glaucoma. He got a complicated cataract, dense scarring in right eye. Left eye comparatively the cornea was quite clear. So I did his bilateral cataract, same sitting because of the developmental delay, anesthesia issues were, and in addition also he had an ocular digital sign. Constantly he was, so fundus I couldn't get to it. But overall, though his visual symptoms were like right eye, there was dense. I did a peripheral optical iridectomy and placed the IOL there. So as his developmental delay was there, but overall his quality of life improved. His mother was very happy that at least he is moving around. So again with the ocular digital, probably his fundus, he may have a Leber's amaurosis as well.
See, children with coexisting glaucoma, again glaucoma is a disease which is lifelong follow-up and there will be more problems coming up. So cataract surgery is just one part in a long journey. So there will be more things
So
happen.
many things in this child.
Yeah, so corneal scarring can come, their pressures can become uncontrolled. Like this child probably at the time of surgery did not need any medication, but now he is on 2 medications already. And Sturge-Weber is one of the difficult glaucomas to handle. It's not simple glaucoma. So
In case it is bilateral, then the age at which we implant an IOL would be like, would it be different?
I think he will need some surgery at some point. At that time, you can combine it with the secondary IOL. Anyway, now you will have a good sulcus thanks to AC.
Thank you to all our speakers, panelists, and all of you for your active participation. I think now we can have a tea break and we'll come back with the next session. Thank you.
We'll take a 10-minute break and we'll try and come back. We are catching up with time, but we are still running behind. So pick up some tea and come back and sit in your chair so we can start as soon as possible. We also have a photo booth up here near the stage. So please come forward and take your selfies and make some memories with friends. We've taken some effort to make a photo booth. So please use it. Thank you.
case of ophthalmoplegia.
Good evening, everyone. I am Aditi Parikh, and on behalf of Child Sight Institute, L.V. Prasad Eye Institute, I will be taking you through a very interesting case named T or T. That is a riddle about case of ophthalmoplegia. So here we can see is a case story. He is a 44-year-old male coming from Mahbub Nagar, Telangana. He came with 4 days of history that he is complained of pain in right eye and also right frontal and temporal headache associated with sudden onset binocular double vision and drooping of right upper lid. In his past history, he had 2 episodes of Bell's palsy. Last episode was 5 months ago and recovered fully. And he is known case of diabetes and hypertension since 3 months. On examination, his best corrected vision in right eye was 20/20 Parsh. He just missed 2 plates of color vision chart, and he has RAPD grade 1. His left eye vision and color vision examination, everything is fine. In this first photograph, left side, we can see that he has severe ptosis in right upper lid and very mild proptosis in right eye. He also had XT of around 20 PD and RHOT of 14 prism diopter. And on motility evaluation, he has limitation in all the gazes in right eye, but left eye is full and free. On fundus evaluation, in right disc is showing temporal failure. So we went ahead with visual field analysis, and here we found that right eye has generalized depression. Left eye is is having very non-significant peripheral depressed points. Center is clear, and on RNFL and GCIPL also showing diffuse thinning. So we advised for MRI brain and orbit with contrast. The first image we can see that it's a eggshell T2 weighted scan, and we can see iso-intense lesion in the lateral wall of cavernous sinus, and which is little bit extending anteriorly and posteriorly also. And on the second image, it is post contrast image, we can see that the lesion is enhancing nicely. So here we are dealing with right external ophthalmoplegia and probably cavernous sinus syndrome. So we wanted to dig into possible etiology. So we went ahead with few serological workup like complete blood counts, also infective disease workup and inflammatory workup. Few positive findings in serological workup are he has leukocytosis, significantly raised CRP level. ESR is very mildly raised. Mantoux was positive and dyslipidemia was there. So keeping in mind tubercular etiology, we started him on ATT, and we also had a plan to start on steroid. Meanwhile, in 3 days, he just presented with sudden drop in vision in right eye, which became just counting finger, and even RAPD grade has increased. So we immediately started him on IV methylprednisolone. We gave it for 5 days, followed by oral steroids tapering dose. And we followed after 1 month. He came back with minimal improvement in vision, but motility is very nicely improved. At the last follow-up at 3 months, his vision and motility came back to normal. So in this case, is a like positive story, it's a happy story, but we are still thinking whether it is T or T, whether it is tubercular or Tolosa Hunt. So we searched in literature, and these are few salient points which I would like to share. Regarding tubercular orbital apex or cavernous sinus is like isolated, it's very rare in absence of other pulmonary and neurological involvement. Usually it presents in early to mid age. The gold standard is CNS biopsy, but it is difficult, so we usually go with the tubercular skin test. Neuroimaging usually won't help us to differentiate between etiology, and combined ATT with IV steroid gives a very good result, but steroid should not be stopped abruptly. Whereas Tolosa Hunt syndrome is, all we know that it is idiopathic granulomatous inflammation, and it's a diagnosis of exclusion. Optic nerve involvement here is less common than tubercular etiology. But there are similar case reports where ophthalmoplegia followed by optic nerve involvement is there as same as in this case. And prognosis for ophthalmoplegia here is good, but optic nerve function prognosis is guarded. So we still have dilemma about T or T. I would also like to ask expert that why was the optic nerve last to involve and last to recover? Does the recurrent Bell's palsy have any relation to present pathology? Or would repeat MRI at any stage of follow-up help us in differentiating etiology or prognosis or anything? That's all. Thank you.
So the only reason why you say that this inflammation is secondary to tuberculosis was the skin test.
Yeah, skin test.
Apart from that, we didn't have any other evidence. What about the
Chest
CT?
X-ray was normal. It was normal.
HRCT was also normal.
We got only chest X-ray done.
Okay, so
also ESR, CRP level were little so just indirect.
ESR CRP will be raised in any kind of inflammation. So that will not be able to differentiate, determine the cause of your, the inflammation that you're seeing. Your optic nerve had started to get involved in the first, in the beginning itself. Your color vision had come down. There was trace RPD. So it was just a matter of the inflammation progressing that your optic nerve inflammation, optic nerve got affected and your vision suddenly dropped. Again, I would, you had given it under anti-tuberculous cover, which is probably what we would all do in this situation. We can't really do biopsies from the apex, or it is difficult. Nobody does it. None of the neurosurgeons will be ready to do it.
But what about a CSF analysis here? Would that have helped? It's actually my question here. Because we quite kind of refer to neurologists most of the time, and they do admit and do a CSF analysis here.
Yes.
So that could have maybe helped in differentiating the two.
Dr. Shailaja,
Yeah.
Divya here. So CSF analysis was done, and it was
that was not
significant, and IgG4 also we did, that was also not. Of course, this was an acute presentation, but still, no other investigation was actually significant. We're not clear about the etiology actually.
So most of the times if you see a Tolosa hunt as ruling out, we try to do CSF, and later now IgG4 is the most common blame, but if it is negative, it does not rule out IgG4 disease. If it is positive, it does not really rule in unless you do a biopsy. But biopsy is not possible. In this case, there are two atypical things. There are two recurrent attacks of facial nerve palsy, and optic nerve pallor was there when you had a vision of 20/60 itself. That means there was a past history of some kind of subtle optic neuritis was there, and it's an inflammatory pathology. And also, if you see the image, Tolosa Hunt syndrome will not have that kind of whole patch like that, but they will have a contrast enhancement will be there, but it's not like that. There are two atypical things. So some kind of inflammatory pathology is going on. Unlikely, in retrospect, unlikely it's a tuberculosis. That's what I would say.
Another differential could be a sarcoid.
That's another thing which is very much possible, that's sarcoidosis. So chest X-ray was done, probably just to get, and in these kind of patients, probably it's a better idea to get an MRI post-treatment also. What was the time it happened, Aditi?
This February 2023.
23. Inflammatory pathologies coming, even myasthenia, a lot of ophthalmoplegias are coming after COVID thing. Yeah. Yeah, anti-tubercular treatment can cause toxicity, but that will not be so sudden in so. Yeah. Okay. Thank you.
Thank you. Next, I'll invite Dr. Sahu. Uncovering the Uncommon, a case series of rare visual defects. And
Good evening,
TRON.
everyone. I'd like to thank POSN team for giving me this opportunity and also my mentor, Dr. Vivek sir. So I'll be quickly taking you through three cases which I have titled Unveiling the Uncommon, a case series of rare visual field defects in TRON. So first case is of this gentleman who is 50 years old. He came with a complaint of left eye pain, redness and swelling about 3 weeks duration, which resulted from a fall from motorbike and consequent trauma with wooden object. It was a penetrating trauma, so he took treatment, primary consultation from a local hospital, and it had involved wood debridement. They removed small pieces from the broken woods from the wood margin, and primary repair of the left lower lid margin laceration, lid margin laceration was noted. You can see in the picture, the left eye there is congestion, there is proptosis, and we can see there was like healing granulation tissue just inferior to the lateral canthus, suggested an entry wound. And the patient is known diabetic, hypertensive, and he is obese. So on examination, the left eye visual acuity was found to be 20/100 and near was N10. Color vision was impaired. As we see in the previous picture, there was lid edema, proptosis, congestion, and there was restricted motility in all gazes. And there was grade 2 RAPD. And on fundus examination, right eye, it was unremarkable, only there was a small crowded disc, and left eye, there was a disc edema with associated inferior retinal choroidal folds. In this right side picture, you can see that on field test, we find a superior altitudinal field defect that also correlated with the retinochoroidal folds. So we go ahead with the CT scan, and you can see the axial and the sagittal cuts. We found the intraorbital foreign body of about 6.6 centimeter in length, lying just posterior to the eyeball, and it was straddling the left orbital cavity, perforating through the ethmoidal sinus, and it was distal tip was projecting into the contralateral orbit. And you can see in the sagittal cut that it was lying in the postero-inferior aspect of the globe, and it was abutting the inferior eyeball, inferior globe. So that was correlating with the retinochoroidal folds. So this we can see that the limited extraocular motility. So with the collaborating with the oculoplasty team, we performed foreign body removal, and there was like 6.5 long wooden foreign body was retrieved, and it was sent for the microbiological culture, and accordingly antibiotic sensitivity profile was done and antibiotics started. There was a gross edema and inflammation around. So we started on high dose intravenous pulse methylpred for 3 days, and subsequently on tapering oral steroids. So on 4th week, we saw there was marked reduction of the congestion and proptosis. The vision, color vision, ROPD also improved. Extraocular motility also improved. And on fundus, we see that the marked dissolution of the disc edema and retinochoroidal folds were also resolved. And in field test, we see that the field was normal. There were no field defects were there. So coming to the next case. So this is 24-year male who came with a complaint of both eye diminished peripheral vision. And on examination, we find the visual acuity of 20/60 in the right, and left it was 20/30 parts. Color vision was fairly okay. And on pupil reaction, we find there was sluggishly reactive both the pupils, and there was diffuse pale disc was noted. And apart from that, the patient told specifically that he noticed a reduced sensation of smell post-trauma. This is the fundus picture, and we performed the field test and we found the bitemporal hemianopia. So we suspected some chiasmal lesion, and we go ahead with the MRI. So MRI was more or less okay. Only apart from that, the specific feature which we noted is that the radiologist noted is that there was thinning of the mid-chiasmal part, so which was correlating with our finding of bitemporal hemianopia. This is the third case of bitemporal hemianopia with 6th nerve palsy. The patient presented with left eye inward deviation after the trauma, and he was known diabetic, and this was the fundus picture. There was a subtle pale disc. Apart from that, the fundus was normal. So this is the extraocular motility which we noted. The left side there was abduction limitation of -3, and we go ahead with the field test. Here also we find the bitemporal hemianopia. CT scan, and he didn't have the CT scan, he had MRI, so there was no significant finding which was correlating with that bitemporal hemianopia. So advised, we suspected there might be a like periorbital fracture that was extending to sella turcica, but unfortunately we could not follow up the patient. So going to the literature, very limited literatures are available for this cases like bitemporal hemianopia. So one very interesting articles we came across. So here the reason for bitemporal hemianopia post-trauma, it is like they have not concluded anything. There are two school of thoughts. Tranker et al. He suggested that the mechanism may be dependent on the rupture of some blood vessels of the chiasma followed by local thrombosis and softening. But Ostelberg, he contradicted that there is no anatomical grounds for supposing that central portion of the chiasma has its own separate blood supply. And he posed a question that why the crossing fibers exclusively should be put out of the action of the lesion of the chiasmal vessels. In fact, he did an experiment where he took out the chiasma and he stretched it mechanically, and he found that the non-crossing fibers were spared, but the crossing fibers, he noticed very minute tearing he noticed on the microscope. So he proposed that because that could be the similar mechanism because of fracture or some the mechanical force which were transmitting to the chiasma during the trauma, that was leading to the like compromising this crossing fibers and leading to this bitemporal hemianopia. Thank you.
I think traumatic optic neuropathy can always have a visual field defect, especially in the other eye. So most often it is due to some kind of chiasmal injury. So it's always good to do a visual field in this kind of patients. Yeah. Thank you for highlighting through these cases. Any questions?
Visual field is has a localizing sign, and there can be these kind of varied presentations where you can suspect, like in the first case one would suspect like just looking at the altitudinal field defect and NAIN, which is the most common thing which is associated with it, but there's so many other causes of altitudinal field defect. So looking at the retina per se completely helps, like even BRVO or branch, the hemiretinal BRVO and all the CRVO, they can all lead to this kind of thing. So it's good. In the first case I was thinking that maybe there was actually a component of a optic traumatic neuropathy or direct inflammation of that optic nerve, maybe to the inferior part leading to the superior altitudinal defect, and not because of the retinal folds. Because retinal folds per se may not lead to such kind of a
body was abutting the optic
correct
nerve.
So that direct so some compression or direct trauma or but it recovered nicely when it was, so maybe it was not like damaging completely, it was just abutting it. So that could be one reason.
Thank you.
Yeah, and also in case 3.
Yeah.
And also in case 3, according to BETT, it should be zone 1, 2, 3 penetrating. So she can just look into that. Thank you, Dr.
Durga, and I'll now call upon Dr. Debasis. Dr. Smita. She'll be speaking on orbital apex syndrome in a child with atypical skull-based osteomyelitis of sphenoid bone.
Sorry. Good evening all. So we'll discuss a interesting case of a orbital apex syndrome in a 11-year-old girl. First thing, when the girl presented to us, this 11-year-old girl, it was the peak time of the COVID. So the girl presented with a history of last 10 days, there is a gradual drooping of the left eyelid, and she had a history of fever, headache and pain and vomiting history before presenting the ptosis. So the girl was presented from a district headquarters hospital to the oculoplasty department. And while examining the girl, we found there was presence of complete ptosis, mild proptosis. There was hypoesthesia over the left forehead. The anterior posterior segment examination of right eye was absolutely normal, but in the left eye, the vision was no perception of light with grade 4 RAPD, and the retina evaluation was absolutely normal. On extraocular motility, it was completely a frozen globe. So all adduction, abduction, elevation, depression, everything was -4. And the girl came with a MRI. Already they had referred the child with a MRI, and they have diagnosed it as a rhabdomyosarcoma of the left orbit. There was a lesion which was completely close to the inferior rectus of the left orbit. It was intraconal mass. There was no penetration or extension of the mass to the surrounding tissue. But we could see there was some ethmoid sinus involvement. However, the child was posted for an incisional biopsy for the rhabdomyosarcoma. So the plastic surgeon, they went through the medial canthal approach through the medial orbit. And while taking biopsy from the mass, they found there was necrotic material also in the ethmoid sinus. So in piecemeal, some amount of ethmoid sinus also was taken, and the mass was also taken, and it was sent for microbiology and histopathological evaluation. By the same time, all the blood investigations were also done to rule out any systemic association. The child was also tested for COVID. She was COVID negative. She has no history of any family exposure also for the COVID. So we're waiting for the report. By the time we wanted to first rule out whether it is neoplastic or not, and fortunately it came negative for neoplasm, and in the histopathology it was only inflammatory etiology, and in the microbiology the early report was staph aureus, but we thought that time it may be a contamination while taking the biopsy. So we started the child with anti-inflammatories and mild steroid medications, but in the meanwhile the culture report came strongly positive for Staphylococcus aureus, and we want to start the IVMP. Before that we just wanted to consult the neurologist once because it is coming infective etiology. So neurologist also went through all the report whatever is available with us. So he suggested that we will repeat the MRI, but let's first start the IVMP under the coverage of broad spectrum antibiotics. So we started antibiotic followed by 3 days of IVMP, and after that we repeated the MRI. So as you can see in the MRI, at the orbital apex, there is the inflammatory lesions, but at the same time, the posterior ethmoid and the sphenoid sinus, the wall was irregular. The marrow, there was edema in the bone marrow, and the mass was also extending to some extent up to the cavernous sinus. The radiologist has given the report, it has a sphenoethmoidal osteomyelitis involving extending up to the orbital apex. So we also reviewed the report with the ENT specialist. So now with all ENT neurologist and neuro-ophthalmologist, so we started the child, continues the IVMP under the coverage of the antibiotic. After giving the systemic antibiotic, IV antibiotic, we switched over to the oral antibiotic, but it was for a longer period. So this time our diagnosis is the left orbital apex syndrome, status post sphenoethmoidal osteomyelitis. So after giving antibiotic and IVMP, the ptosis improved and the extraocular motility also slightly improved. We repeat the MRI this was the last MRI at the end of 9-month follow-up. So as you can see in the right side, the inflammation of the osteomyelitis has decreased. The orbital apex also it has improved. The motility and ptosis completely resolved, but unfortunately we could not save the vision of the child. It was still PLPR inaccurate. And the neurologist and the radiologist gave the report that there is some amount of osteomyelitis still persisting, but we can't resolve it completely. So if we can go through the timeline, it was a complete, it took 9 months to resolve the complete disorder of this child who presented with us as a case of rhabdomyosarcoma, and then we diagnosed it as a sphenoethmoidal osteomyelitis leading to orbital apex. But unfortunately, we could not find out what is the source of infection for this osteomyelitis, because the child has no lesion, no trauma, and maybe the child had a sinusitis before presenting to us. For that, she had fever or headache or vomiting, but they could not reveal it properly. Till now, the child is doing good. So after this 9 months of follow-up, vision is still PLPR accurate. There is no ptosis, and extraocular motilities are full and free in both the eyes. So in literature, we try to find out what could be the causes of orbital apex syndrome in pediatric age group, though it is not so common. But there is no literature about any skull-based osteomyelitis causing orbital apex in a child. There was a report about a 72-year-old male where the hematogenous root was the source of infection for a skull-based osteomyelitis. That is atypical variety. Here the sphenoethmoid is involved. That is called atypical skull-based osteomyelitis, because most of the time it is temporal bones to the otitis media that is typical. But this is a kind of atypical which can cause a orbital apex. And another case report of rhabdomyosarcoma in a 12-year-old girl, which caused orbital apex syndrome. In the histopathology, it was proven case of rhabdomyosarcoma. After doing proper management, the child recovered completely. So, but our child has the just opposite. It is not a rhabdomyosarcoma, it is a skull-based osteomyelitis. It is a 11-year-old girl presented with orbital apex. So, I just want to know whether anybody has this kind of experience. Sorry? Yeah, there was a necrosis. That is not. I could.
So it is very rare to have this kind of osteomyelitis, skull-based osteomyelitis in an immunocompetent child.
Yes.
It is extremely rare. So, in fact, it takes a long time for the diagnosis. You were very lucky to get a diagnosis. They say that you have to do repeated biopsies before you can get an organism to differentiate out, and they keep repeating it, thinking that it might be one of the cancers. Yes. So I'm wondering, why should an 11-year-old immunocompetent child have such an infection, even if it is sinusitis, to involve the skull base? It is usually associated with immunocompromised individuals.
Yeah, so all her blood investigations were normal except only ESR raised, because it was a COVID time, so everything was done. The child was completely normal for everything.
Maybe child had some latent COVID infection which could
That's
have reduced the immune status.
I think in this time, even if they are not immunocompromised, they can have this unusual infection. But what is very important is in children, when they have external ophthalmoplegia, it's not a typical IgG4 or Tolosa hunt. They will always have some kind of underlying infective or inflammatory etiology. That warrants a very, very deep investigative procedure for them before we start in IVMP. Otherwise, any external ophthalmoplegia, get a quick MRI, we can always start IVMP. That's what is there. But in them, we have to be very careful. But the imaging really helps. It's not a very usual swelling what we see. Combination of MRI and CT scan is much more useful in these cases, especially when the bone is involved. So sometimes, because of economic and the travel and the distance, it's difficult to advise both. Practically, we can sit here and say, but it's difficult to get both of them. Any other questions, suggestions from the panel or from the delegates? Okay.
Thank you,
Go
Dr.
ahead. Thank you.
Debasmita. Thank you, Dr. Debasmita. So now I'll call upon Dr. Faraz Hussain. He'll be speaking on visual loss after cataract surgery from endophthalmitis 269 to NAION.
Good afternoon all. Thank you POSN, the managing committee as well as the panelists for giving me the opportunity for presenting this. So this is a unique sequence that I came across. I wanted to present it. Vision loss after cataract surgery from endophthalmitis 269 and then non-arthritic ischemic optic neuropathy. So the incidence per se of severe vision loss reported to be less than 0.08% due to the complication of acute post-operative endophthalmitis. This is a very known data. The risk of NAIN, however, after cataract surgery, even a routine phacoemulsification is estimated to be 4 times greater than the normal population, and that is in the first year, usually occurring within the first 6 months. These are all documented studies with Epstein, McCulley presenting in 2007, 2016, huge number of case series. This rare sequence, however, is the possibility of the added insult of endophthalmitis being managed with a pars plana vitrectomy and then presenting with vision loss after. So my patient was a 53-year-old male, came for routine left eye cataract surgery, which pre-op vision was 6/24 NS2 grade. The only systemic risk factors were hypertension and associated alcohol abuse. The routine phacoemulsification was done in the back, foldable IL-6 vision on day 3. However, the patient came with hand movements on the day 10th, and we operated the very next day with pars plana vitrectomy, 23 gauge, as well as the intravitreal antibiotics. PVD induction was not done. The routine and empirical treatment was given along with dexamethasone. So this was the first day presentation with the blood-stained membrane covering the whole pupil, which improved within 1 month to 6/9, and as we can see, just a mild peaking of the pupil. Rest the patient had a normal fundus, good vision, and the patient was quite happy. Sadly, patient 4 months later again presented with acute vision loss, patient presenting to us within 1 week of noticing the symptoms in the same eye and now having finger counting 4 meters only. No associated pain, watering, redness, or no associated other acute events. So this was the disc photograph as well as the, just for documentation, the right eye optic disc is almost near normal. The left eye, however, shows the pallor which is nasal more than temporal. The only remaining pink neuroretinal rim was inferotemporally. The size was normal, CDR was normal, neuroretinal rim was normal. There was no RNFL even on green filter testing. Even on OCT, we documented that. However, the atypical finding apart from that was the yellowish white speculated dots seen in the foveal area. We did a visual field analysis. It was not giving reliability indices because of poor fixation. So we extensively investigated along with a team approach. We involved the neurologist, the physician. Our provisional diagnosis was a non-arthritic ischemic optic neuropathy following pars plana vitrectomy in a case of acute endophthalmitis 4 months later. The right eye was still the same. There was no other associated illness except the hypertension, which was documented to be under control, and the alcohol addiction. The patient refused FFA. We did the MRI, the MRV along with the neurologist, even the MR angiogram. The vertebral artery being hypoplastic is almost a normal variation, so we did not really do anything about that. Empirically, we gave the whole IVMP sequence as advised by the neurologist. Possible differentials, a posterior ischemic optic neuropathy, again very, very rare and infiltrative one, but we did not really get why did he get these. The possible pathophysiology, suspect a compromise to the vascular supply of the optic nerve head with multiple stress of endophthalmitis, pars plana vitrectomy, alcohol abuse, possible irregular hypertension. Because the other known factors are the night, the hypotony systemic, which might lead to NAIN. So queries being any other possible reasons, and how could we have reduced this or possibly prevented the
One of the things could be, there is a hypothesis that induction of PVD or a PVD in a patient can cause NAION. There are
Exactly.
2-3 papers on that probably 5 to 6 years ago, especially from them. And some of the retinal surgeons at that time was advising vitrectomy for the treatment of NAION. So That's one of the thing, but reversing it to normal 6/6 is something unusual. I still think it's something inflammatory in retrospect.
That's exactly why I did not do a pars plana vitrectomy, PPV induction in this. But even then, 4 months later, which is the normal time period for the NMI.
For endophthalmitis, they will never induce PVD.
No, ma'am.
They will just go ahead and do core vitrectomy and come out.
No, there is a group of VR surgeons who do that, but I am not doing that. Especially in this patient, we had avoided that.
And he also has irregular hypertension. Okay, somebody having this variation, it can cause some kind of ischemia.
So
that's one of the possibilities.
It is 4 months later.
4 months later,
so,
yes.
it may not be related at all. The inflammatory peptides which would have been released would be reduced by 4 months. It would not be persisting after 4 months, right?
The only was that finding of the foveal exudates, that was a bit confusing. So I was not sure if that was maybe indicative of infiltrative one.
It could have been a simple NaION.
Just one point to highlight. The other eye, you said that the disc looked normal. What I want to say is that the photograph which you showed, it was not normal. It also had this temporal pallor, mild temporal pallor. And I don't know if the patient comes back to you, just do the good eye perimetry once and do a 10-2. And you might see some sort of central scotoma because you said that the patient was a chronic alcoholic. So what I feel that the optic nerve was already stressed.
Compromised.
Yet because of the inflammation, the vision went down. The vision came back to 6/9 because there might be some island of vision which was there, and due to further, I don't know what kind of stress the optic nerve had, it came back to 0. This is what I feel.
So the visual field we had done, of the other eye it came normal. So even the 10-2 we had documented.
I had a similar case, post-surgery, didn't have endophthalmitis, but the patient was hypertensive and irregular on taking antihypertensives. 4 months post-surgery, developed a PION with a pale disc. So everything was investigated, gave her IVMP. And the other eye cataract surgery, I did it after 3 years. Tried to delay the cataract surgery, and exactly 4 months after the other eye surgery, she again developed a PION. So this time, so it is also, there's an entity which is known as post-cataract sequential optic neuropathy. So some type of inflammatory mediations or these play a role. Though otherwise, second time we were very careful in controlling her hypertension, controlling her lipids, and every time the surgery was routine, but both the eyes, unfortunately, at the same time duration, she had a PION.
Yeah, I think what, hi Shailaja. So what I feel, this is an isolated event. It's not related to the
possibly,
the episode of the endophthalmitis. So I think most important thing is to look at the other eye, disc at risk. There are certain systemic risk factors, and we have seen many patients when they present with the acute severe form of NaION attack, they do have a subretinal fluid. So what hard exudate you are saying, that could be a part of NaION. And I think serum homocysteine also you need to.
We had done that. That came normal. We had done.
Treat it accordingly if it is high.
Thank you.
Thank you all. I'll just hand over the session to Dr. Pooja Lakhani. Thank you all.
I think this is the last session for today. 3 more cases to go. And then I think we have the dinner at 8 o'clock. Maybe further notice is awaited, I think. Yeah.
Yes, delicious Gujarati special dinner will be awaiting for all of you. So this is the last session of ocular genetics. Though we are least, bothering this in our clinical practice, it is a very good chance for us to discuss with our seniors and panelists of how to apply this in our clinical practice. I would invite our panelists, Dr. Vivek Wakat sir, Dr. Siddharth sir, and Sandra madam. Please join us on the stage. Without delay, I'll invite our first speaker, Dr. Sampradha Kulkarni madam. She's here. Yes, okay. She'll be talking on a rare case of cataract in a young child presenting with unique genetic disorder, cerebrotendinous xanthomatosis.
Okay, good evening all. So last session about ocular genetics, and this was a rare case which I had seen in OPD. This is a case about a 9-year-old male child presenting to our clinic with complaints of blurring of vision in both eyes from past 3 months. This child was referred by a school teacher because he was not able to see. Just post-COVID school started and child was not able to see. And they referred it as saying it is a posterior subcapsular cataract and need cataract surgery. So going back to his little bit of past medical history, there was no systemic history. The only positive family history was that the parent had second-degree parental consanguinity and he had other 2 siblings which were normal. So birth history, there was a history of neonatal jaundice and for which the child had received phototherapy. Looking at the general examination, when the child was entering inside the room, that time he had an ataxic gait. If you look at the child carefully in high magnification, there were freckles on the forehead as well as in the malar and nose area. There was a long philtrum, little bit of anteverted ears and thin hair which were golden in color all throughout his body. Looking at the complexion, the child was fairer compared to the family members which were very dark. So then we did cycloplegic refraction which was coming to be as compound myopic astigmatism. He had little bit of right head tilt but no squint was noted. On lens examination and slit lamp examination, rest of the findings were normal except that if you see carefully here, there were some flake-like opacities which were seen in the extreme mid-periphery which were visually significant. If you see in this retroillumination, it gives a granular opacity like picture and which was obstructing slight view but not very clearly. But because the child had compound myopic astigmatism, we decided to give the spectacles. Because the skin presentation was different, freckles, thin hair and developmental cataract with ataxia, we kept in mind that maybe some genetic association is also there and we decided to send the patient to a pediatrician as well as dermatologist and if possible get a genetic testing done. Luckily the child actually underwent whole exome sequencing and it came out positive for CTX which was an autosomal recessive disorder. So what is this? So basically this is a disorder which is a lipid storage disease which caused by mutation of CYP27A1 mutation. The usual presentation of this disorder is with the patients who present at the age of 30 to 40s with extrapyramidal symptoms and there will be a cataract. So retrospectively we see that there are xanthomas and all other things and usually the delay in diagnosis happened by 16 years but this was picked up at very young age and hence we got his bile acid analysis done which was suggestive of some of the changes. Usual clinical features which we see in these patients are neonatal jaundice, developmental cataract, chronic diarrhea in infancy, tendinous xanthomas which can be seen at the age of 10 to 15 years. Along with that, neurological, especially extrapyramidal symptoms like Parkinson's symptoms can be present in most of the patients. So when we went back and searched the literature, there are few cases which are diagnosed once the family members are diagnosed as CTX, especially based on their extrapyramidal symptoms, and then the siblings were diagnosed that they had little bit of cataract. So when we were going through the diagnosis criteria, there is a Mignari suspicion index, which actually comes out to be very useful for our patient also, where there was a strong score. Parental consanguinity was there, child had neonatal jaundice. Along with that, there was a ataxia or spastic paraplegia in the younger age group. So the bile acid synthesis was actually suggestive of high plasma cholesterol, and this child actually started a treatment which will be given as a conodeloxylic acid, but this is not available in India very easily. You have to procure the drug from US. So we consulted a metabolic disease specialist and we started him on cholic acid supplements, and the child started improving weight gain. His ataxic fetus improved. Till now, I mean 1 year follow-up, there are no evidence of any xanthomas in this patient. Visual acuity is stable, but the cataract has not regressed. It is still the same on clinical examination. So the take-home message is all juvenile cataracts, we should prompt through a complete diagnosis, and etiology need to be found out if it is not fitting into a clear classification. It is a progressive disorder, and developmental cataracts being the most common presentation. Early diagnosis is extremely important because medical treatment can prevent the further deterioration of neurological manifestations in this disorder. Thank you.
Yeah, I think that's very interesting and it's very rare presentation, isn't it? So
yes.
I think two things that we need to highlight when you see, similar case where the history of diarrhea and developmental delays that these patients do present. It's very, very important. So once you have this high index of suspicion, and then this is very typical, the morphological presentation. So usually these cataracts start with the flake-like opacities, and over a period of time they present as a posterior subcapsular cataract. Yes. Most interesting thing is this is the only some of the entities where when you put them on CDCA as a treatment, the cataract regress. So this is an opportunity, being an early presentation, to follow this patient on a treatment and see what happens to the opacity. Yeah. So I think 1 year is a very short time. Maybe down the line probably we might see that these flakes are going away. So there are anecdotal reports where like first time people have tried to look at what happens to this. Although CDCA is like, that is the standard therapy, where they have used over a period of 3 to 6 months, 2 to 3 times in a day. I don't know, I mean, just giving the cholic acid would help, or we have to add that particular therapy that would help to regress that.
So metabolic disease specialist is seeing the child, and his bile acid synthesis reports, whatever are coming, are actually in the normal limits. But recently we had seen the patient and the cataract is stable and vision is not improving beyond 20/50. So we were actually thinking to, plan cataract surgery. But
yeah, so ultimately, if there is no regression, then that's the way forward.
Yeah, but now he is planning to switch to CDA because he is enrolled in one of the fund for the rare disease dictionary. So he is able to procure the drug. So we'll wait for another 4 to 6 months and see how he is responding.
And what about the family? You said the father and the sibling are also screened, right?
Yes, so actually mother and father both were autosomally heterozygous positive for the gene, and even one of the sibling is also positive, but he doesn't have any symptoms, and his bile acid synthesis profile is done, that is normal. So that is also followed every 6 monthly.
So no cataracts in
No cataract in the siblings. As of now there is none.
How long do we give CDC in such patients? I mean, how long they need and how much it is safe? I mean, long term.
I think it's around like 125 milligram. That's what I could see in the literature. 125 milligram 2 to 3 times a day over a period of 3 to 6 months.
3 to 6 months.
Yes.
That's it. Then
So yeah. So that you can monitor by looking at how much is the cholesterol level.
Yes.
So that start decreasing, and that's the indication. I mean, the symptoms in terms of diarrhea and their developmental behavior, that keeps on improving. Even the growth retardation is also the problem in this condition. Yes. So that start improving. No, that's what cataract is very rare. Not every patient of this particular entity would have the cataract. It's one of the ocular manifestations.
Very nice. Thank you, Dr. Kulkarni, for sharing such a rare case. Now I'll invite Dr. Saubik to present a case report on achondrogenesis type 2 with congenital onset. Okay.
So I'll be presenting on behalf of my optometry colleague, Mr. Souvik. I'm Dr. Shreya. I'm a pediatric fellow at LVPI. So achondrogenesis type 2, it's an extremely rare genetic disorder, and it is characterized by metaphyseal dysplasia, and there are very few case reports because it is usually fatal in the first year of life. With this background, let's go ahead with the case. We have an 11-year-old boy who was born at full term with uneventful birth history, presented to us with blurred vision in both eyes. On preliminary examination, he was noted to have short limbs and small chest. He was under care of a pediatrician and was taking calcium supplements, and there was also a significant history of surgery of lower limbs twice for some orthopedic issue. His presenting visual acuity was 20/125 and 20/100 in right eye and left eye. The refractive error was -10 and -10.5 at 4 years, which progressed to -12 and -13 over the next 5 years. Progressive axial length elongation was also noted. It was definitely high myopia to begin with, so whether it was an age-related progression or was it related to its characteristic phenotype is something we are not sure of. His anterior segment examination was within normal limits. He had a clear crystalline lens with normal anteroposterior diameter, and anterior vitreous space was also clear. So the clinical picture shows an 11-year-old boy who is short for age and has bowing of legs. His palate, hands and feet are within normal limits. Extraocular motility is full, and there was no dysmorphic facies that we could identify. There was no hearing loss, no cardiac abnormalities, no nyctalopia, no day blindness. The fundus showed mild peripapillary atrophy, and retinal thinning was seen in the peripapillary area. Detailed periphery examination was done, and no treatable lesions were seen. So because he underwent orthopedic surgery and presence of characteristic phenotype, he underwent a genetic test, and whole exome sequencing was done for the patient, which revealed a heterozygous missense mutation in exome 15 of COL2A1 gene. I would like you all to recall that this is the same gene which is usually involved in Stickler syndrome. However, segregation analysis done in both parents was negative. The patient was given a trial of contact lenses, and the best corrected visual acuity was 20/30 in both eyes. He is asked to follow up regularly for retina examination, and we have also planned an ERG for the child. He has recently undergone a third surgery for the fractures of lower limbs and is recovering from the same. So in this case, why was genetic test important? As it is a heterozygous mutation in the proband, the carrier status of the parents become important in order to plan their next pregnancy. Had they been carriers, the chance of next offspring getting affected would have been as high as 25%. However, as the parents are not carriers and it was a de novo mutation, the risk is lower in the next offspring, but never zero. So we chose this case to reiterate that COL2A1 mutation includes, but it's not limited to, Stickler syndrome. Stickler syndrome is a type 1 collagenopathy, and its ocular features of high myopia and vitreoretinopathies are well reported. There have been some studies in type 2 collagenopathies, but none seen in achondrogenesis type 2 in particular. Maybe it's probably because it's fatal in the first year of life. COL2A1 mutation encompasses a broad spectrum of collagenopathies, Stickler being the mild variant and the most severe being achondrogenesis type 2. Thank you. I would like to ask the panel if they have come across similar cases in their practice.
Many cases of Sticklers, but not this particular association.
So all the studies that were done in the past, they were all done in abortus, and they were more on the skeletal features of achondrogenesis. Nobody had really seen any ocular features. So this was something.
Because overall the lifespan is very less in
yes,
such.
Yes. He's 11-year-old. He's still functional. He's ambulatory at least. Thank you.
Nice presentation.
But
Any
what was
questions?
the cause for this myopia? It showed progression, right?
Yes. So what
I mean,
I
in
have
terms of I am asking axial length, or there was a peripheral hyperopic defocus.
So there was axial length elongation. Because this is a type 2 collagenopathy, what I came across the literature was type 2 collagen is seen in vitreous. So it is known that there are some vitreous changes which can also cause axial elongation. It's unlike sticklers. Sticklers like type 1 collagen is usually present in cornea and sclera in Stickler syndrome.
Yeah, so exactly that's what I wanted to point out. Like here, there is something going wrong in the vitreous.
Yes.
The vitreous milieu is being affected, which is still responsible for, axial length elongation and not primarily the sclera or scleral
Yes,
fibroblast.
yes.
So this is again, the rare variety with some atypical presentation. Otherwise, we have seen other types, as you said, like metacarpopharyngeal dysplasias presenting as a cataract. And most of these, the syndromes, they do have very short lifespan.
Yes.
I have seen 2 patients when I was a fellow, within 2 to 3 years after doing cataract surgery, that they succumb because of a number of other reasons and systemic problems. Nice, interesting case.
Thank you. Thank you.
Now I'll invite our last speaker of the day, Dr. Mayuri. She'll be showing us about a case report. I'm seeing double and having balancing trouble in a case of Miller-Fisher syndrome.
So I would like to thank Team PO Lesson for giving me this opportunity. We will see a case of Miller-Fisher syndrome in an 8-year-old male child who was born full-term normal delivery, first by order of birth, and was born out of non-consanguineous marriage, who presented in April 2023 with chief complaints of double vision, in which images were appreciated side by side with both eyes open since 1 week, difficulty in maintaining balance while walking since 1 week, with excessive sleepiness since 4 days. Patient had a past history of fever with upper respiratory tract infection 1 month back. There was no history of difficulty in breathing or swallowing. There was no history of bladder or bowel dysfunction. There was no history of excessive sweating. Family history was not significant. On general examination, patient appeared drowsy, though oriented to time, place, and person. His temperature was 96 degrees Fahrenheit with pulse of 90 beats per minute and respiratory rate of 16 per minute. His weight was 23 kgs with height of 126 centimeter. This is a picture in a primary position. The other gazes was not possible as the child had almost frozen bilateral eyeballs. So this picture shows us a mild left eye upper lid ptosis with bilateral internal ophthalmoplegia, semi-dilated, non-medicated, non-reacting pupil with a mild exotropia. The other picture shows a dilated fundus which shows normal disc and macula. So on ocular examination, patient had a distant unaided vision as noted on Snellen's 6.9 in right eye and 6.12 in left eye, which improved to 6.6 with -1 cylinder at 20 degree and with -1.5 cylinder at 150 degree. Near vision in both eye unaided was N36, which improved to N6 with near add of +3. Color vision in both eyes was normal. Anterior segment showed mild conjunctival congestion in both eyes. Pupils were semi-dilated, non-medicated, non-reacting to light, direct and consensual reflex, as well as near reflex was absent. Lens was normal. Dilated fundus examination was normal in both eyes. On squint examination, Hirschberg's reflex showed 10 degree of XT. Worth 4 dot test showed diplopia. Stereopsis on TNO showed gross stereopsis. Extraocular movements, ductions and versions in both eyes showed elevation deficit of -4 with depression deficit of -4, adduction deficit of -4.5 and abduction deficit of -3 with left eye mild upper lid ptosis. There was no lag of ophthalmos in both eyes. On alternate cover test, there was no refixation moment. So Krimsky test was performed, which measured 16 PD base in exotropia. Diplopia charting was possible in primary position, which showed crossed horizontal diplopia. Other cranial nerve involvement was looked, which showed bilateral facial weakness. On neurological examination, patient on tandem gait showed ataxia with finger nose test showing dysmetria. So a probable diagnosis of acute external ophthalmoplegia bilaterally with bilateral internal ophthalmoplegia and ataxia was made. So patient was advised for MRI brain plane plus contrast on urgent basis, which turned out to be normal, and patient was further referred to in-house pediatric neurologist who went ahead with further neurological examination showing truncal and proximal muscle weakness. Muscle tone was normal in all 4 limbs. Power was 3/5 in upper limb and lower limb. Deep tendon reflexes were normal. Plantars were flexors. Hughes score was 2, which indicated patient was able to walk for 5 minutes or more without assistance but was not able to run. So investigations, CBC was performed, which was normal. CSF analysis was done, which showed a protein of 140 milligram per DL with 6 mononuclear cells per millimeter cube, indicating albuminocytological dissociation. MRI brain, as said, was normal. Nerve conduction study was done, which turned out to be normal. So a probable diagnosis of Miller-Fisher syndrome was made. Patient from the ophthal point of view was prescribed bifocals with by making him aware that the near component of the glass would eventually wear off as the internal ophthalmoplegia will improve. Patient was admitted in pediatric ward and was started on IV immunoglobulin at 2 grams per kg over 4 days. Tablet gabapentin 100 milligram 1 BD for 5 days followed by 1 BD SOS. Syrup calcium, vitamin D3 5 ml BD for 1 month. Patient was followed up every fortnightly on discharge, which showed gradual improvement in diplopia, extraocular moments and ataxia. 1.5 month follow-up showed no diplopia, extraocular moments were completely full, there was no ataxia with recovering bilateral internal ophthalmoplegia. This is a 9-gaze picture on 1.5 month follow-up post-treatment, which shows improvement in the left eye upper lid ptosis as well as the exotropia, and all the extraocular moments were full. Thank you.
Thank you for your presentation. It was very nice. And this is one of the things that you may come across in your private practice. So if you are attached to any general hospital, you will usually get a call for this kind of a case where the patient will already be admitted in the ward. They will have this kind of external internal ophthalmoplegia. MRI will be normal, and the diagnostic sign is usually CSF. So they respond beautifully to IVMP, and there are very few differentials for us. Actually, it's more often.
Can I just, what is the definitive diagnostic test to diagnose Miller-Fisher? There's a very specific test for it.
Okay.
Anti-GQB
Anti-GQ1B.
That only confirms the diagnosis. This is just a presumptive diagnosis.
Hmm.
It could be anything. There are multiple antibodies you have to test. Actually, now the dictum is, even if you do not do a lumbar puncture, if you get an anti-GQB antibody positive, it is very sensitive and specific for the Miller-Fisher.
Yeah.
So neurologists, in fact, rely on that. So and this IVAG is very effective. So
yeah, I think I completely agree with her. That's a very important test. Nowadays, you know, if that is positive more than 30%, then you can label it, and usually these patients, as you have shown, that very good response to the treatment.
Usually the antibody results come quite late. So you are mostly dependent on CSF in such cases. because the lab turnaround time for these antibodies is 3 to 4 days.
Similar case. It was a young man who came to us after a bout of gastrointestinal disorder. I mean, he had something like a diarrhea. Even I wasn't suspecting this. He came to us with something like lateral rectus palsy. So then I thought probably he's, having a viral infection post-viral. But the next day he came back with total ophthalmoplegia. So, and then he said, I'm feeling wobbly, I can't walk. So I didn't know it. I didn't know that it was Miller Fisher, but I knew that he was getting some neurological problem. I sent to the neurologist. He immediately diagnosed. They must be doing this, seeing this every day. He immediately diagnosed it as Miller Fisher. And I said, why didn't you do a lumbar puncture? He said, it is invasive. If you want, I'll explain all the things to him. If he refuses, I won't do. And I started straight on IVIG. It's like magic.
Yeah.
He responded like magic. And it's not IVMP that you give, it's IVIG.
Yeah, IVIG.
And it responds. So that was like an eye-opener for me. And for the first time, I was also aware. So then we read about it. And we do see a lot of cases. So that patient didn't undergo, but yes, lumbar puncture and CSF study is required to rule out infectious causes. But in this case, since the anti-GQB antibody came out positive, he said it's very specific and sensitive. And patient did improve almost near for total recovery, but he had some diplopia for which I had to give him some prisms.
Okay.
So he's on prisms now. So that was some eye-opener for me. So I thought I'll share.
Yeah, I think the most close differential is OMG, right? So even if we think and try to exclude how it doesn't fit into the OMG, then these patients are very typical clinical presentations as a neurological manifestations. And they have that history of some sort of infection.
The key thing is ataxia. Ataxia. So diplopia with ataxia and total external ophthalmoplegia. Some pupils are sluggish also. So that is the thing of metavision.
I saw 2 patients in last 3 months, similar cases. One first patient was 8-year-old male with previous history of URTI. And initially he had only external ophthalmoplegia. Pupil was round and reactive, no RAPD. Vision was normal. Every fundus examination normal. So he was treated by neurologist with IVIMP first. Then he was not responding at all after 5 doses of IVIMP by the neurologist. And then they did that antibody test, and then they started on IVIG. And he responded well, but still he has a large esotropia of 40 prism diopter. The second case was from tribal area, 12-year-old girl.
Okay.
She presented 1 month after the complaining of squint and limitation of eye movement. We refer it to the neurologist, but somehow we lost to follow up. I don't know what happened to that girl.
Yeah, I think, the treatment decisions, they depend upon how much is the antibody levels. So if it is like, it can be as high as 300%, 500%. It is more than 30% is a diagnosis. But if it is very high, then, IVIG, or if it is in the lower range, then even steroid would do.
Regarding the residual squint portion, I have had one patient, 11-year-old boy, history of Miller-Fisher syndrome, completely recovered. Everything was fine, but the residual esotropia was around 30 prism, I guess. And that was 1 to 1.5 year post he recovered from everything. So after due talk with the new patient was not willing for surgery and prisms were not enough. So I gave Botox to the patient, because we generally are very cautious in such cases, but it was completely recovered, and with due discussion with neurologist and patient, I opted for Botox, and the patient is doing very well since 1.5 years, clear with everything.
This patient, extraocular motility is full now, but still he has a 30 prism.
Yeah.
Then Botox will work on that.
Yes, yes. In fact, Sandra ma'am will
But
be able to guide more on Botox than me, but this was the case I dealt myself. So
this patient I saw in July, mid-July. So
Otherwise, in cases of neurological cases, we don't think of Botox, but it was because completely recovered patient and considering all other situations, but it worked well. So, very nice presentation, thank you. So before concluding, let us have something practical about genetics. Ocular genetics is something I feel very dry, many of us has left, but because we are here, I would like to know from the seniors that where do we practically use it most in our practice? Like most commonly, I feel I get a question when we operate a case of pediatric cataract, and the parents are asking that when we are planning for a second kid, what do you think is the incidence of cataract in such patients, even in cases of high myopia or something? So where do we generally prefer using genetic testing in private practice or maybe even institutes?
So we are fortunate to have clinical geneticists in our area. So wherever we suspect a genetic disorder or genetic problem, we refer it to them, and then they do all the testing and they do all the counseling also. But we personally don't advise any genetic testing at our level. We refer it to the specialist.
So when there is some syndromic association, that's right, but just plain cataract and nothing else.
No, then I don't work up.
Then no point.
See, in private practice, the workup has to be minimum.
Even in even in institute, see for just autosomal dominant cataract familial history will be there. You can see that it is there. Then you're and unless you give a specific gene what you are suspecting, they have to screen the entire genome. It is very expensive, and you do not get a you cannot get a good diagnosis also. So unless you are very sure about what you are suspecting, then you can ask for a genetic testing. Better that they decide.
Yeah, so
If all the if the patient spends all his money is testing, he will have very little left to give you.
No, this is to be thought after we operate for cataract.
No, what?
Then we think of.
You know what I feel the most important step is, the proper pedigree as a part of history. The second most important thing is having the counselor, if not the geneticist. So I think these two things are very important. Otherwise, randomly asking for genetic tests, that create a lot of chaos in the parents and their family, right? So I think these two steps are very, very important to begin with. And then given the setup that you have, and then, the insurance and money is not the issue, then probably ideal case scenario, every cataract that we would do it. But that's not practical in this part of the
Those
world.
patients are mostly non-affording ones. I have two patients where the congenital cataract is in third generation. So they ideally should be tested, but they are just not affording and not ready to go anywhere.
I think Shailaja has something to add. Yeah.
I think one we should do probably as clinician is we should examine the siblings and parents. We should look for dysmorphic features, and we should look for the symptoms which are associated with cataracts, like diarrhea or a dysmorphic feature or a broad thumb. We should be a little bit more observant for cataracts. The 3-generation cataract probably doesn't need testing. Doesn't need testing. You need testing for people who have some preventable, or the one case which was where dietary modification may reverse some of the neurological things. Probably those are the cases where you should test it. Simple autosomal dominant cataract probably does not need testing, especially if you are in a resource scarce country like ours, where, as he rightly says, sometimes extensive testing and then patient says, I have no money for surgery, and goes off home. So you probably have to see, and it's very important to do a phenotype establishing first and then asking for a specific test, rather than just saying gene testing without any input for the geneticist. So if you don't do it, refer it like Siddharth is doing. I think they are better in looking at associations very quickly. They have softwares also to look for, okay, this. There are some softwares which will give you a clinical or a genetic diagnosis. But I think examination of the baby and parents and siblings is something which we all can do in the clinics, and we probably should ask for a little guided history about the conditions which we know are associated with cataract. I think that is something we should do rather
Because
than
that is what they really want to know, that what about the next, because there is a random, you know, one sibling is having and the second is not having. So what about if, you know.
yeah, but there are so many genes for cataract. It's not just one gene.
See, roughly, if you make a pedigree chart, you will know it is autosomal dominant or recessive. Accordingly, roughly you can tell. So those percentages you can give.
Turns out to be autosomal recessive,
then test it, yeah, because they are more
otherwise
likely to.
autosomal dominant, it's not required as such.
And I think in the syndromes like Marfan's and all, it's very important to recognize in any case of subluxation, I think we should do a very detailed workup and have a high degree of suspicion, because even if it comes out as Marfan's, there are many life-threatening situations associated with Marfan. So we should work closely with a cardiologist and others, because there are a lot of treatments now. They may be needing to be on medications which may reduce the aortic enlargement and such. So I think those are also very important.
So as ma'am has rightly pointed out here, that phenotyping is the first thing that you have to do. And many times the phenotype will tell you the genetic diagnosis. Like in Marfan syndrome, every time you don't need a genetic diagnosis. If you see a typical ectopia lentis, you examine the family, a 2D echo can just tell you whether it's a Marfan's or not. Okay, additional eye findings like cornea plana if you have along with it. So you know that it's FPN1 gene. So sometimes you don't need it. So clear-cut indications for a genetic testing would be, one, if it has a prenatal diagnostic indication, like for retinoblastoma patients. That would be much more important to do a genetic testing and know whether it's a de novo mutation or the mothers or parents are carriers or what kind of a thing it is. Okay. Apart from that, the second would be if there is a diagnostic dilemma, like some of the early onset retinal dystrophies. Here we really don't know, and the prognostication depends upon the type of genotype. Okay, so it's for a genotype-phenotype correlation and a prognostic indication. So these are the two most common which we do kind of in our clinics. Just establishing a diagnosis or just to know, like in autosomal dominant cataract, it's more of a research thing rather than, you know, giving any implication to the patient. Also, like in a cataract, which is a treatable disorder, generally again, what the parents will ask, even if you test, what will it achieve? If the next child is born with cataract, you don't ask them to, you know, discontinue that pregnancy. So again, the prenatal diagnosis doesn't help. So broadly, it is for prognostication of disorders where the phenotype is not very clear for you to prognosticate them, and for a prenatal testing. These were the two most common indications for genetic testing per se. Other third thing, as ma'am mentioned, if there's a syndrome, and again, syndromes, if you refer to the right kind of people, they might come with a diagnosis and do not require a genetic testing. But if it's gray zone and it comes back, for example, I'll give you an example. Patient was referred to us with a diagnosis of Holt-Oram syndrome. So that cardiologist had prepared an ASD, atrial septal defect, and there was a typical radioulnar, you know, dysplasia, which was difficulty in supination. And interestingly, Holt-Oram syndrome is associated with congenital cataracts and sometimes microcornea. Along with that, that child also had an anterior segment dysgenesis kind of a picture, which was quite rare. So I was like thinking, oh, maybe it's something new. So I thought, okay, maybe let's do it for a research sake, and did it. It actually came out to be a BCOR mutation. Now, when you go back and read, it is actually well reported in BCOR that you can have anterior segment dysgenesis or microcornea along with these radioulnar defects. So whichever specialty sees it, thinks of kind of their syndrome, and whichever. So our learning is also improving with these kind of genetic testing. What we really don't see usually, and either so. One thing would be, don't disregard these patients. I mean, don't say that, you know, it's a genetic thing, it's over there. Genetic tests have become much more cheaper nowadays, commonly available. Genetic counselors are also available with these genetic testing labs, so you can take their help, or you can appoint a genetic counselor, collaborate with them, and they are the ones who actually tell you what kind of test you have to order, but you have to give them the correct phenotype. Otherwise, if you don't give the correct phenotype, they might land up with a wrong kind of test also. So there are some things that I wanted to add. Thank you.
Very true. I mean, if you just write the phenotypes, the things that you see in the patient, just type them in a sequence on Google, and most of the times you get the diagnosis. So even at your level, you can make that phenotypic diagnosis, then send him for definitive testing if it is not clear, And sometimes the testing is very simple, like karyotyping, which is very cheap and very quickly available. So that you can do at your level also. But when you are ordering for the expensive ones like whole genome exome sequencing, and that you leave it to the geneticist
Actually, they're
probably.
not very expensive. I just wanted to tell you that genetic testing is not that expensive now. And I've just, got into this, so I have a little bit of experience. So I'm from Kerala. There, the patients are very educated, and they come and ask me, is my next child going to have this? Can we do some tests to find out, what sort of inheritance it is? So important thing is you don't do it alone. You involve a pediatrician. If you're suspecting a syndrome, please refer the patient to a pediatrician. Find out about the other systemic involvements, and also have a pediatric geneticist also with you. And you should know how to interpret the report, because sometimes you may find some gene with and the report would be unknown significance. It really doesn't have any significance. And it may be autosomal recessive, or you should know how to interpret. So interpretation is very important. So if we don't know, we should have an ocular or a pediatric geneticist to call up at least and ask, is this significant, so that I can transmit this information to the patient. Otherwise they may just get scared. So it's a teamwork. So sometimes the labs will have their own geneticists and counselors, or you can have a tie-up with a multi-speciality hospital in which there is a pediatrician and pediatric geneticist. So this whole exome and the whole thing comes, at least in Kerala, it's coming only to 13,000, 14,000. So it's not that expensive, and people are, it's like in Kerala where I work, people have already read about everything and they come to you. So if you cannot tell them, sometimes I don't order all the tests for all cataracts, but if there are some patients who ask me, I give them this option, that there is this option, you can do this. And for cataracts, I use my discretion. But for the other tests, for the retinal degeneration panel, I straight away tell them. And even those tests are only 13 to 14,000, which most patients, if you tell them in the right way, will afford and will do it. And what is the significance? As she's already said, Dr. Shailaja, it is for prognostication, and for find some rare diseases you may pick it up, but most of the time it's prognostication. And yes, it is going to be in vogue. So we cannot shy away from it, but we need to have a better understanding of how to interpret the tests and break the news to the patient. So you need to have a genetic counselor, or at least a geneticist in your kitty.
I just wanted to add to what has already been said, apart from a dilated examination of parents, which we can all do, dilated examinations, and a reverse phenotyping. We are all learning because we are reversely phenotyping what we are actually seeing. A variant of uncertain significance, if you have the access to resources and you're actually testing, kindly report them. Because ACMG guidelines keep changing. If it might be uncertain significance now, because we have a very less database of cataract genes from India, and if you have an uncertain significance mutation today, it might be significant because a lot of people are reporting it. So I think you should all report whatever, even variant of uncertain significance at ClinVar, and you get an accession number, and you can see maybe years later we all are reporting the same uncertain significance, and it turns out to be significant for our population. Yeah, thank you.
Yeah, I think that's a very valid point. That's how, a decade ago we had 37 genes known for cataract. Now they have become 56, isn't it? So I think those documentation of the uncertain significance is very, very important. As Shailaja said, probably the institute level, I think it should be doing more and more, even for autosomal dominant recessive cataracts for research purpose, so that we would add more number of genes. We never know that our population within the India, or even different part of the India, they do have different new gene which are not reported. That's how we can look at it.
Thank you so much everybody for being here. There is one important announcement. For those who are not staying tomorrow, those who are leaving today, the certificates are already available in the room beside. They can collect. For those who are staying tomorrow, you can collect tomorrow. Thank you.